first session will start with Dr. Monica. Dr. Monica is my colleague in Emirate Specialty Hospital. She is a consultant pediatrician and neonatologist, head of neonatal department. She is well known in UAE in the field of neonatology, and she was previously working in Zulaikha Hospital, and she was the head of neonatal pediatric department there. She has a lot of publication and a lot of studies on neonatal babies, and she has an interest in allergy and neonates. So please welcome Dr. Monica to the stage.
Thank you, Dr. Basil, for a kind introduction, and thank you for involving me in your great esteemed conference. My topic was different, and as what happened with Migdadi, same thing happened with me with Basil. When he told me to say allergy, and when I prepared the whole thing, he said, no, this is being overlapped, so please change. So this is not what you can see in the leaflet. The topic is different. And my disclaimer for the topic is, I am for breastfeeding. So, but the topic is infant formula and neonates, which one to choose. This is only in case we are not able to breastfeed our little ones. So our objective is, what is the main benefit of breastfeeding? All of us know, but still we need to re-emphasize ourselves. And if we need to choose some formula, which one to choose? What are the nutritional supplements of the infant which we are looking for? And if there is any difficulty in feeding, what do we do? So as we all know, WHO recommends 4 to 6 months, we should be exclusively breastfeeding. And even when we start weaning our babies, we need to continue breastfeeding up to at least 2 years. So what are the benefits of the breastfeeding? We all know the benefits are to the babies and to the mom also. So it contains antibodies, reduces infection risk, promotes healthy weight. So we are not looking into, when we say malnutrition, it is obesity is also a kind of a malnutrition. So healthy weight. And ideal nutrition, better brain development. So that's one thing which is given to the babies. For the moms also, we want to go back to our normal weight, so it helps us to go back to the lose weight. Faster evolution of uterus, lower risk of postpartum depression, and risk of the breast and the ovarian cancer. Pauses ovulation, so it acts natural contraception and economical. So I would say it's a liquid gold. It is nurture and it's nutrition, and the whole thing which it is containing is oligosaccharides, nucleotides, growth factors, lactoferrin, lysozymes, probiotics, prebiotics, LP-PUFA, etc. So the breastfeeding is the best, and always try to use it. How many infants in UAE do you think are breastfed? Any idea? Yeah? 60? Aha. So we are really very, very positive approach, but you see, UNICEF 2009, where do we stay here? Between actually 20 to 40, and some parts are less than 20. So even if you look at 194 countries, they saw that only 23 were exclusively breastfeed. 23 countries exclusively breastfeeding were still, only those were rates above 60%. Rest, all the countries were below 60%. And actually, when you talk about improving the things, the government has to step in. And the Sharjah is going forward to it when they're asking you to be having a BFHI model in your hospital. So we should know all the baby-friendly, the salts should be there in the hospital. I won't go to all of these, but there are segments where critical management procedures are there, where you need to comply on the codes of the breastfeeding. You should have a written documents to say what are you going to do, communicate to the staff and the parents. Ongoing monitoring and the data management is very important. And then ensure that the staff has sufficient training and knowledge about the breastfeeding support. And then we have to start the breastfeeding thing to the moms antenatally. So we have to start talking to the pregnant moms. And once the baby is born, we have to do skin-to-skin contact so that, they start the breastfeeding at the earliest. And support the moms who have problems. Don't give anything which is not breastfeed. And rooming in should be there 24 hours. So I am really against the nurseries in the hospital. And 14 years in Zuleika, I was successful not to have a nursery in the hospital. Here, unfortunately, it's not there. I will try. And support the moms to recognize and respond to their infants' cues for feeding. Counsel moms on the use risk of the feeding bottles and even the pacifiers. So this is important. And discharge, you have to really coordinate and give an ongoing support, so it should not lose when they go home. So my 1,000 dirham question for you guys is, name one advantage of cow's milk over the human milk. Is there any? No. And is breast milk the same everywhere? Yes, it's same. It's like, the mom's milk is same everywhere. And so that's one which is important for that particular baby. So if you allow the camel nose to go in, ultimately you're going to be shivering in cold. So don't allow the bottles inside to make our babies go into thing. And historically, we were talking about the vet nurses. So when we don't have the breast milk, we have the options. There are some cultural issues on that. So which among the following is contraindicated in breastfeeding? Galactosemia, TB, smoking, radioactive isotopes, chemotherapeutic drugs, drug abuse, herpes simplex on breast, HIV? All. And in this, what is the contraindication? Hepatitis B, C, moms who are febrile, moms who have low environmental chemical agents, CMV, or drinking? None. So even drinking, sometimes the moms will come and ask you, can I drink? So yeah, they can, and after 2 hours, they should be feeding the baby. So what are the alternatives? Role of the breast milk expressions, when should we look for it? Measures to support lactation, includes teaching the moms to how to express and handle, and especially when you have preemies, we have small babies who cannot suck, primey babies, moms who are working, and later on they need to store their milk. And if you start in the first hour, it is going to increase the mom's output. And it stimulates, and emptying is very important to help the baby to latch. And it also brings parent attention to adequate support to avoid dehydration and risk of hypernatremia or jaundice. So this is the role of the breast milk expression, and you should have all these in your hospital. Factors that determine the feeding choice in the 21st centuries is knowledge, demographics, and our professional support. So when do we need to give the baby formula feed? So sometimes you need to give baby formula feed when it is a transient state, when you know that the baby is going into hypoglycemia, dehydration, hypernatremia, jaundice requiring exchange, or some conditions where you have to keep giving the formula feed because of the, when you cannot give the breastfeed. And some parents here, you will see that they would not like to do whatever you try. So those also you need to give a formula. So when you are teaching a baby, parents how to give a formula feed, you also need to tell how to give it. So if you're giving it transiently, tell them not to use the bottle, try to use the cup or the syringe or the Paladay, so that they can go back to the breastfeeding. And also you should tell them how to sterilize, because we don't want the babies to get infections. Constitution of the formula feed should be like you boil the water, and then for 15 minutes you make it to get cold, and then you should be putting the powder, and then give it when it is of a temperature which is optimal for the feeding. Now you will see all this in the market, multiple different kinds of boxes. So different brands have many similarities but differ substantially in quality and support, so we should know. And composition of the formula may change over a time, which we will see. Every time they will come up, doctor, we have added this, doctor, we have added this, because we are trying to go as close to the breast milk. So we have different options. So why cow's milk? There are too many cows, and we have got lots of milk. I think that's the reason we are going for the cow's milk. What about the goat milk? It is there, but it is expensive and it's less. Then we have rice milk and a soya milk. We'll talk about each and every formula. So when we talk about a term formula, usually the protein source is humanized as close to breast milk, but the difference is that it differs with the higher protein content and the quality is not the same. Vegetable fat is the one which is used and not the butter which is in the mom's milk, and the carbohydrate is lactose, which is also different. We all the formula milk term are iron fortified, and the vegetable oil which is used is either soya, palm, coconut, sunflower, safflower. So you will get different formulas who are using different kind of oil. And then there are additives like iron, vitamins, nucleotides, LP-PUFA, MCT versus LCT, pre and probiotics, and again, I will also not say HMO, MOs because they are not human oligosaccharides. So this table will keep adding as we are talking about different formula. So breast milk has, all of us know, way more than casein, lactose, and the fat is butter. When we talk about the standard term formula, it is humanized, but still the casein is more than the whey. There is a lactose, which is different from the mom's milk, and the fat is vegetable. So types of infant formula, so there is a stage 1 and the stage 2 and the stage 3. So stage 1 is typically whey predominant, where 60% is whey and the 40% is casein. Protein content is 1.3 to 1.4 gram per 100 ml. Vitamins and iron are supplemented. And all these are added, and some of them don't have MOs, but they say they have other oligosaccharides, so prebiotics should be there. And 67 calories per 100 ml is usually the standard. Sometimes you get hungry babies, and then there is a formula for the hungry baby. So what they do in that is that they reverse the whey casein ratio to 80%, because the casein makes it thicker, curds, and make the stomach to empty late. So that's why they will be helping. And what is the difference in the stage 1 and stage 2? In the stage 2, they have little more protein. It's casein predominant, and the sugar content is higher, which is non-lactose sugar. So I sometimes consider, continuing the stage 1 only because of these factors. Then you come across lactose intolerance, and then you say milk allergy, and different kind of things. Are they both same or they are different? So when you talk about intolerance, so you get a baby who is colic, who is irritable, fussiness, gas, distension, spitting, abdominal stools. So functional gastrointestinal disorder it is. These are related to the macronutrients, either the protein, the carbohydrates, or the fat, and they are non-immunologic. So it's not the IgE-mediated issue. So what do we do in that? We try to normalize the feeding. Trial of cow's milk elimination is done in these babies, and if it's exclusively breastfed in the mom's diet. And sometimes unrelated to formula, so you should look at the temperature, noise level in the house, light, personality, and sometimes when you keep doing something, change the doctor. That's what happens. Then comes the lactose-free formula. So lactose-free formulas, they have polykosed maltodextrin, corn syrup, cornstarch, and sucrose instead of the lactose. So how do the different standard lactose-free formula, they again have casein more than the whey, they are lactose-free, and they have vegetables. So usually most of them are not zero lactose, they have a little bit of the lactose in them. So when do we say, and when do we need it? So there is a lactose intolerance which will happen, which means that there is an inability of the small intestine to produce enzyme lactase. And lactase deficiency actually is very rare. Sometimes there is an infection, and in post-infection lactase deficiency may be present. And then there may be a developmental lactose deficiency, hypolactasia. Fermentation of undigested lactose in the colon can happen. And then there may be distension, diarrhea, diaper rash, which will give you a clue that this is babies into a lactose intolerance. So in those babies, you can try soya-based formula or low lactose or a lactose-free formula. How many of you are asking the moms to give lactose-free milk in diarrheas? Yeah. So we are not routinely, we should not be doing that. Only if it is really going beyond a particular days, then is the only time. So don't go and give lactose-free milk to the all the babies with diarrhea. So we have different brands, and also these lactose-free milk are not zero lactose. So we cannot give to babies who have galactosemia because they still have lactose. And usually we should give it for a short term. So whenever we are giving, prescribing this milk, we should give for a shorter while and then switch back to, as yesterday Nitin said, switch back to the previous one. So that's what we should be doing. And then the soya formulas. So the soya formula will be, of course, the difference would be that it has a soya protein, and again it is lactose free, and the fat is vegetable oil. So again, we have two different soya formulas. There's protein base is soya, lactose free, and AAP says if you have a cow's milk protein allergy, it can be used, but it's a safe substitute, but cannot be like 100% taking care of the cow's milk allergy. But if it is just, if you want to give someone cow's milk formula or you give soya formula, it's the same, and usually given for more than 6 months of age. The concerns about the soya milk is that it has a phytate. So because of this phytate, what happens is that the absorption of iron, zinc, and calcium is reduced. And what they do, the companies, they add actually extra so that the availability becomes higher. There is an issue with bone mineralization, which they are trying to compensate by increasing it. And then there is a phytoestrogens, and they have looked into the babies who are given this soya milk, that the phytoestrogen levels are higher in the babies. However, the American Academy of Pediatrics says that there is no effect of this on the growth and the pubertal development of the babies. And then there is another issue about the aluminum toxicity, which because a little bit of content is higher. And especially if you're giving to our prematures and IUGR babies, there may be an issue of osteopenia to these babies. So and if you say that, I want to switch the baby to soya milk just because the baby is colic, so that's not significant benefit, and that should not be done. And the indications are that if you have a term infant with galactosemia or a lactase deficiency, because here is the one which will have zero lactose, and if the parents are seeking for a vegetarian-based diet, they don't want cow's milk at all, that's the time. And sometimes for some IgE-mediated cow's milk allergy, because the other one cross each other, so that one you cannot replace. However, there are few contraindications, especially for our preemies. We cannot give this because of the bone mineralization issue. And if any baby who is having a cow milk protein enteropathy or enterocolitis, you cannot say, okay, switch to the soya milk, because they will have the same bad effect. And most previously well infant with acute gastroenteritis should also not be given. And again, as I said, it is not for the prevention of colic or allergy. Then we come up with the hydrolyzed protein formula. So what are they? They're different in the market, and so we should know each one of them what they really mean. So hydrolyzed means they are hydrolyzing the cow's protein. They are again lactose free, and they have a vegetable oil. So hydrolyzed formulas are many. So you can see the way that it hydrolyzed, it is protein, partially hydrolyzed, extensively hydrolyzed, and then you get amino acids formula, which are single amino acids. So it helps in allergenicity, helps the babies who don't have, who have problem with the tolerance, and the problem comes with the palatability. And the biggest issue is about the cost, because the more and more you are going to hydrolyze it, more costlier it becomes. So you should know which one to really give. And partially hydrolyzed formulas, when we say, if someone is really allergic, you cannot give a partially hydrolyzed formula because it's not hypoallergic, not appropriate for the cow's milk protein allergies. It generally contains hydrolyzed whey, but the benefits are induction of tolerance and prevention of atopic dermatitis, which he was talking about yesterday. So it may be used, especially if the baby is little colic, irritable, and there is a distension, constipation, or reflux. So it is hypoallergic milk, HA, is also not completely hydrolyzed. So it is also similar to above partially hydrolyzed, exclusively whey or casein based, with some reduction in lactose. So no clear evidence that it reduces allergy. So if really there is an allergy, HA or partially hydrolyzed formulas will not help our babies. Then is the extensively hydrolyzed formulas. So these are the formulas when you really talk about CMPA allergy or soya milk protein allergy. Then that is the time when you will go for these extensively hydrolyzed formula. But as you will actually hydrolyze it, the palatability becomes a problem, and moms will come that baby is not liking it, and it becomes more costlier, and the osmolarity becomes an issue. So there are different brands which are available. Some of them actually increase MCT oil, and they may be used for the diseases like if you have a baby with a hepatobiliary disease, pancreatic disease, intestinal or lymphatic problems. Then comes the free amino acid formulas that absolutely when you have single. So you will have single amino acids. They are also lactose free, and they have vegetables as a thing. So free amino acid formula, you know the Nucate and Alcare, they have a different MCTs. Nucate has 5% and Alcare has 30% MCT. These are absolutely hypoallergic, but you have to be very careful when you want to really give this to your babies, when you have extreme protein hypersensitivity, severe malabsorption disorder, especially when you have a surgical babies and you have short bowel syndromes. Those are the babies where you will be giving. It's not for the prevention. It's not a first primary line in CMPA. Disadvantage again is cost. I think it is around 200 dirhams now. And palatability, osmolality, and these are the brands which are available. So we should know which one to give. And then comes another alternative to our cow's milk protein allergy, and we are hearing about the rice-based formulas where proteins are hydrolyzed rice proteins, and these are actually free from the rice starch. Lipids are again vegetable oils. Carbohydrates are free from lactose and sucrose, and they are all enriched with the zinc and things to reduce the diarrhea. They are enriched with lysine and tryptophan. So the only hydrolyzed rice protein based formulas are here, I think, is the Blemil. We don't have the others. And the AAP also says that you can think of giving rice based formula if you have CMPA. And this is Espagan, which said, yeah, it can be. And then there was a study which showed that the infant studied with the rice proteins, they didn't have any kind of side effects, and it is quite safe. So then comes the goat's milk. So I think you must be having lots of moms coming up and saying goat's milk is the good. So what do you say? Yeah. So the goat milk has an issue about, one is if you have a cow's milk protein allergy, it is also cross-allergic. And sometimes when you have severe allergy, and as he said, they may come with anaphylactic reaction if it is given because it's cross-reacting. And so not recommended in cow's milk allergy. Another issue is that it causes intestinal irritation, blood in the stool, and anemia. So please, you have to educate. We are coming lots of moms giving Caprita and other goat's milk because they think it's more closer to the mom's milk. It's the same protein as the cow's milk. Then sometimes we have special diseases with the specific formulas. So we might have GERD, constipation, colic, comfort formulas, then some metabolic disorders, organ dysfunction. So GR formulas, that is the anti-reflux formulas when you get, what happens in them is they thicken the thing like cornstarch or the gum is added, and they are to be prepared in the lukewarm water. Why? Because if we don't do that, then the thickening may happen before the feeding. So the main purpose is that it thickens the stomach, so what will happen is it will not go back. But actually speaking, if you look at the evidence, none of the things actually helps in reflux. So even these thickened formulas, they are not proven to be effective, but yes, they are available. And then there are some constipation formulas. So what's in that? So anti-constipation, it's an altered formulation of fatty acid position, altered calcium content, added magnesium, and it has a high lactose. So that's how it acts. Then the comfort formulas, how does it act? So we don't know what's causing discomfort. Discomfort can be with the protein, with the carbohydrate, with the fat. And so we all know that it's not a human protein, so it's something which is not human. And it increases the antigenic load. Gut barrier maturation may be a problem. And increased permeability may be issue, especially if you have a preterm babies. So what does this comfort formula do? So what they want is that they should reduce the colic and the constipation. So what they do is that they partially hydrolyze the proteins, they decrease the lactose in their thing, and they modify the fat blend palmitic acid. So that's how the comfort formula is given. And then if you have a baby who's having galactosemia, so don't go for lactose-free formula simple, because here the baby cannot metabolize galactose at all. So we should have a lactose and galactose-free diet. So usually they are given soya-based formula isomil, which is fully lactose-free, zero lactose thing should be there. And these milks, especially the lactose-free, they are not for the galactosemia. So modified formulas will be modified according to what you need, and you have to look at that. Usually all of them are lactose-free and have a vegetable source. Then you may have babies who are with the organ dysfunction. Then if you have a baby with a renal disease, then they will have another thing with the goat milk was that the mineral content is very high in that, and especially the renal load is there too much, especially in the first few days. And if you have a renal disease, now you have a low renal solute load is required, so you should have low potassium, calcium, phosphate, chloride, and these are the brands which are available. And if you have a maple syrup disease, then use a formula free of leucine and isoleucine and valine. That's what we will look for. If we have a baby with phenylketonuria, use phenylalanine free formula. And if we have lymphatic function disorders, then we use, especially if it is a chylous fistula, chylothorax, then we need a high MCT based formula, and that is monogen. And if we have hypercalcemic conditions like Williams syndrome, primary hyperparathyroidism, then we will look for a formula which is low in calcium, and so this is Calcilox XT. So we should know if it is a protein-free formula, there is no protein at all, lactose-free and vegetable. So we should just look at only these things when we are trying to prescribe a particular formula to a particular baby need. And if it is a carbohydrate free formula, then again protein is also modified, no carbohydrate, and the fat is vegetable. So there are other conditions when we come across, we have babies who are not gaining weight properly, and they need a high energy milk, so then we will look for a high energy milk. Short gut syndrome, extensively hydrolyzed formula with a high MCT or amino acid formula to be given to them. We have a preemie babies who are given preterm formula which is containing, like we said, for a term formula the calories are 67 calories per 100 ml. For a preterm babies it is 80 kilocalories per 100 ml, and the protein also goes higher, 2 gram per 100 ml, and there it was 1.3 gram per 100 ml. More calcium, more phosphorus, sodium and other supplements. And when we discharge these babies, that's why comes a name post-discharge formula. So we get confused. What is the difference? So the difference is that they don't require any more 80 calories, so they go down to 74, still higher than the term calories. The proteins are also higher than the term formula, but lower than the preterm milk. So it is 1.6 to 1.7 gram. Still they have needs calcium, phosphorus, iron, vitamin supplements, which is higher than the term formula. And we should be using these for the discharging our preemies, especially till 3 to 6 months, and we just follow them up, how they are growing, and if they are not going well, we can give that to up to 9 months or 1 year. So to summarize, still I would say take home is breast milk is a full option. It's a liquid gold. And time spent in promoting and supporting breastfeeding is well worth the effort. Let me tell you this, we should, as yesterday was telling, that we should be looking at not at the newborn, but we should look at what we are making them as an adult for our society. And there are situations necessitating formula feeds, we don't deny on that. And so we should know which is the safe formula, what should be used for which condition, and what are the special formulas which requires for those particular condition. Study your formula well. So I just want to highlight this because if we have a newborn, we should look into this, that how do we prevent allergies, because we are talking about the allergy. So if a baby is born, we have to see that can it be exclusively breastfed? Yes. Then exclusively breastfeed this baby up to 6 to 4 months. High risk of allergy being assessed. If you have assessed it, yes. Then if there is a family history, no. No family history, go for a standard formula if you need to give formula. If there is a family history of allergy, please go for the partially hydrolyzed from the beginning. And if you have not assessed the allergy, then start with partially hydrolyzed till you really fully assess the history. These are my references, and these are the old and new timer. My again thing is never compromise on quality. Thank you.
Thank you very much, Dr. Monica. Very nice talk. Very confusing talk too, not because of your talk, just because there are a lot of formulas on the market, and each one claims is the best formula. So thank you for giving us this insight about these different kind of formulas. I will open the session for questions, please. Yeah, Dr. Shohrab.
Dr. Monica, I had one slide. It's a term formula. I was waiting to see from where it has come. I didn't see. I'll add to that. In 1903, in America, there was a pediatrician neonatologist. He used to calculate formula for this feed, this much carbohydrate, this much fat, this much. Every day he used to change, and he was not telling anybody. This technique of formula of calculation, he termed it as formula for himself. This name has been, from 1903, has been, this Thomas More Roch is pioneer in that. Now, one question. Mother comes after adding number 2, number 3, say, my child is not taking. My child was taking number 1 well. Can we continue?
Yeah. That's what I said. So we can continue. The problem comes because it contains too much of a sugar, and that sometimes makes the issue and the taste, and also the protein. So the whey and the casein increases, so that also causes an issue with some of the babies. So we can continue. Yeah.
Dr. Nitin.
I just have a quick question about your last slide where you mentioned that for, I think if there's a family history of atopy, you start with partially hydrolyzed formula. I mean, what is atopic history? Hay fever, eczema, allergy? What kind of atopy will make you consider going for partially hydrolyzed formula?
No, because as you said yesterday also, that we don't know, we don't come to know like with what the baby had this. And so when we are talking about atopic history, we are talking about like eczema. So that's the thing which we are looking, not like just few rashes here and there, but when there is an eczema, severe eczema history, like how your baby yesterday was. So in that situation, that's the time when you are trying to start partially hydrolyzed.
Thank you.
I'm a pediatrician from Sharjah. My question is with regard to a problem I face in practice. We know that animal milk is not the ideal milk for babies, and we try to educate the parents. But a lot of parents coming from the Indian subcontinent, they and the previous generations are used to taking, say, cow's milk or buffalo milk from the age of 2, 3, and 4 months. And when we put this, the plus and minus points of animal milk and breast milk, they say that we all grew up on animal milk and we have no issues, so why should we change now? So what would be your answer for that?
Because this is a thing, and that's why my first slide, the gold, liquid gold. And so we need to, that's why, actually, that's why I said that when we talk about BFHI, it starts from the antenatal period. You know, you have to train the mom's mind from that time. But I mean, if it's already late, then the only thing what we have to do, we have to sit more with them. We have to show them evidence where, when you are giving the breast milk, what is the benefit to the baby, and vice versa when we don't give the breast milk. And so we have to spend an extra time on them to change their mindset. Joe, I understand it's quite difficult, but it's not impossible, I would say.
Dr. Christos, please.
Thank you for the nice oversight of all the formulas available. I just want to little bit create a bit of debate. I know neonatologists in the UK and surgeons traditionally for short gut syndrome, they use amino acid based formula. But these babies, they come to us afterwards, after they discharge from NICU and they stay for many, many months. I just want to say there's no evidence for amino acid formula. Even the ESPAGAN guideline says if you have a lot of bowel distension, yes, probably use it. But I would just say that I always try, I don't know, my colleagues who are here, or to transition them to extensive hydrolyzed formula. And the reason is in the short gut patient syndrome, especially if there's no ultra short gut, is a intestinal adaptation. When the molecule is not broken down, the stimulation is better. Just this comment for this very particular cohort of patients.
Yeah.
Thank you, Dr. Christos. I just want to make a small comment, and then we close the first lecture. Looking at the table, Dr. Monica, that showed about the different kind of formulas, you can see that human milk has a lot of lactose. Normal formulas has a lot of lactose. Then after that, most of the specialized formulas, they are lactose-free.
Yeah.
And all the studies now showed that lactose is very important in formulas, even in specialized formulas. So when a child has a cow's milk allergy, it doesn't mean that you have to give him lactose-free formula. You need to search for hydrolyzed formula with lactose in it, because lactose promote good, healthy gut. This is a very important message. A lot of doctors, they choose lactose-free formulas in addition to hydrolyzed formula. Thank you very much.
That's very important, because and that's the reason I said even the lactose-free formula has some lactose, so don't go for except for galactosemia.
Thank you very much, Dr. Monica. It doesn't mean that you have to give him lactose-free formula. You need to search for hydrolyzed formula with lactose in it, because lactose promote good, healthy gut. This is a very important message. A lot of doctors, they choose lactose-free formulas in addition to hydrolyzed formula. Thank you very much.
That's very important, because and that's the reason I said even the lactose-free formula has some lactose, so don't go for except for galactosemia.
Thank you very much, Dr. Monica. And now we go to the second lecture. I'd just like to introduce Dr. Hanan Sharif. Dr. Hanan Sharif is a well-known consultant pediatrician at University of Sharjah, specialized in allergy. She has over 20 years experience in the field of allergy in the UK and the Middle East. She's part of our program since the last year, and now she's back again. Yesterday she ran a very, very nice workshop on eczema, and today she's going to talk to us about anaphylaxis. Thank you.
Well, good morning to you all, and I'd like to thank Basil for the invitation to be part of this exciting and wonderful conference. I slightly deviated from the topic to make it a little bit more interesting, and to share with you a study that I conducted at the end as well about anaphylaxis at school. I start off with this case that presented to me the other day in clinic. This was a 9-year-old boy with a peanut allergy. They recently moved from Canada. He was born in Toronto, and he was lucky enough to be enrolled in a study from birth. Mum describes his infancy period that he has consistently tummy pains, consistently having allergic rhinitis or runny nose and watery eyes, but they never could think of what was the cause at the beginning of that. He was wheezy and later on developed asthma, and he was on prevention medicine. As part of the study, he had a skin prick test at 3 years of age. They found that he was sensitized to peanut, and the advice was given to avoid nuts at that point. Later on, as was rechecked at 2 years later, the peanut allergy was confirmed by a food challenge, and he was told to avoid nuts and was given EpiPen. So her concern when she came to my clinic was she wanted a new supply of EpiPens. She expressed the concern that the school nurse did not know how to use an EpiPen and wasn't sure what to do with it. She also asked for a management plan for him. And she was really struggling to find a school with a nut-free zone because the school he was in does not encourage nut-free zones, and she was having problems with her child going to this school. Luckily enough, I knew some of the schools who did have a nut-free zone in my community, and I referred her to that, and she was very happy with that. So in spite of our research food allergy, we are still at the point of the management will be avoidance, provision of a management action plan, and making sure that they are equipped with medication in case they need, in case of an accidental ingestion. And the worry of these parents is, of course, at school. So just to highlight what are the common allergens, I'm sure you're all aware of them, but just to also highlight that we do grow out of some of them. Some of them we develop later on in life, and some of them are long life, they stay with people. So I'd like to talk about the anaphylaxis at school in 3 main parts. So I divided it into what's expected from the physician or the pediatrician, what is expected from the school staff, and what is the parent's dilemma if they had a child that goes to school carrying an EpiPen. Just highlighting how to make a diagnosis of anaphylaxis, where variable manifestations, it can be difficult at some point. But the first picture here I'm showing is, I don't know if I've got a pointer, but yeah, so I'm showing the first picture here, and this is the how to make a diagnosis of anaphylaxis, and this is the consensus in the white paper. So if you have a skin reaction, being either skin or mucous membrane, plus sudden respiratory distress or sudden cardiorespiratory hypertension, then you make a diagnosis of anaphylaxis. Or number 2, if you have any of those 4 elements, 2 of those 4 elements together. So it's either skin, breathing problems, hypotension, or GIT, vomiting and diarrhea. The third one is if you have just hypertension on its own. But more recently, they've divided phenotypes for anaphylaxis, and that's the second picture here. And the phenotypes of anaphylaxis, the first one is what we know is the type 1 IgE, hypersensitivity reaction. The second one is a cytokine release, so it depends on what are the mediators released. The third one is a mix, so it's a combination of the first 2. And the last one is only complement activation. And just bear in mind that in all of those phenotypes that they've recently identified, they all receive the same treatment, which is adrenaline. So a pediatric role or a pediatrician is a constructive strategy, and support is needed. So he needs to make a diagnosis, and he needs to confirm this diagnosis, making sure that they are able to avoid this allergen, provide the patients or the parents with an adrenaline auto-injector, and showing them, of course, how to use it, which is very important. You need to have a dummy in your office if you do prescribe an EpiPen, and you need to make sure that either you or your nurses are aware of how to teach the parent. And then you need to provide them with a personalized emergency action plan. Advice to the parents and the health caregivers that if they do have anaphylaxis, what to do. Make sure that they have one of those leaflets just to remind them as well. And this is what an action plan looks like, and you can download them from any website. So is food allergy common in the UAE? Well, this is the only study that was done in the UAE regarding food allergy by Sulaiman Al-Hamadi. I'm not sure if he's here today. But yeah, so he looked at food allergy prevalence in Al Ain in 2010. And the food allergy prevalence was 10%. Bear in mind, this was not a full diagnostic food allergy. There was no food challenge, but it was just a questionnaire and regarding the presence or absence of food allergy by the physician. We looked at anaphylaxis in the US. The prevalence is 1.6%. Even so, 60% of these individuals who have had anaphylaxis were not equipped with EpiPens. Similarly, in the Kuwait, they recently published a study looking at the prevalence in their population of children, and their prevalence of anaphylaxis was 4.2 in 1,000, and again, about 60% did not have an adrenaline or a written action plan, even though if they did have an adrenaline pen, about 40% did not use it. Recently in France, they published similar cases or similar. And they looked at their admissions in the emergency department. About 323 of those had clinically validated anaphylaxis, and about 45% of them had a severity criteria, but only 32 of those were prescribed epinephrine in the emergency department, and 17 of those received EpiPens when they were discharged. So in spite of all of these guidelines, we still failed to treat anaphylaxis appropriately as pediatricians or as physicians. And this was, I take you to a consensus that was published in 2014, and just to highlight what is the main management or treatment of anaphylaxis. And the first line of treatment of patients experiencing anaphylaxis is epinephrine. And we still see a lot of people coming in saying they've got a food allergy. What do you use? We have antihistamines. Most of those patients who have got severe anaphylaxis are still not being treated appropriately. A lot of them have got a full-blown anaphylaxis. They arrive to the emergency department, they're giving the adrenaline, they're given hydrocortisone, they stay overnight, they go home, and they say, what do you have at home? They only have antihistamine, and this is what they use. In the practice parameter that I've just showed you, it's a consensus that do not routinely administer antihistamines or corticosteroids instead of epinephrine. There is no substitute to epinephrine, and administration of antihistamine and corticosteroid should be an adjunct therapy. Aziz Sheikh looked at a Cochrane database systematic review of antihistamine and whether it was effective in treating anaphylaxis with and without shock, and they come up with a conclusion that there was no evidence that it had any effect. So how many devices are you going to use? You're going to use 2, or you're going to prescribe 2 devices. And why? Because there's a potential for misfiring the first one. There might be a need of a second one in severe attacks, or if they had a rebound for a biphasic type of anaphylaxis. If the child was obese, or if they were in a remote location and it takes them a while to get to a near hospital. And what is the dose? It's easy to remember if you remember the number 3. So if they are under 30 kilos, they receive the junior epinephrine or adrenaline. If they're above 30 kilos, they should receive the 300 microgram. So antihistamines are never a substitute for epinephrine in the treatment of anaphylaxis. Administration of epinephrine intramuscularly in the anterior lateral of the thigh is the initial treatment. I take you to the second point, which is what expectations from the school staff. Since anaphylaxis is unpredictable and rapid in onset and potentially life-threatening, I think it's very crucial that for school to be trained to know how to use epinephrine, adrenaline, and respond to any anaphylactic reactions that happen. Because there has been a report that about 25% of these do happen at school for the first time, and the patient doesn't know that they are allergic to this allergen. And in spite, it is students do die from it. These are some of the pictures I took over from the internet. And one death, I think, is too many for something that can be prevented with a simple measure. So we highlighted what are the common allergens of food. Other anaphylaxis can be seen from insect stings or latex or medication. We discussed that nearly 8% of them would have food allergy. 16 to 80% of school-age children who had food allergy had a reaction at school, and about 20 to 25% was their first time they had an anaphylaxis at school. We also know that delayed administration of epinephrine is associated with fatalities, and early use of epinephrine is associated with decreased risk of hospitalization. So what is expected from the school staff? Well, I think expected for them is, apart from knowing what is the manifestation of anaphylaxis, but also to know what is an emergency plan and do they have a policy at school, know where is the medication, where does it sit in the school, and be able to administer is very important, and make sure that their staff is being trained is also very important. And we also know that sometimes it can be difficult with the new phenotypes that are being published now, that it can be difficult to make a diagnosis of urticaria, of anaphylaxis, because there's a vast majority of manifestations to it. But not only knowing what is anaphylaxis, I think how to administer anaphylaxis. For this child, although he was in a nut zone, free zone school, and he had an EpiPen, but this teacher did not inject him, she injected her thumb. So training is very important, and subsequently this child died because he did not receive his adrenaline. There is a global shortage of adrenaline, and if you look at this picture here, about 65% of the world do not have the auto-injector. So the main two obstacles at schools will be the availability of the EpiPen and the accessibility of somebody who has been trained to use it. Well, the food allergy epinephrine bill found its way to Obama's desk, and he signed a contract saying that he is going to make it available for all schools, meaning that not just the child who has it, but every school should have an EpiPen in case that somebody does have an anaphylaxis for the first time, and he needs to be treated immediately. We are also seeing in the UAE a lot of concerns about nut-free schools, especially in Dubai. There's a lot of media about this, and it's in the newspapers as well. The last topic I would like to talk about is what is the parent's dilemma? Well, food is everywhere. So it's in social events, special events, sports day, Christmas fairs, summer fairs, birthday parties, cafeterias, holidays, field trips, science classes, you name it. So the parents are very worried when they send their children off to school if they have got any food allergies. Training the parents as well how to use the auto-injector is very important. Some of them think that they have to undress the child and then inject. They sometimes inject and pull the auto-injector straight out without counting to 10 and making sure that the medicine has gone through. So it's very important, and you keep on training them every time they come and take a new set of pens from you. So school for the parents is perceived as a danger zone of these parents of allergic children. There's a lot of time spent at school for the children, and finding the right school and directing them to the right school is very important. I'd lastly like to just share with you the study that we did in the UAE a few years ago. We looked at the management of threatening conditions in school in Sharjah. We collected data with a validated questionnaire from schools. We approached about 80 schools, but only 33 of them responded, filling in this questionnaire. And we asked them whether there was any anaphylaxis happening over the last year, and what was used, how was the treatment given, and how quickly was it given, and did they have a policy or not. But I'm just going to share with you a few points. So the epinephrine availability in the 33 schools, only 5 of them had the epinephrine available. They had 14 anaphylactic cases, and only 2 of them received a pen. There was 3 schools that had a school policy regarding nut allergy, and the male-female ratio was 11:3. So my summary is that school must be prepared to handle allergic reactions that require epinephrine. With early use of epinephrine, I mean, this has been quoted by other studies, is associated with decreased risk of hospitalization, and delayed administration is associated with fatalities. Ensuring the availability of epinephrine in the community becomes increasingly important, and its growing area of concern is the preparedness of these schools for both recognizing and treating anaphylaxis. Thank you.
Thank you very, very much, Dr. Hanan. Very interesting talk, really, and shocking statistics and data regarding epinephrine and the school availability of epinephrine and action plan in schools. So I will open for few more questions if anybody's interested. Dr. Hiba?
Thank you very much, Dr. Hanan. You've hit the nail really on a very, very soft spot. It's a real struggle for us as allergists, and I'm a parent of two children with nut allergy as well as an allergist. So it's a nightmare. As you said, our school is great, but the bus, taking them out, the younger one, you have to be with them everywhere. What did you eat? Where did you go? It's really denerving. It's really tough. So my suggestion is that we need to have a voice. We need to form an allergy community. I think this is a community problem. This is a public health issue. We need to raise awareness, and we need to try and go through the Department of Education to be able to address all schools, because it's very variable, as you said, between schools and even patients who, as you said, are allergic. Some of them, you train them and they still say, oh no, I'm not going to use it. I'll just take him to hospital. So it is a real struggle. And the other thing for the UAE, I think sesame seed is more of a problem than nut allergy. So we need to include also, I would suggest, sesame-free schools. So I don't know what you think about that.
Yes, I agree completely with you. Since I presented this talk a few months ago in our conference, and I was approached by the Ministry of Health because they had an incident in Sharjah regarding this, and I think they are looking into it. I know that Sharjah Health Ministry is looking into this strongly, and I think they are making a campaign. But if you'd like, I'll take your name as well, and we can add it. If anybody would like to join in, that would be great.
Definitely, yeah. Thank you.
Thank you.
Oh.
Dr. Hamad.
Thank you, Doctor, for this presentation. I just have one comment. It's not only the school that need more training. I'm a pediatric allergist, and I see this problem on a daily life. Most of the general pediatrician, when they prescribe EpiPen, sometimes they write one, most of the time, but if they write 2, they tell the parents that they need to keep one at home and one in the school. And as you mentioned, that we know that 20% of these allergic reaction can come as biphasic. So we need to emphasize on the point that everyone has to take 2 EpiPen all the time, not one for the school and one for the home. That's it.
Thank you.
I think the only problem is that the parents face that it's not covered by insurance. And when I first starting in the UAE, the price of the EpiPen was 500 plus. It's recently only reduced to 250. So it was a struggle to ask the parent to buy two. And I was happy that if they at least took one at school and one at home, at least something is there. But I do agree with you, yes, it is something that we do need to advise too. I don't want everybody to go home and think that, you know, if you see somebody with an allergy, EpiPen is the first thing that you need to prescribe. Please be aware that you do need to make sure that you confirm the diagnosis by testing. Maybe you need to do a food challenge, but it's not a matter of this child has got an anaphylaxis that we're going to give him an EpiPen. Please make sure that you do know that he is truly allergic before you prescribe it. But yes, I think that's...
Dr. Ahmed.
Okay. I think schools are not high-risk areas. What are more high-risk areas? Vaccination, clinics, private and government. If you do inspection to 100 private and government vaccination centers, you will not find epinephrine, or if you find, it will be expired. Thank you.
Thank you for the comment. Just it raises a very important point about EpiPen, and I'm sure Dr. Hanan agree with me. We have a shortage of EpiPen. We have only one company who provide EpiPen in the UAE. There are 3-4 companies in Europe and US. So if this company does not give enough supply, everyone is suffering. And parents get panicky. They come to our clinics. They say, I have EpiPen, it's expired, what should I do with it? So what we tell them, if you have an expired EpiPen, still use it. Expired EpiPen works. Maybe it's not 100% as efficient as the new EpiPen, but it still has some effect, and use it. Sir, I'll give one more question, please.
Thanks, Dr. Hanan, for your presentation. I share with you my experience at Sharjah, as you mentioned. For the last 3 years, by chance, I was giving presentation to nurses of private schools. So as my colleague mentioned, it was regarding vaccination. And I keep talking about how to manage anaphylaxis. I discovered all the private school, they don't have emergency kit while giving vaccinations. So I raised this issue at the level of Ministry of Health. So I started by myself training at the Ministry of Health building for all nurses at the governmental school and at the private, how to manage anaphylaxis, whatever the cause. Unfortunately, as Dr. Basil said, EpiPen is not available too much, but we have epinephrine 1 in 1,000 vial. So now it's mandatory at the level of governmental school. They cannot give vaccination without this emergency kit. Once they come to collect the vaccine from the clinic or preventive medicine, they took the emergency kit with them and they returned it back. And now they keep the adrenaline at the school, 1 in 1,000. And they have the algorithm printed and available in all the school. And we have around 19 schools now at Sharjah GCI accredited. And most of our health center also accredited. So it's a mandatory. So I think practice started, but still need, because vaccination there is very dangerous. Thank you.
Just recently, the CDC extended the expiry date. They had this EpiPen, they extended the expiry date. So even expiry can be used.
Yes, yes. Very good. Up to 3 months, yeah. Exactly. Thank you. Thank you very much. Thank you, Dr. Hanan. And we'll go to the second or third speaker, Dr. Christos. Dr. Christos is our consultant pediatric gastroenterologist from Al Jalila Children's Hospital. Dr. Christos, he has done his full training, pediatric and pediatric subspecialty in the UK. Before moving to Al Jalila, he was the head of Liverpool, Alderhay Liverpool Children's Hospital, which is one of the biggest hospitals in the UK. He's going to talk to us today about non-IgE mediated food allergy. Welcome, Dr. Christos.
Thank you very much for Basil for the invitation, for this nice meeting. I'm very happy to be among allergy colleagues and general pediatricians. So my talk today, I will focus on the non-IgE mediated food allergy, which we deal in our general practice. I mean, you had a lot of talks for allergy. It's going up, so allergies will be very busy for sure for a while, and we don't know the reason behind that, but it's going up. So you have seen this slide, I'm pretty sure. So I will focus mainly on the actual non-IG mediated disorders. We'll talk about FPIAS, which is not so common, but very important to identify. Allergic proctocolitis, very common. I'm pretty sure you have come across food protein enteropathy. And of course, we have the eosinophilic esophagitis, which as a gastroenterologist, we spend some time on this. And the actual pathophysiology is mainly food-induced, but the IO allergens play a role as well. But is not an IgE-mediated allergy. This has been confirmed now, and the consensus have been published. But we'll talk about this in the next few slides. So if you look, I know you had cosmic allergy protein talks yesterday, but it's something we come across as well, and sometimes we have to work together. If you look on the symptoms, so common. It could be reflux, it could be colic, especially in the young infants. So, of course, if you have failure to thrive, that's a red flag. So the symptoms can be overlapping. I like, particularly from the archives of childhood diseases, this education practice edition, which comes periodically. That's what's published 2 days ago. It comes from the Southampton allergy team. It's very easy to apply this on your history, which is always the most important. That's called the EATS method for food allergies diagnosis. It comes from the acronym EATS: exposure, allergen, timing, environment, reproducible symptoms, and the symptoms typical for an allergic reaction involving multiple organ systems. So have a look on the archives. I think it's very easy, even for the general pediatrician, even for us, to use this to make sure we catch in the history the important elements. So if you look now between just the basic difference between IG and non-IG food allergy, you will see on the left the non-IG mediated characteristics and the IG mediated characteristics. Usually it's a cow's milk, formula fed, could be breastfed also baby as well when the mother is consuming dairy products. Milk and soya are most common in the non-IG, but in the IG mediated you have a lot of foods. The symptoms occur about 1 to 24 hours later, so it's a late response, where in the IG mediated it's very quickly you have the symptoms. And the allergen is a regular part of the baby's diet. A lot of parents ask me, my baby was fine, what's happening at 4 or 5 months of age? Why is cow's milk protein allergy? It is not like the IgE is when it's a newly introduced. It can take time to manifest. And the symptoms may take to settle an exclusion diet normally 2 to 14 days. So I always say to the parents, have some patience, not after 2-3 days, because you haven't seen the response, you go change the other milk, and then 1 month they have changed 3-4 formulas. Of course, you can have multi-organ system involved, skin in both of the allergies, but in IG it's particularly obvious. You have urticaria or angioedema. You can have vomiting and reflux in both, and abdominal pain, and that becomes difficult to distinguish. But if you take the history of this, I think you will come to the diagnosis. Now, I like it particularly, I will pass quickly the cow's milk allergy, the IMAP guidelines we use in the UK a lot. That's a publication by Vender and Toll 2 years ago. It's available, it's free. So because you had a lot of slides, I will just pass quickly through that. You have to have, you start always with extensive hydrolyzed formula unless you have severe symptoms. It does work most of the cases before you jump to the amino acid formulas. That's my message from there. When an exclusively breastfed baby, the first line is to mom to exclude the dairy and make sure we think about the mother as well. She is prescribed vitamin D and calcium, and then you do at least a trial for 4 weeks. Minimum 2 weeks. Yeah, this have to say the parents, this is something you have to comply, and you have to be a little bit patient, unless there are red flag symptoms. And of course, ideally, according to the guideline, once you have a clear improvement, you have to do reintroduction. I know in real life that becomes difficult to convince the parents, but that's how the guidance works, just to make sure you have the diagnosis. Because sometimes it could be something coexisting, and this baby stays until 12 months or 18 months on a dairy-free diet, and this was not a diagnosis. Remember about the reintroduction. Now, in formula-fed babies, as I said, we start the extensive hydrolyzed formula. Again, 4 weeks, ideally 2 weeks minimum, and you do the reintroduction. Now, how long do you stay? The IMAP guidance say cow's milk-free diet 9 to 12 months, and then you apply the IMAP ladder, which I'm pretty sure you are familiar. It has become much more easier now. It used to be 12 steps. Now it's 6. And I will tell you to go to the website because there's very nice fact sheets for the parents, which are always printed in clinic. There are recipes there as well available, just to make the life of the parents easier. Dietetic support is ideal and is needed, but sometimes either for insurance or for need for repeat appointments, they don't come. At least this website gives a lot of information there. Now, if severe non-IG-mediated cow's milk protein allergy, of course, then we have diarrhea, vomiting, failure to thrive, then we go straight to amino acid formula. So I didn't spend much time because we had a lot of cow's milk protein allergy slides yesterday, but I spent some slides on this particular condition. It's called FPIAS, food protein-induced enterocolitis syndrome, and proctocolitis. There was a nice review article published a few months ago. It's all free on the annals of Nestlé, and the international consensus for FPIAS 2 years ago. Now, this is a very bizarre condition. It presents with a lot of toxic clinical picture. You see a child who's vomiting, he becomes pale, he becomes sweaty. He looks septic, actually. A lot of these kids have come about 10, 12, I remember. They ended up in general pediatrics, had a full septic screen, because actually the presentation is quite dramatic. The main is the vomiting. And this is the main criterion. There is a nice FPIAS foundation, which always tell the parents to have a look. There's a lot of support there. And now from this consensus I gave you, the main thing is, the main criteria is the vomiting. But there's some minor criteria as well. The obvious trigger, the usual trigger, again, cow's milk. But sometimes could be soy, proteins, even solid food. When it's solid food, it's more rice or oats. Now, the criteria, they're published on this consensus, which are again free of the internet. You have the vomiting within 1 to 4 hours after the ingestion of suspected food, without the classic IG-mediated allergic skin or respiratory syndrome. That's the main difference there. If you do skin prick test, IG test, nothing will come up. You have mainly the vomiting, but you need also to have 3 minor criteria. This could be a second episode or repeated vomiting. It could be extreme lethargy, diarrhea, hypotension, hypothermia. A lot of these kids have presented in the emergency department, have been treated as septic. And I don't blame the doctors there because it looks quite dramatic. You can have a chronic form of that, which looks a little bit more, not so dramatic, but the vomiting is again the mainstay of the diagnosis. In the severe presentation, again, you have quite a lot of morbidity. Now, the differential diagnosis comes quite broad. You can have in the chronic FPIAS, which is not so dramatic clinical picture. You can have you think it may be bad reflux, food protein-induced enteropathy. It could be eosinophilic aciduropathy, however, not so common. Hirschsprung's disease, it's severe because you can have also blood in the stool, or inborn errors for metabolism because of this vomiting and this toxic picture. Acute FPIAS can look also like anaphylaxis. Some kids have taken even adrenaline by some doctors who treated this condition. But if you look on the protocols, some guidelines, especially this consensus, when severe, even advising to have a dose of IV methylprednisolone. Now, I'm sorry about this slide. I don't know, some kind of not agreement with this PowerPoint edition. So the food protein-induced allergic proctocolitis, it starts the first few months of life. Usually breastfed babies, up to 60% if you look some studies. Cow's milk, soy, egg, and corn, but again, the cow's milk comes always first. So this is a healthy baby who is thriving. It doesn't have some symptoms. Parents are panicking, they're coming, or blood in the stool. Usually some streaks. Not usually too much. It takes Normal to moderate loose stools, intermediate blood streaks, takes several weeks to resolve, and most of cases outgrow by 1 year of age. Now, if it's severe, again, the first diagnosis has to be there. Make sure we don't have a volvulus, pseudosusception, necrotitis enterocolitis, if it's appropriate for the history. And Hirschsprung's disease, still we have to think as a blood in the stool and diarrhea. But when it's mild and moderate, you can have a bit of anal fissure as well, perianal dermatitis, and this is something to think. But this is, I would say, a benign condition in comparison with F-bias, which is quite dramatic, the clinical picture. Of course, for breastfed babies, the first thing you do, you make sure the mom takes out the dairy, and if persistence, you take the soy as well. Very rarely, if it still persists, you may take out for the mom the wheat and egg. Now, the formula of fed baby, you start with amino acid formula, with excess hydrolyte formula, and if it still continues, it's quite a lot, you may end up using amino acid formula. I tell to the parents, this usually doesn't cause anemia, and it's not something, but sometimes they come anxious after 2 weeks, the blood hasn't stopped, doctor, we'll have to do something, and then sort of you have to change to the amino acid formula, but usually no need. And again, skin prick tests, rash tests are negative, not needed. Now, there's a nice summary slide just to finish with this non-IG mediated food allergies. Severity scales published last week. It looks overall, you see the severity as you go mild, you have more vomiting, but the blood stool becomes more, and then the weight gain is affected. And as you can see, you can have even fever in the very severe. That's why these babies are treated like septic. And the tolerance, of course, more severe becomes to 0. You have increased neutrophils, platelets, CRP, LFTs, and of course, if you do endoscopy, which I don't recommend. However, I ended up scoping few of these children because we always worry if there's any very early onset IBD. But generally speaking, they don't need an endoscopy. The history should be enough to tell you the diagnosis. Right, so I finished with the proctocolitis and the F-bias, so I spent some time now on the eosinophilic GI disorders, which is our particular interest for gastroenterologists, but there are a lot of sections of the management which will have to cooperate with the allergy colleagues. The guideline was published by ESPGHAN about 5 years ago. It's been updated now and under development. The last vote of the working group was last Saturday in Slovenia. So I will tell you the latest, which is again not published. So eosinophilic GI disorders. Again, like the allergies, we know about this probably the last 25 years, starting from the first reports in the 90s, but we still have a lot to discover. The clinical presentation is basically infiltration of the GI tract with eosinophils. This allergy cell has a lot of functions, and still we haven't found out everything. Now, we don't have biological markers, unfortunately, for this disease, so the diagnosis here, it's a mass endoscopy and histology. It's a histological diagnosis. And apart from the esophagus, which we know it has to be above 15 eosinophils per high power field, there's no consensus at the moment about eosinophilic enteritis or eosinophilic colitis or gastritis. So there's still a debate there how many eosinophils per each part of the GI tract have to be there in order to be pathological. The treatment status depends on the involvement of the GI tract, and maintenance treatment, this is a new one, which is often necessary to avoid relapses. As I said, you can affect usually the esophagus, which is quite common, but also you can have the stomach, the small bowel, and the colitis, and the symptoms, they are particular for every GI part which is affected. Now, if you remember that slide I put at the beginning, just to make it a bit more complicated, you see the overlap of the symptoms between cow's milk protein, allergy, and non-IG, I'm talking, and the even eosinophilic esophagitis or eosinophilic GI gastroenteropathy, especially in the young ones. Now, you look at the study 15 years ago, and you see that's a classic pattern of the clinical course. You see the symptoms in the older kids. They are more food impaction and dysphagia because I'm talking about the eosinophilic esophagitis now, the infiltration of the eosinophils will cause this motility of the esophagus. So very often you have a food impaction or you have to drink a lot of water, especially with solid food like chicken or piece of steak or bread, which are the most notorious ones. And you look the results from the pediatric, European Retrospective Pediatric Eosinophilic Esophagitis Registry, the RetroP registry, which only published last week in JBGN, and you see actually the similar pattern again as you grow older. You have the bolus impaction and abdominal pain dysphagia more, which is actually the commonest symptoms. When you are younger, it becomes a bit more difficult. To be honest, I don't know, my colleagues here, when I scope a child, even if it looks normal, I take at least an upper or lower GI esophagus biopsy just to make sure I don't miss a diagnosis, especially if they are feeding difficulties or vomiting. Because you can't have normal endoscopic pictures and still have eosinophilic esophagitis histologically. Now, as I said, this debate is still going on. Ideally, eosinophils, they don't reside in the esophagus. They reside in the rest of the gut. That's why it becomes a difficulty to come to the consensus what is pathological. Especially the colon has a lot of them, and even the small bowel. So, but still, we don't have. How it looks like is on the staining, that's normal. You have a reflux esophagitis, which looks with a papillary length, which is prolonged, increased lymphocytes, and here you have the eosinophil, which looks like it's purple color. They like the eos, means in ancient Greek means the dawn, and that's the color of the sky, which brings that purple color, and that's why it's look like this. Now, if you look on this histology severity score, which is now developed and hopefully be validated in pediatrics, you have all these components, which they define the activity of the eosinophilic esophagitis. A big debate we have at the moment between the gastroenterologists, how many biopsies you do, the more the better. Now, the latest which comes, however, not with huge evidence, but it looks like if you do upper, middle, lower, middle, and upper level, 2 each, you will catch 99% the eosinophilic esophagitis. I think it's more than enough because at some point, some US studies, they were doing like 15 biopsies, which is a bit extreme. This is endoscopy image, how it looks. So you start like this furrowing. This can be look also in severe reflux like this, but then you see it gets worse. You have this furrowing, and eventually you have an esophagus which looks like a trachea. And this is an example of what happens if you don't treat. This is an initial presentation at the age of 7, a bit of furrowing there, no treatment, and then the dracularization and the rings of the esophagus, and quite, as you can see, easily to bleed after the biopsy, and 1 week of steroids, and then becomes much better. Now, pathophysiology, I will not spend too much time. I saw already the slide. It's mainly non-IG mediated food allergy, but also the aeroallergens play some role. That's why we have seasonal peaks on this disease. We know now it's a non-IG mediated allergy, but we have to be realistic. These kids, somehow, they develop over the course quite often atopy, they have coexistent atopy, and also they have even true IG-mediated reactions. They are quite prone to that. That's a study 15 years ago when the US studies will start coming up. There is a lot of atopy coexistence with eosinophilic esophagitis, and also you have even food-induced anaphylaxis. So I have seen kids who had at the beginning they started with just a classical eosinophilic esophagitis, but on the long run they developed true IG-mediated reactions. Again, environmental allergies is something which is now well known. You have seasonal peaks of the eosinophilic esophagitis, especially when the pollen is high, and it's logical because you inhale a lot of. When we eat, when we choke, we have a degree of aerophagia, so eventually the aeroallergens, they come in contact with the esophagus inevitably. Especially some toddlers, they have a lot of aerophagia. Now, talking a bit about the management and what's new, what is coming in the new asthma guideline, we used 5 years ago, the guideline said 2
a trial of PPIs for 8 weeks and then redo the endoscopy. How realistically was this in real life? Feasible was this in real life? Was difficult to rescope all these kids. But there was this notion of the PPI responsive esophageal eosinophilia, which thought to be an aftermath of gastroesophageal reflux. This is not the case anymore. If you have more than 15 eosinophils per higher paraffil, this is eosinophilic esophagitis, and the PPI now is a first line of treatment along with diet and topical steroids. We will come through that. And now we adopt in eosinophilic esophagitis the same kind of strategy like we do in inflammatory bowel disease, the treat to target. We have to reduce the inflammation, improve symptoms, stop fibrotic progression, because as you can see, if you don't treat, you end up with a stricture. You need balloon dilatations. That's quite debilitated. And in the long run, we don't have yet long-term data. We don't know if eosinophilic esophagitis will be related with adult, usually onset of Barrett's esophagus and so on. Now, to obtain deep remission, like we say in IBD, we need histological remission of the disease. A lot of kids have scope in the various time intervals. They have a normal endoscopy looking like they don't have symptoms, but the disease is still active. Now, there is a pediatric symptom indices score developed in eosinophilic esophagitis, and hopefully will be validated with the studies which are running at the moment. Now, there are a lot of debate, what is the maintenance therapy? Because if you don't treat, it will recur in the majority of the patients. There is a cohort which may do well just with a bit of dose of PPIs, but usually will recur and will come back, and they will even continue during adulthood. You don't outgrow from eosinophilic esophagitis easily. It's not like the non-IgE cowsmic protein allergy. Now, what was known before by the American College of Gastroenterology and the ESPGHAN 2014 guideline, you can use these oral steroids, usually the topical steroids. You use oral is only for strictures. You can titrate them, but not for very long. Then you try to see what happened, and you stop it. Now we know that the PPI responders, long-term PPI therapy is effective and maintaining remission. I know there will be some shouting there about the long-term safety of the PPIs, but as anything in medicine, the benefit has to outweigh the risk. There is an ongoing study now which is happening with long-term PPI in eosinophilic esophagitis. Steroid-responsive patients, long-term therapy with topical corticosteroids. If you see the adult colleagues, they give oral viscobudesonide forever, but there's a caveat there about the safety. There have been cases of adrenal insufficiency reported, and prolonged avoidance of triggering foods and may lead to the sustained clinical and histological remission of the disease. Now, of course, if you have this cohort with the PPI, you start high dose at the beginning, but you can go to half dose later, or you can just use it as a maintenance. Also, with your topical steroids, if you have remission, you can do this strategy to have 50% reduction of the dose. But always remember about the rare but existed risk of adrenal insufficiency, even with oral viscous budesonide. Now, we depend a little bit about the diet in the next few slides. Just to tell you, traditionally, when the studies started, we have the inhaled fluticasone. The problem with inhaled fluticasone, it has to be swallowed, not the inhaler of the fluticasone. It has a particular technique, which is very difficult in the young kids. Even I, if I try, probably I will not manage very well. So that was a difficulty with the swallowed fluticasone. Of course, you have to wash your mouth. Then the liquid budesonide came, which we use as a DIY, do-it-yourself preparation. You use the sucralose, the Splenda is in the UK, but any kind of sugar substitute in the powder form with the residual budesonide you use for asthma, it will do the job, and you have to take it before you go to sleep, and it has to be in viscous form. That's why it's called oral viscous budesonide. There's new tablets coming now from Aldas, and that's a study which was published a few months ago, retrospective comparison between fluticasone and oral viscous budesonide. As you can see, the oral viscous budesonide, the score always much better in response, remission, and even partial response in comparison with fluticasone. Now, that's been established now. And the adrenal insufficiency, we had reports in pediatrics, and there is a study proposal now in the working group to do a baseline early morning cortisol, and every 3 months or various time points to check an early morning cortisol to identify these kids who develop adrenal insufficiency due to the long-term oral viscous budesonide. Now, a few slides about the diet and the feasibility in EUE, which is a lot of cost, especially here, because usually the formulas or they are not covered by insurance. A diet is a big component. So in the very severe eosinophilic esophagitis, especially those ones with strictures or very severe disease trachealization, we used to use amino acid formula, but of course this is not palatable. It has to come through the nasogastric tube. I remember a couple of adolescent patients I had, they put in the NG tube themselves, just they were feeling so much better to have 6 weeks course of amino acid formula. Of course you can see all the more than 80% it works. But is most effective, yes, for sure, but the palatability and the feasibility is quite difficult, and the cost here. Now, if you look on the 6-food elimination diet, which was the other one which was quite commonly used over the last 15 years, and it's still used, I'm not saying there's no role for that. More than 70%, if you look at all the studies, you do have histological remission. It's a highly effective, yes, in treating children with EOE. But again, it's very difficult. Sometimes you say this to the parents, say, how can I manage to do that? You need a lot of dietetic support to make sure that the child is nutritionally depleted. That's a difficult diet, 6-food elimination diet. But sometimes you have to do when it's severe cases. Now, the new thing which is coming now, and I want to pass a message with our allergy colleagues, and it's clear now from all the studies, we used to do skin prick tests or RAS tests to guide our elimination diet for eosinophilic esophagitis. This is not the case anymore. All the studies have shown that this is maximum you have 40% histological remission with the target elimination diet. This is not recommended now on the guidelines, and wonder why this is not an IG-mediated food disease. But again, I say that there is genetic predisposition there. There is aeroallergens. There's this periodic variation. There's some reports coming with eosinophilic esophagitis induced by sublingual polyimmunotherapy, which allergy colleagues use. So still something there. We don't know everything. So yes, we can use it, but it's expensive, and the feasibility is difficult. Most of these kids for amino acid formula, they need a nasogastric tube, and the 6-food elimination is very, very difficult. So we now started using, looking on the data we have from the peer registry, probably target the commonest culprits on that, which are milk, and as you can see, then wheat, then egg. The milk is always there. Unfortunately, it's always there. And I encourage whoever has eosinophilic esophagitis patients to get the data. It's very easy to get the IRB approval. It's just a registry. So because the easiest way to collect is the real life data. Now, why not 4 instead of 6? Yes, why not? There was this study, a landmark study published 2 years ago. Of course, this is only in research. You see what they do here. They do 4-food elimination diet for 8 weeks, and then they reintroduce, then rescope, and then see histological remission to identify. Yes, it's very nice for the study, very beautiful, but in real life, that's very difficult to do. So many endoscopies and so many endoscopies and biopsies. But you do have, in order to, at least not so often, in order to see. In the older kids, it becomes a bit easier because they have this dysphagia or dinophagia and food impaction. If that goes away, more likely, hopefully with the development also of the pediatric eosinophilic esophagitis symptom score, we will get an idea, and hopefully we'll do less endoscopies. And why not 2 instead of 4? Yes. There was a study looking on the adults and children, 2-food elimination diet, combining with 4-food elimination diet, and 6-food elimination diet. As you can see, adults and children, no much difference there, and not huge. Of course, when you go 6-food elimination diet, you have a better response, but even before, the statistical significance was not there. So probably we say goodbye to the 6 food elimination diet, and we approach with stepwise elimination, even starting with 1 food. You have to talk with your patient, you have to talk with mama. I have some parents say, there's no way me to do even 4 foods. So at least always have the milk there. With the appropriate dietitian support, you have it, or the appropriate supplementation, because you take foods from the diet. Now, and then it may be a good option as a single therapeutic option, but the compliance is a big problem. That's why we're looking on the safety and the efficacy of the oral viscous budesonide. There are new ones coming. There's a tablet which is effervescent. It's called Jovelza. It's been by Falk. It's been approved in adults. Hopefully, we'll have it in pediatrics in a few years, at least for adolescents. It's a controlled release of the budesonide, so you don't have to do this DIY with the oral viscous budesonide. And the final statement from the assistants at the moment from the final voting is consider a bilic elimination diet, no target elimination diet anymore based on a RAS test or a skin prick test, and with the choice of the eliminated foods individualized. That's the key there. You have to work with the family, you have to work with the patients. And unfortunately, still we don't know everything. More prospective studies needed. I encourage everybody to join the e-peer registry, and thank you for your attention.
Thank you very much, Dr. Christos. We'll start questioning. Dr. Ajmal, please.
Thank you, Christos. Really good talk. My main question is about FPIs. We know the one who present very severely, almost like shocked. What is the recommendation when to reintroduce for a confirmation of diagnosis as you would normally do for other allergies? And any timeline for that?
If you look on the consensus for severe like this, even they give IV ondansetron and IV methylprednisolone for these kids to start with. Then for the reintroduction, it's in the hospital setting, like in severe IG allergy, because it's so severe the picture.
After how many weeks?
Now, the majority of them, they grow out of this. That's a good thing.
Yeah, they grow out
up to 1 year. So usually when the parents are ready, I would say for a few months, they have a stability. Then, but in reality, when it's so severe, I never did it before 1 year of life. However, the guidance says you can do it 9 to 12. But the good thing with FPIs is they outgrow. They outgrow.
Yes, sir. Thanks a lot for your presentation, sir. Just I have 2 questions. The first one, of all the 3 common non-IG-mediated food allergies, which one of them have the most potential for causing failure to thrive? Of the 3, like common pulmonary allergy, esophagitis, and FPIs, which one of them has the maximum impact on growth, like weight loss?
I will say the common non-IG cosmic protein allergy, when it's severe, it can cause failure to thrive. The FPIs usually has this very traumatic picture, so difficult to miss this child, okay? It will end up in emergency department, but the chronic FPIs, yes. But it's rare, okay? FPIs is rare.
Yeah.
So I would say the bang-on classic non-IG cosmic protein allergy we see, if you neglect it, that one can cause you failure to thrive when it's above moderate to severe. The IMAP guideline, which I say, and the IMAP ladder is for the mild to moderate, not for the severe. Allergic protocollitis doesn't cause failure to thrive.
And suppose you have this undiagnosed, untreated, does you have a pattern where you have steady weight, then weight loss, weight gain, like a varying picture of weight loss, then stable weight, then weight gain over a period of time?
You can have this, especially with the eosinophilic gastroenteropathy.
Thank you.
You can have this.
Thanks a lot.
And some of them, actually, they can grow and still have the eosinophilic gastroenteritis. That's why you can delay the diagnosis a lot. But not very common to have eosinophilic gastroenteritis. And again, there's a bit of debate again about the diagnosis. Now, there are centers in the UK, I mean, our GI colleagues know about that. They were over-diagnosing these conditions and were giving all sorts of medicines. But at the moment, there's no consensus about this. Only the eosinophilic esophagitis has this consensus. But if you see in the biopsy abscesses, a lot of eosinophils degranulating, and microabscesses due to the eosinophils probably, and it fits with the context of the clinical picture, probably you may securely put the diagnosis. Yes.
A quick question, Dr. Christos, before the coffee break. As a pediatricians, we deal with cow's milk allergy, non-IgE mediated, and we put kids on hydrolyzed formula. I'm talking about babies or children less than 1 year of age.
Yes.
There is an overlap with this diagnosis, cow's milk allergy and eosinophilic esophagitis. And we don't know if really we are dealing with eosinophilic esophagitis child or with cow's milk allergy. And part of the treatment you mentioned is to use PPIs, topical steroids, in addition to elemental diet or hydrolyzed formula. So how to differentiate this group of babies who are less than 1 year, who we are treating at cow's milk allergy, and we're giving them a hydrolyzed formula, and they are not eosinophilic esophagitis patient?
Now, I will not tell you to send everybody to the gastroenterologist to do an endoscopy, which would be very nice for me and good for the hospital, but just to be realistic, in this age, it's not so common. It's difficulty with the symptoms, yes, because they have more or less the same. But if you treat with extensive hydrolyzed formula, okay, I don't believe in the partially hydrolyzed formulas, and you don't see improvement, and the child, after at least 4 weeks, then you start thinking about this. But usually, these kids, they will have something else as well. They will have a bit of atopy. They may have asthma attacks or viral-induced wheezing. You cannot say asthma no less than 2 years. So that will be persistent. It will not be just cow's milk protein allergy. Because yes, the milk is there, that's the top culprit of any eosinophilic esophagitis or eosinophilic enteropathy, but usually there are other foods needed as well. So I will say treat and wait. I say this to the parents as well, to have some patience, because a lot of them, they want something quick. This doesn't work like this. There's an irritation of the mucosa. The immune system has been triggered. In order for this to come down, it needs some time. At least 2 weeks, ideally 4 weeks. So I would say just keep calm and carry on, as the British say, and see how the child. If it's not failure to thrive, I would just carry on. And if it's still persistent after 1-2 months, then I will think about this. It's not so common in that particular age you mentioned.
Now we have to finish as soon as possible because the prayer is 12:15. So we'll start with our Dr. Basil Nasrallah. He's consultant pediatric and allergy respiratory, Emirates Specialty Hospital. He will present today about curing allergic rhinitis and preventing asthma. Is it possible? Thank you, Doctor.
Thank you, Dr. Amr. Thank you. It's a pleasure today to talk to you about a very important topic, which is allergic rhinitis and asthma. And together we would like to see if we can really prevent allergic rhinitis, and if we treat allergic rhinitis, can we really prevent asthma from developing? Do you think we can prevent asthma from happening? It will be a very novel thing if we can do. What do you think? Is asthma preventable? Positive thinking, good. All right. So my aim from this talk is to introduce you to allergic rhinitis, talk about how to diagnose allergic rhinitis, relation of allergic rhinitis with asthma as a comorbidity. Is it one disease or there are two separate entities? And how to manage allergic rhinitis to see if we manage allergic rhinitis, can we stop asthma? What is the definition of allergic rhinitis? All of you know allergic rhinitis, it's inflammation of the nasal mucosa. So it can be allergic if there is a trigger allergic factor. It can be non-allergic or infective. The definition, if you want it more specifically, it's clinically, I mean, it's 2 or more of the following symptoms for more than 1 hour per day: runny nose, blocked nose, sneezing, itchiness. When we say allergic rhinitis, when there's an involvement of IgE factor, it's IgE mediated. So there is a trigger which give these symptoms we talked about. The area classification for allergic rhinitis, they divided into mild or moderate to severe. Mild when none of the following are present. No sleep disturbance, no impairment of daily activity, no impairment of work or school, symptoms present, but they are not troublesome. If one or more present, it will become more severe to moderate. Intermittent versus persistent. Intermittent means 4 days per week or less than 4 days per week or less than 4 consecutive weeks. Persistent, more than 4 days per week or more than 4 consecutive weeks. All right, so what is the prevalence of allergic rhinitis? How common is allergic rhinitis? This is a very big study. It's a global study. They looked at 1 million, more than 1 million children of 2 years of age and 236 centers in 98 countries to see how prevalent is this disease. And they found a variation. It's different from one country to another, but the conclusion that it's more prevalent in Western society, in Western countries, although it's more severe in low economical countries, especially in Africa. So in Europe, allergic rhinitis is very common. In Belgium, it's the highest, 28%. In the UK, it's 26%. If you put all countries together, it's around 22.7%. What about in the UAE? There's a study done by Dr. Bassam and Dr. Sulaiman Hamad. Dr. Bassam, who was here yesterday, and they found that in Abu Dhabi, allergic rhinitis reached to 36%. It's too high. And they found that house dust mite is the most triggering factor, followed by grass, pollen, and animals. It's more common in winters, although there's not much winter in UAE. So the results of the report show that 37% of the people responded and showed they have allergic rhinitis. Interestingly, 89% of them, they have asthma. And 44% they were polysensitized to more than one factor, and only 39% received treatment. They are undertreated. Most common symptoms are aggravated by the house dust mite, and as we say, the winter is the peak season for allergic rhinitis. Allergic rhinitis can be seasonal, can be perennial. So, and if it's seasonal and you have a triggering factor, you have to avoid that trigger. So, as you can see from the slide, grass pollen, pollens, they are peaking on June and July, while tree pollen is peaking in April and May. The weed pollen peaks in August. The fungal spores peaks in the summertime. When you examine a child with allergic rhinitis, they have the classical presentation other than the symptoms. They have the transverse nasal crease, allergic salute, and allergic shiners, buggy, pale eyes. The nose, if you look inside the nose, you will see pale, congested turbinate of the nose. Don't forget the eyes. They are part of allergic allergic rhinitis. They will be red, inflamed, couple-stone appearance. And I'll talk to you more now about how to manage allergic rhinitis. The management is first diagnosis. You have to make sure you diagnose rhinitis. You have to make the diagnosis from the history and the examination, as we said. You can confirm which triggering the symptoms based on skin testing or RAS test. Make sure if it's a unilateral symptoms, it's not allergic rhinitis. There are other causes. It's a red flag to refer to ENT doctor. So after you do the history, you do the examination, you do the skin testing, then you can reach the conclusion. Is it allergic rhinitis, or is it infection, structural problem, or other things? This is the skin test we do in the clinic to see what triggers allergic rhinitis. You can see we do different triggers, the cats, dogs, feather, of course the positive control, negative control, and animals, fungal triggers. And house dust mite is not there, but it's the most common positive skin test we see. Other conditions you may resemble allergic rhinitis, but they are not. Septal deviation, non-allergic rhinitis, CSF leak, tumors in the nose, gastroesophageal reflux, adenoid hypertrophy. How to treat allergic rhinitis? This is based on the area guideline. You can see that based on the symptoms, you can start treatment. So the common medication we use for allergic rhinitis are the intranasal steroid, the antihistamine, non-sedative, intranasal decongestant, oral decongestant, avoidance of the allergen if you are able to find which allergen, and the new treatment is the immunotherapy. This slide shows you the symptoms of all the symptoms of allergic rhinitis, from rhinorrhea to sneezing, nasal itchiness, nasal obstruction, and the medication used and how they affect the symptoms. For example, oral antihistamine, they have a positive, good effect on all of these, except they have no effect on asthma. If you have asthma, has no role. Intranasal antihistamine, which we don't have them here. We have a new medication coming newly to the market. Nasal corticosteroid, which are the cornerstone, you can see they have more effect on all these symptoms, including the asthma. I'm sure you use cetirizine and loratadine. Cetirizine is the Zyrtec, loratadine is the Aries. Which do you prefer? Aries disloratadine, yes. But I mean, the molecule is the. So which one is more effective? Really, there is not. I didn't find any study in the literature comparing Zyrtec to Aries to say this is better than, except one study, which is a recent one, 2017. It's really comparing cetirizine with Aries, but it's a small study, randomized, placebo-controlled, in seasonal allergic rhinitis. They have 228 patients on cetirizine, 220 on Aries, and 229 on placebo, and all of them, they have a good total score for nasal symptoms, so they have nearly the same severity of allergic rhinitis, and they have the same demographic statistics, so they are around 8 years of age, and so they are comparable. And they want to, they looked at all the symptoms changes, and they found, give you the conclusion, it was a short study over 2 weeks period, that cetirizine, Zyrtec 10 milligram was statistically significant, more effective than placebo, while for the loratadine, it was not significantly statistically effective. So this, based on this study, Zyrtec is more effective. I don't have any shares with Zyrtec, the company, but I'm just showing this study. Of course, we need more studies, bigger studies, to prove that claim. All right. How many of you use antihistamine, Zyrtec or Aries, for common cold? Common cold. Dr. Johnny, you use it, yes. Who else? Common cold, runny nose, URTI. We use it, all of us, we use it. Come on, we have to admit that, right? Exactly. Yes. This is a very good Cochrane review. You can find it free online. It shows that antihistamine has no role. Exactly. No use, no role. But I know that all of us use it. What about the steroids? Steroids and allergic rhinitis, yes, they are very efficient. They are very effective. This study shows you how effective they are. And the effect starts even from day one. 10% of the symptoms improve. To see the full effect, nearly 30–40%, it needs about 10 days to 2 weeks. So you have to educate parents that give it time to work. Which is better, steroids or antihistamine? The steroids. Steroids are the cornerstone of treatment of allergic rhinitis. This meta-analysis, all these studies, favors steroids over antihistamine. Which steroids to use? There are a lot in the market. I'm sure you know a lot of them. This is just giving you the names of the steroids available worldwide. The most common ones we use here in UAE is the Avamys, Nasonex. These are The two approved from 2 years of age and above, FDA approved, all right? So the rest, Rhinocort is available. Flonase, I think it's not available. It's GSK2, but I think they're not available anymore. So the most common we use is this Rhinocort, Avamis, and Nasonex. But Rhinocort, 6 years and above. This is a slide show you all the steroids, the doses, how to give, and the price, which is the most expensive one, which is the cheapest one in the market. So if you want to look at the Avamis and the Nasonex, they are nearly equal in price per dose given. Bioavailability, it means if you get the nasal steroids, how much is absorbed in your body and causing systemic effect. You can see that the flutokinase, furate, propionate, and metamazone, all they have low bioavailability, which means they are good. The budesonide, they have high bioavailability, which they have more side effects. So go with these intranasal steroids. This is a new one. Have you heard about Dymista? It is in the market. Dymista is the only nasal steroids combined with antihistamine, and it's been in Europe and US for the last 4 years, and it has a good effect because it has 2 medication in one for the nose. So they have this study, Dymista themselves, and showed that they have a better symptoms control in compared to steroids alone or azathioprine. 12 and above. Yeah. Yes. Not very accepted by patient. In adults, they use it and it works. But if you want to try it above 12 years is okay. So the preferred medication, according to the area guideline, is nasal steroids and H1 blocker. There's a role for leukotrienes. I will show you the role later, montelukast. So if you don't improve after 2 to 4 weeks, if improved, you continue, then you step down after a month. If you fail to control the symptoms, you have to review the diagnosis again. Are you dealing with allergic rhinitis or something else? Review the compliance. How is he taking the medicine? Is there any infection? And maybe you need to refer to the ENT specialist. Which one of these pictures shows that the child is taking the intranasal steroid in the right? None. Bravo. Yes, none of them. So how to take intranasal steroid in the right way? And this is very important. Otherwise, it has no effect on the symptoms. Exactly. So the key is the other. Exactly. So the place where the problem is the turbinate, the outside, not the septal. The septal is cartilage. It has no major effect. The problem is in the turbinate on the either side. So what we tell parents how to take it, they have to bend a little bit, not to bend a lot. Clean the nose with saline, blow, and put the intranasal steroids in the, for example, right nostril towards the eye. So it will affect the lateral turbinate, and give 1 puff. Same for the left towards the eye, inside, give another puff, and ask the child not to breathe from the nose for 15 seconds, if possible. So I teach my kids in the clinic how to take it, and I ask them to demonstrate, and I tell them breathe from your mouth, and they do. So after they take it, they do mouth breathing 15 times. If they do, they swallow the whole medicine, and it goes into the throat and the gut and has no effect. All right? Avoidance. Does avoidance work? If you are allergic to house dust mite or grass pollen or tree pollen, does it work in treating allergic rhinitis? It does work. This studies was done a long time ago. It's in, I think, Switzerland, in the Alps. It has a very high altitude. House dust mite is very low, nearly free there, and they showed that improve the symptoms of allergic rhinitis. This is a study done in Marina Lake. It's in Italy, I think. It's house dust mite free lake. So it's a cold, because house dust mite, they don't live in cold weather and high altitude. They don't live there. They like the hot, humid atmosphere, Dubai atmosphere. This is what they love. So they did that study there. They took all these patients with allergic rhinitis, house dust mite, and they put them in that nice resort for a few weeks, and they found that the asthma symptoms decreased, they need less treatment, their bronchial hyperresponsiveness is less, and their total IgE dropped, which works. I'll give you a case. This is a 10-year-old girl who has seasonal allergic rhinitis. She has, you have treated her with antihistamine and nasal steroid, no much benefit. And she has a strong family history of allergy. Her young sister has eczema, older brother has asthma. You refer her for allergy testing, skin prick test positive for house dust mite. The parents are concerned that she may develop asthma like her older brother. What therapy might you try next to diminish the risk of allergic march from house dust mite induced rhinitis to asthma? This is a big question. Any suggestion? Montelukast. Okay. Others? Guess. Have a guess. Immunotherapy. Nothing you should not. Yes. Okay. This will take us to talk about more immunotherapy. This is the allergic march. If you have atopy, there is a chance that you will develop all the atopic diseases. It starts usually with, at birth, with food allergy, which you are to grow it at some stage, eczema, then the other allergic rhinitis and asthma develop later, and usually they persist longer. So allergic rhinitis and asthma, they are one common pathway. We should not look at allergic rhinitis without looking at the asthma. Why? Because yes, they have common inflammatory process, they have common inflammatory mediators. If you look at the allergic rhinitis and asthma, they share the same inflammatory cells and mediators, starting from the mast cells to the T cells, the eosinophils, interleukins, nearly the same. The prevalence of allergic rhinitis and asthma have similar prevalence. This shows the allergic rhinitis prevalence, this shows the asthma prevalence. They are nearly the same. So they look like one disease. 80% of asthmatic patients have allergic rhinitis. If you treat allergic rhinitis, only allergic rhinitis, without treating the asthma, you improve asthmatic symptoms. So this study shows the placebo, the nasoclacram, nasal, you see that improve in asthma symptoms just by giving intranasal steroids without giving any asthma medication. But as I said, what makes difference is immunotherapy. It's part of the area guidelines for treating allergic rhinitis is immunotherapy now. It's part of the GINA guidelines 2017. Consider immunotherapy, especially for house dust mite sensitive patient, to treat asthma. This is a big study, allergen immunotherapy for allergic rhinitis, systemic review and meta-analysis. And this study shows that immunotherapy works for allergic rhinitis. It's very effective. Indications, if you have mild to moderate asthma, I would say mild asthma, but if you have mild to moderate allergic rhinitis, you can consider it. If symptoms on exposure, you have an allergens, IG sensitized, inadequate response to anti-allergic drugs, and unacceptable side effects of the drugs, then you should consider allergen immunotherapy. How does sublingual immunotherapy compare with others? So if you want to compare immunotherapy with other allergic rhinitis medicine, this is a very nice meta-analysis study, and they looked at different ways of treating allergic rhinitis. 6 studies, they looked at 6 studies treating trimethoprim with sublingual immunotherapy, for ragweed, 2 studies for house dust mite. They looked at the Montelukast 10 milligram trials, 7 studies, 9 studies on ARIAS, 8 studies on intranasal steroids. They look at all of these and compare them to each other and compare with immunotherapy. And this shows the effect of disloratadine in seasonal and perennial allergic rhinitis. It has an effect. It helps the symptoms. The same for Montelukast. It has an effect on allergic rhinitis for both seasonal and perennial. Trimethoprim, ragweed, slet house dust mite. So, and this is the table shows in comparing them all together, the Montelukast with the Aries, intranasal steroid, immunotherapy for grass, ragweed, and house dust mite. And you can see they work very, very well, immunotherapy in such cases. So in summary, it shows, yes, it works. I'm just going to go quickly over these slides. They have a long-lasting effect. So you treat with sublingual immunotherapy, and they last 5 years. They may last even to 10 years. This study shows that sublingual immunotherapy to house dust mite in pediatric patients with allergic rhinitis and asthma, it shows before sublingual immunotherapy, after sublingual therapy. It's a small study, but it shows 39 children with asthma and rhinitis allergic to house dust mite were treated for 3 years with house dust mite sublingual immunotherapy, and they have complete clinical remission of asthma in 37 out of 39, 95%, and complete remission of allergic rhinitis in 82%. This meta-analysis shows that immunotherapy in prevention of asthma in children with allergic rhinitis, it works. It favors the immunotherapy and compare with the control. How to give immunotherapy? You start with different kind of immunotherapy, sublingual and oral or sub-Q. So it takes 1 to 3 years minimum treatment. You build up the treatment, you see the symptoms improving over years, and then you stop and you see the effect lasting for minimal 5 years. If you give immunotherapy to one allergen like house dust mite, there's a chance you stop not just house mite, you may stop also pollens and pets allergy. So it stops allergic rhinitis, but also stops allergic rhinitis and asthma. So immunotherapy works in monosensitization. It stops also polysensitization. It helps to stop allergic rhinitis into asthma. Thank you.
Thank you, Dr. Basil, for a very informative presentation. We have to take 2 or 3 questions if there.
Thanks, Basil, for such an interesting talk. I just have a quick question. Like, if you have sort of sensitization to, say, pet dander and to house dust mite, and both are significantly high with significant respiratory symptoms and sort of allergic rhinitis, can you give like double immunotherapy?
Yes. As we said, single immunotherapy works, but if you want to treat polysensitization, you can treat 2 together, not 3. Yani you can choose which is the most important triggering factor for his symptoms. If he's allergic to house dust mite, cat, and grass pollen, then you have to decide which is the worst 2, and you can start with these 2 and leave the 3rd one later. So you can treat house dust mite, and they don't want to get rid of the cat because they love cats at home. So you can treat for house dust mite and cat. You give the sublingual, for example, immunotherapy. 15 minutes to 20 minutes later, you give for the cat. So start with house dust mite, 20 minutes later give the cat. Every day, same day, 2 together can work and allowed.
Thank you.
Thank you, Basil, for that interesting talk. What about air purifiers? Do you advise your patients who've got house dust mite allergy to buy or invest in one or not?
We have an air purifier company outside, so I cannot much about air purifier. But yeah, I don't want to be biased. There are a lot of studies on air purifiers and house dust mite sheets, pillows, covers, vacuums, different things. And these studies are not very convincing. I wouldn't say they don't work, because there are some studies shows they have some effect. But if you want to be very scientific, very evidence-based, their effect is not major.
And sir,
how many centers are offering immunotherapy?
There are a lot of things. I think we offer, Nitin, you offer immunotherapy, Dr. David, they offer, I know these 3 people, Dr. Hanan, you offer this 4, 5, there are. It's not covered by insurance, but if you fight the insurance and you're willing to write letters and letters, they may accept it. Hi.
is high in UK because they have closed the house, the carpets, and all these things. Here, I don't think the houses have so many carpets, and
There's still carpets, but I think
and the weather here is not so humid, so moist like the UK. Maybe the change of season, but the house dust mite here is the same as prevalence, the same as the other parts of the world.
It is.
Like
It's
UK?
even higher. I think it's even higher. The only study we have here is Dr. Bassam. This is the only study in UAE, and it shows that the house dust mite is on the top of the list. But I believe, from what I see in my clinic, the house dust mite is very common. As I said, the weather is not helping here. It's humid, it's hot. People, they don't expose their houses to sun. House dust mite loves dark, humid places.
Yeah.
Although there's not much carpets, but the weather is not helping.
And is it the same? Because here we have children from all over the world. Is it the same to all nationalities, or regardless of where the child
House dust mite, I don't think has to do with nationality or genetic. It's a mite living in the environment. So if the environment is the right for them, they will nourish and live and start to sensitize people. The sensitization has to do with some genetic and ethnicity.
People, yeah, not
ethnicity. Yeah. But house dust mite is very common among all ethnicities.
All over the world,
I think we can receive one question more.
Thank you, Dr. Ahmed. Dr. Bassel, thank you for the beautiful presentation. It's really eye-opening. I just want to ask about your insight about the relation between nasal congestion, wheezing, and reflux. We see only the tip of the iceberg, and a lot of cases come with reflux presenting with like congestion, wheezing, and all this. So I just wanted to hear your intake on this.
As I showed in the slide, reflux is part of the differential diagnosis of nasal congestion and nasal symptoms, especially if it happens around sleeping time, waking up in the morning with a blocked nose, congested nose. You have to think about, you have to look at the whole picture, look at the symptoms, but I wouldn't say it's very common. We have to think about it in kids less than 1 year of age, more than healthy children who don't have vomiting, they are healthy, they're not having any GI symptoms, but they have only nasal congestion with itchiness. I won't think about reflux as a first thing.
I am so sorry for not receiving more questions. I know this is a very interesting topic, but I think Dr. Bassel, after we finish, we can answer all the questions. I would like to invite Dr. Zara Kuza. She will present today oral immunotherapy and food allergy. She is consultant pediatric allergist in Cambridge University, United Kingdom. Welcome, doctor.
Good afternoon, everyone. Sorry for the IT issues. So today I'm going to be talking about oral immunotherapy for food allergy. It's potentially a very, very large topic, so I will keep it brief. We'll go over a brief overview of immunotherapy, oral immunotherapy. I'll show you a few examples of peanut oral immunotherapy. I've chosen this because this is what we do at Addenbrooke's Hospital. We'll discuss the role of omalizumab in oral immunotherapy as well. So food allergy is IgE mediated. We've seen this slide at David's talk yesterday. I really like it because it shows the immunological processes between sensitization and allergy really, really clearly. So first of all, sensitization in food allergy mostly occurs in the mucosal surface of the gastrointestinal tract, although skin and inhaled routes have also been described. So food antigen is picked up by specialized epithelial cells, gut epithelial cells, and it's transferred to an antigen-presenting cell. In this case, it's a dendritic cell. The MHC class II cells on the surface of the dendritic cells process the antigens into smaller peptides, and they present it to a naive T helper cell. There's a very specific interaction between the MHC class II cells and the T cells. So in atopic individuals, they have the propensity to develop, an allergy. The Th2 cytokines are released, and it encourages B cells to produce IgE antibodies, which are specific to peanut. These specific IgE antibodies then attached to the surfaces of mast cells and basophils through high-affinity IgE receptors. Upon ingestion of peanut, subsequently, these peanut antigens cross-link with IgE, leading to mast cell degranulation with release of inflammatory mediators and symptoms that you can see there. So burden of disease is pretty high. Yesterday, we heard that food allergy epidemic has been described as a second wave of allergy, where there's an increased prevalence of sensitized children, there's an increased severity to the profile of food reactions, and there's a broadening of reactivity to more allergenic foods. The pattern of food allergy also differs with different ages. So in infancy, particularly in Europe, milk and egg allergy is very common, followed by nut allergy in younger children, and older children tend to develop shellfish allergy or seed allergy to seeds. In developed countries, the prevalence of food allergy in children is between 3 to 6%. In the UK, the prevalence is around 7.1% in breastfed infants, 1 in 20 of whom will go on to develop egg allergy, and 1 in 40 will develop peanut allergy. This is from LEAP study data. The best available management for children with food allergy really comprise of education and training to strict avoidance of food proteins, the culprit food proteins, and also teaching patients to recognize symptoms and signs of anaphylaxis and to give them a prescription for an adrenaline autoinjector if they have a risk of anaphylaxis. It is good practice to supply patients with a written allergy action plan. This is an example of the BSACI treatment plan, which anyone can download. You don't have to be a member. So the next, we discuss the goal of immunotherapy and the different concepts that people use. So a healthy gut mucosal milia balances host defense and immunoregulation. Disrupted oral tolerance results in food allergy. So this can be in the development of oral tolerance in young infants, or even in established oral tolerance can also be disrupted. Defective induction of regulatory T cells can lead to food allergy. So T cells suppress immune responses in lymphoid tissues and also target organs. The aim of oral immunotherapy is really to promote oral tolerance. So when people talk about oral immunotherapy, desensitization means protecting patients against severe anaphylaxis type reactions, and you do that by some of the mechanism includes increasing IgG levels and reducing IgE levels, and also reducing reactivity of mast cells and basophils. Whereas tolerance is the active induction of T regulatory cells. So what exactly is involved in oral immunotherapy? So the concept is based on the success of injection allergen immunotherapy for inhalant allergy that Basil touched upon earlier. So the efficacy for grass pollen immunotherapy for allergic rhinoconjunctivitis patients is well established. So in oral immunotherapy, we use powdered food protein given in a food vehicle. So in our practice, we give them in yogurt or chocolate mousse, or something of that consistency. Patients are given incremental doses, and the dose increases are usually done under controlled settings, so in an outpatient clinic or in hospital. Patients then have regular home dosing of a maximum tolerated maintenance dose. At the end of the treatment period, patients tend to undergo a food challenge to assess desensitization or tolerance. So this is results of the STOP2 clinical trial, where efficacy of oral immunotherapy was assessed for children with peanut allergy. Just under 100 patients were recruited. They were children aged between 6 to 17 years. They were given the oral immunotherapy regime consisted of incremental doses of 2 milligrams of peanut flour up to a maximum of 800 milligrams of peanut flour, and the increment was 2, 5, 12.5, 25, 50, 100, 200, 400, 800 milligrams. And the increment was over a 2 to 3 week period. At the end of the treatment period, which is 26 weeks, children underwent a challenge to a maximum of 1,400 milligrams. So that's almost a doubling of the maximum dose they tolerated in the maintenance phase. They found that the primary outcome measure was to assess the proportion of children who achieved desensitization, which is tolerating the challenge after the 6-month period. So this was a randomized trial, so half of the patients were given the treatment and half were given placebo. And after 6 months, the control patients were given peanut oral immunotherapy, so it's a crossover design. So they found that around 62% managed to pass the challenge after 6-month treatment. And the increase in the reactive threshold was calculated to be around 25 times higher. And that just shows the median a dose of peanut that was tolerated without any adverse events by the treatment group, and then after 6 months by the other originally placebo group, and who then received treatment. Adverse events were mild. 5 patients reported gastrointestinal reactions, mainly nausea and vomiting, and 1 participant needed IM adrenaline. This was after having a dose at home, and he developed wheeze, and he self-administered adrenaline. In hospital updosing, none of the patients received adrenaline, although I think 4 received inhaled salbutamol. The method of updosing was novel at the time because other oral immunotherapy protocols were based on venom immunotherapy protocols, where there was a rush updosing regime on day 1. So based on the success of the STOP trial, a spin-out company called Cambridge Allergy, was set up by the lead investigators, so Andy Clark and Pam Ewan, which led to the setup of the Cambridge Peanut Allergy Clinic. This is the only clinical service in the UK that offers peanut oral immunotherapy. This is not, the product is unlicensed, so this service is not available on the NHS. It's a patient self-fund for this treatment. Since starting at the end of 2015, we have now treated 170 patients at varying phases now. We've seen them longest at 3-year follow-up, so at the end of this year, we'll see them at 4-year follow-up. So children, again, like the STOP trial, 7 to 16 years of age with moderate to severe peanut allergy. They have to have had a high likelihood of an IgE-mediated reaction to peanut, and they have to have positive allergy tests, including sensitization to the seed storage components of peanut protein, because this correlates with a higher level of, it's a more severe phenotype of peanut allergy. So the regime that we use is similar to the STOP trial. So the first 14 weeks is what we call the updosing phase. That's the most intensive because patients come in for 7 visits in total, where they get updosed at every visit from 2 milligrams up to a maximum of 200 milligrams. The study team felt that a maximum dose of 800 milligrams didn't really confer much immunological benefit, but resulted in a higher rate of adverse events, and 200 milligrams was found to be enough. At the end of the 14 weeks, patients achieve desensitization, but we don't challenge at that stage. When they come back for their first year review, we offer a dose test, which is a single challenge or a single dose of 1,000 milligrams of peanut, which is 5 times the top maintenance dose. We've had around 40 patients who've had that. We only started to offer that in the last 6 months or so. And the majority of patients tolerate the dose without any problems. 3 patients have needed antihistamines and 1 needed adrenaline, but they were recovering from a respiratory tract infection. So we probably shouldn't have done it at the time. Patients continue on 200 milligrams of a maintenance dose every single day until 2 years. At the end of the 2-year period, in order to maintain the immune tolerance developed over the 2 years, patients continue on once-a-week dosing of 200 milligrams. And this is a problem with oral immunotherapy. A lot of studies have shown that desensitization is achieved, but this effect isn't prolonged unless you maintain a certain dose or intake. Exclusion criteria, we don't exclude patients who have had anaphylaxis. We don't exclude patients with asthma. We can get the asthma under control. They're welcome to be treated. Also, patients come from all over the world. We've had patients come from Malaysia for the treatment, and it is very well tolerated, the 200 milligram dose. After treating the first 100 patients, this is a BSACI abstract that was presented, not in the last one, but the previous BSACI conference. So we looked at efficacy and adverse events in our cohort of patients, and we found that total symptoms in the first 100 treated patients, so over 10,000 doses were free of symptoms, and adverse reactions were reported in about 2,367 doses. And some of these adverse reactions can occur simultaneously in the same patient. When you look at peanut immunotherapy days, so this will include the updosing period and also the maintenance phase, over 8,000 treatment days were free of symptoms, and 1,700, so 16% adverse events were reported, looking at days of treatment. So the symptoms reported, they tended to be mild. Most were self-limiting. 75% of the reactions were mild and self-limiting, and only 12% required a single dose of antihistamines for treatment resolution. There were 4 A&E attendances. 2 of them were for anaphylaxis. This was during the maintenance phase, where the patients were treated with adrenaline, and 2 of them were due to asthma exacerbation. The number of, that's the individual sort of number of adverse events experienced by patients. So the first ones were sort of less frequently, so 1 to 9 adverse events up to sort of more than 70. So adverse events were pretty mild. So basically our treatment is very well tolerated by patients. The most frequent adverse events tended to be gut, so abdominal pain, nausea, a few vomiting, but these tended to be worse with patients who were generally anxious to begin with anyway. This is another trial. This is actually a clinical trial. It's a phase 3 trial looking at the immune product for peanut oral immunotherapy called AR101. It was a phase 3 trial. It was huge. They recruited over 500 participants, but they also looked at the adult age group as well. However, the vast majority of patients were children aged between 4 to 17 years. Their protocol was a little bit different from ours. Their starting dose for immunotherapy was 0.5 milligrams up to 300 milligrams. That, again, was around over 6 months. They had a screening sort of challenge where they only recruited patients who reacted to peanut at 500 milligrams, and they excluded close to 200 people who didn't react at that level. And at the end of the trial, at the end of the treatment period, patients were challenged to peanut at 300, 600, and 1,000 milligrams. So desensitization was achieved in 67%. This is comparable to the STOP trial, which was around 62%. However, they had a really high rate of adverse events in almost everybody during the treatment phase, but most of them were mild to moderate. They did report systemic reactions, most of which, almost all of them, were treated with intramuscular adrenaline. So it was a shame that there weren't very many adult patients recruited. They didn't show any efficacy in the adult group, which is this group. But compared to placebo, the treatment group, so over half tolerated the 1,000 milligram peanut challenge after 6 months. Also, they excluded quite a large group of patients who had a higher threshold for reacting to peanut. Perhaps they could have had a milder phenotype of peanut allergy. This other study, again, yesterday we had an interesting talk about pre and probiotics, and this study conducted in Australia, looked at, it was a 4-year follow-up of patients who've been treated with peanut oral immunotherapy in conjunction with a probiotic. And they found that in the initial study, they were treated for about 18 months. Active group received peanut oral immunotherapy plus that probiotic. They were then challenged 6 to 8 weeks after completing treatment, and those who passed the challenge were advised to eat peanut just regularly in their diet. In the follow-up study, in those who were still taking peanut in their diet, were invited to return for follow-up, and they were advised to do 8 weeks of peanut avoidance, at the end of which they were challenged to peanut to assess for sustained unresponsiveness. So they found that the specific IG to peanut was a lot more reduced in the treatment group compared to the placebo group, but that didn't really reach statistical significance. But the ratio of IgG4 to IgE was a lot higher in the treatment group compared to placebo. And they also found that the 8-week sustained unresponsiveness was maintained at 4 years without any advice to regularly keep peanut in the diet. They postulated that the addition of a probiotic was beneficial and added to the treatment effect. However, they really needed a third arm where they assessed patients undergoing peanut oral immunotherapy without probiotic in order to clarify this beneficial effect. Safety-wise, there was no anaphylaxis reported. So this treatment was very well tolerated in the patients. So in the clinical trials I described, the ones that the STOP trial and also the A-Immune trial, anaphylaxis was reported. So in the A-Immune trial, it was about 14%, where patients needed adrenaline treatment during treatment. So safety is still a concern for patients undergoing oral immunotherapy, and people have tried to think of ways to improve safety profiles of oral immunotherapy for patients. And one of the ways that you can do this is by using omalizumab, and yesterday I explained that omalizumab can dampen the effects of IgE and also mast cells and basophils. In this study, it was very novel because they looked to treat patients with multiple food allergies. So patients were given multiple food oral immunotherapy, a maximum of 5, or placebo. So they were first treated with omalizumab alone for 8 weeks. At 8 weeks, they added the food, multiple foods, and they stopped omalizumab and continued oral immunotherapy for some time. The patients, again, had a screening challenge to 500 milligrams of the protein, food protein that they're allergic to, and the maintenance dose, they increased to a maximum of 2 grams. At the end of the treatment period, patients underwent only a challenge to 2 of the foods, again at a dose of 2 grams. So in the, it's quite a busy slide, but basically the green means that they passed the challenge, and the red dot are all the patients who had omalizumab pre-treatment. So there's a lot of green there, so they felt that omalizumab significantly increased safety profile and enabled patients with multiple food allergy to receive treatment. This is the placebo group, and these are treatment failures, so people who couldn't reach the maximum level grams of food protein during treatment, so they had to be stopped. So omalizumab was found to significantly improve patient safety. The active group passed most of the food challenges. There were a few treatment failures, and there was no systemic adverse event reported. So it's just a very brief overview of oral immunotherapy, what the aims are, discuss some peanut oral immunotherapy trials, safety can be enhanced with omalizumab, and that desensitization plus minus tolerance can be achieved with oral immunotherapy. But the question is, will there ever be a cure for food allergy? Because at the end of the treatment periods, patients are desensitized, but that is a short-term effect. If you want to prolong the effect, you have to maintain a certain dose over time, but this is quite, it's quite a commitment for patients, time and money, and it's probably unsustainable for the general population. But this question is what drives people to keep looking for answers. Thank you.
Thank you for your presentation, but we'll postpone the question after the next session, and we'll make it all together. I would like to invite Professor Robin Jay. He's Director of Pediatric Surface and Pediatric Pulmonology and Pediatric Intensive Care, Allergy Service in South Africa. He will present today allergy prevention and is it possible?
Right, well, good morning, everybody, and thank you for that kind introduction, and thank you, Basil, for the invitation to come speak at your meeting. I know that I'm standing between you and lunch on you and prayers, so I'm going to kind of move rapidly through my presentation, and I'm happy to take some questions during lunchtime afterwards. So what I'm going to talk about is the idea of allergy prevention. Is it possible or not? You've heard a lot about allergy during the course of this meeting, and I'm not going to focus on the clinical manifestations of allergic disease, but you know them well by now. We're in this epidemic of allergic diseases. They're the commonest chronic condition that we face in a pediatric practice, in adult practice. They are responsible for a huge healthcare burden, cost, and many patients have a very poor quality of life, like these two children illustrated in this slide. So I've come to understand that there are things that we can do today to talk about prevention of this epidemic, to talk about prevention of allergic diseases. And I'm trying to focus your attention and my attention in allergy prevention in certain domains. So I've thought about this as the windows of opportunity that we may have where we can intervene in the life of a child or a parent to be able to turn off allergic disease. And I think today we should start to think that allergy prevention is possible in these 3 or potentially 4, if you include the method of birth, which I think is really critical as allergy prevention strategies. I'm not going to go through the definitions. You've heard about definitions throughout the course of the symposium, but these are the conditions we're trying to prevent: IgE-mediated allergic diseases. So for many years, we used to believe that based on your genetic makeup, you were predetermined to develop a disease or not. So this is the so-called potential developmental outcomes of health or disease. We used to believe that genetically you were born with a predisposition to a certain condition. Remember, allergy is a genetic condition, although the genetics, it's a polygenetic disorder and the genetics are not well understood. But we used to assume that based on the fact that mom and dad had an allergic profile, your child would be born with an allergic condition that would manifest. That's how we used to come to understand that you could do nothing more to prevent allergy. However, we know today, based on environmental associations and epigenetics, factors on top of your genes, that we can actually alter the outcome for a child who has a genetic makeup for a particular condition. So this is the idea that we can start to think that allergic conditions can be turned off or reduced in terms of intensity in some children. Your genetic profile does not have to express itself in every domain. There are things, environmental manipulations that we can achieve in order to turn off allergy and the allergy outcome for a particular child. So let me just touch on a few of the things in those windows I showed you that we can start to do in terms of talking about allergy prevention. Now, in window one, which is in pregnancy, would require us to cooperate very closely with our obstetric colleagues. And I think this is the important issue about allergy prevention. It's going to take more than one intervention to get it all right. And unfortunately, what we haven't got yet is a complete understanding about putting the whole package of these allergy prevention tools together. So there are individual studies looking at individual interventions. And I think that we need a study that looks at a package deal of putting all of the things that I'm going to tell you together to see how much allergy prevention we can achieve. But in pregnancy, there are certain things to do. Many years ago, there were a number of randomized studies that were conducted, especially in Scandinavia, looking at eliminating allergenic foods from a maternal diet to prevent food allergy in the child. And in fact, that failed. That strategy of eliminating allergens from high-risk maternal diets is a failed strategy. So mothers who are allergic themselves or atopic by nature should not exclude allergenic foods from their diet, except, of course, if they are particularly allergic to a foodstuff. But the total avoidance of allergenic foods in the maternal diet is not applicable. And then there are probably two things that we should be adding to the maternal diet to start to prevent allergy, and where there is quite significant body of work today to suggest. The first is that polyunsaturated fatty acids should be added to a maternal diet. And the best way of achieving that is that a maternal diet, a pregnant mother's diet, should include fatty fish at least once a week. And that's tuna or salmon in the diet. So a pregnant mother should include polyunsaturated fatty acids in her diet. The second, quite controversial, but at least has been adopted by the World Allergy Organization, is probiotic supplementation in pregnancy. So the World Allergy Organization, which is one of the few organizations, actually suggests that mothers who are at risk of allergy should include a probiotic in their diet. And of course, lactobacilli are probably the best studied and most efficacious of the organisms. Many of the other recommendations around vitamin D and so on, the evidence is not clear. But the topic vitamin D is a whole story on its own, and I won't delve into that. But there are two other important things that are very important allergy prevention strategies in pregnancy. The one is, of course, cigarette smoking. And we know that cigarette smoking in mothers, both active and passive smoking, induces allergy, as well as a whole range of other allergy-related phenomena like recurrent wheeze and asthma. So mothers should avoid active smoking, but also passive smoking. And good studies have shown that when fathers in the house smoke, mothers are at higher risk of delivering allergic babies. And then I say plan vaginal birth, because mothers who are pregnant should always, especially high-risk allergy mothers, should always think about the way they're going to deliver their baby. And I'll show you what I mean by that as we talk about the next window of opportunity. And then there are, of course, a whole lot of generic things we should do in pregnancy. Of course, mothers' allergic disease should be well controlled. And mothers should get a healthy, balanced diet and a healthy dose of sunlight exposure and so on. Just to show you that there are studies emerging today that show that antibiotic use, not only antibiotic use in young children is a risk for allergy and asthma, But antibiotic use in pregnancy is a risk for allergy and asthma. And this is a study recently published that showed that antenatal use of antibiotics, pregnant mothers, increases the risk of allergy. When I talk about window 2 and the method of birth, remember that one of the big problems about cesarean section, I'm not sure if this happens in your country, but certainly it happens in my country, that cesarean section is always associated with an antibiotic that is given at the time of the cesarean section. So not only are you being delivered by cesarean section, which is a problem in terms of allergy risk, but you also get an antibiotic, which is an allergy risk profile. So let's talk then about this second window, the actual method of birth and the first 4 months of life in terms of feeding. Now, one of the biggest or greatest risks for allergy and many other chronic inflammatory diseases, at least by association, is elective cesarean section. So elective cesarean section means that you elect to deliver your baby on a particular date, irrespective of whether you go into labor or not. Often it's on daddy's birthday or granddaddy's birthday that you elect to deliver your baby. And this has been associated, elective cesarean section has been associated with many of the chronic inflammatory disorders that we're talking about this weekend, including allergy and asthma, but also the metabolic syndrome, hypertension, diabetes. Many of them are associated with elective cesarean section. And the two reasons that elective cesarean section is terrible for allergy is because of two things. First of all, you don't get exposure to mommy's normal vaginal flora, the gastrointestinal and vaginal flora that are essential as probiotics, if you like, for the newborn baby. And secondly, babies don't get that cortisol stress response that is essential to turning off chronic inflammatory disorders. So for two reasons, elective cesarean section has been associated at least with many of these conditions. Now, why I say associated is because there's no randomized study to show proof. It's going to be very difficult, in fact, to get proof based on randomizing in that fashion. But I think there's a good body of evidence today to say that elective cesarean section is problematic in terms of allergy. And so one of the important preventative strategies would be to start to promote normal vaginal delivery in the population, at least in mothers who are at high risk of allergy. So then the issue of feeding practices in those first 4 months is important. Now, although we say there are a number of benefits to breastfeeding, and I've shown you some of them on the slide, in fact, the evidence around exclusive breastfeeding and prevention of allergy is very controversial. There are some studies that show that exclusive breastfeeding is protective for allergy, and in fact, there are some studies that show that exclusive breastfeeding is a risk factor for allergy. So we don't quite have the answer in terms of breastfeeding and prevention of allergy, but because of the number of other benefits that I've shown you, the number of other immunological benefits from breastfeeding, we would suggest that allergic mothers, mothers at risk of allergy, electively breastfeed for at least 4 months of life. Now, what happens if a mother cannot breastfeed or elects not to breastfeed? Is there an alternative that we can suggest that may have a hypoallergenic, an allergy-reducing strategy? And one of these relates to the hypoallergenic formulae feeds, the HA formulae. Now, you heard your speaker who was talking about food allergy this morning say hypoallergenic HA formulae are not a treatment for food allergy, and that's quite true. But they play a role in allergy prevention. And this work was based on the Genie study. Andrea van Berg, who's been to this part of the world many times, and many of you may have heard her speak about her Genie study, where they looked at using NAN-HA specifically in that study as an allergy prevention tool in mothers who could not or would not exclusively breastfeed. And the study was designed in a way that was patients were randomized to get one of 4 feeding strategies. They were either given NAN-HA, they were either given a extensively hydrolyzed casein and a partially hydrolyzed casein. Remember, NAN-HA is a partially hydrolyzed whey formula, or they were given placebo. And these babies were randomized to get one of those 4 feeds. And there were a large number of babies in the study, over 2,000. And then they had an open extension arm to the study where they followed up babies whose mothers decided not to participate in the study, but they followed them up for some years afterwards to see what would happen in a group of babies where mothers elected to feed their babies in different ways. And I'm not going to go into the details of the study because I'm sure many of you know by now. But Professor Hania, who's also been to Dubai many times, and you may have heard her speak, she did a meta-analysis of the studies of HA formulae in the reduction of atopic dermatitis. And you can see that when you use HA as a preventative feed strategy in babies who aren't exclusively breastfed, there is at least a 50% reduction in atopic dermatitis in the first year of life. And that's really a significant benefit to mothers who are at risk of allergy. Remember, we are talking about a strategy in families at high risk of allergy who can't exclusively breastfeed. An HA formula is able to reduce the risk of atopic dermatitis, at least, by about 50% in the first year of life. Now, the Genie study has now gone on to 15 years, and there's still a 30% reduction in atopic dermatitis up to 15 years by using NAN-HA in that population group. What I wanted to show you one slide from the Genie study, which is quite important. What they did in this Genie extension study, the open label arm of the study, is they followed up the high-risk mothers who had their own allergic disease or came from a family with allergic disease. And they followed them up. And you can see in the black line is those mothers who elected to give all sorts of different formula feeds. If the mother who has a risk of allergy of her own elects to give a cow's milk-based formula feed to her child, the risk of allergies actually increased that you see in the red line above the black line. And this, I think, is important. When we are talking about allergy prevention to mothers, to families at risk of allergy, we should be giving advice around feeding practices in the first 4 months of life, not leaving it up to the family to choose the milk. Because if they choose a cow's milk-based formula, they're actually going to increase the risk of atopic dermatitis in their child. They must be spoken to about either exclusively breastfeeding or giving a hypoallergenic formula. And then I want to talk about this window between 4 and 6 months of age, which talks to the concept of oral tolerance that you've just heard about. Because during this period of 4 to 6 months of age, there's a window of opportunity in which if you expose children to high doses of allergens, you actually turn off allergy by promoting this concept of oral tolerance. And it works in this window between 4 and 6 months of age. If you give allergenic foods under 4 months of age, remember the gut is immature and the peptides get straight into the bloodstream and cause allergy. And after 6 months of age, you've lost the window. The window of immunological development has already occurred. But between 4 and 6 months, we have an opportunity in which we can do a few things to promote tolerance and reduce especially food allergy and atopic dermatitis. And one of the things we can do is antigen encounter, and the other thing that we can do is microbial exposure, the probiotic exposure story, and I'll talk to you about that. So we've got this window between 4 and 6 months of age. Now, you heard about the LEAP study earlier. This is a study that was conducted, published in the New England Journal of Medicine just a few years ago now, a landmark study looking at giving children peanut in the first few months and years of life in order to be able to reduce peanut allergy. You know that we live in a world where peanut allergy has become an epidemic. And so this study, they looked at exposing children to regular doses of peanut in their diet to see whether you could actually induce oral tolerance to peanut and reduce peanut allergy. And the results were dramatic. I'm not going to go through the methods. There were, in fact, two groups of patients in the study, those who were already sensitized to peanut and those who had no sensitization to peanut. And what you can see, I've highlighted the results in the red boxes at the top. A dramatic reduction in peanut allergy if you expose children to peanuts in early life. Obviously, we're talking about high-risk allergic children. If you expose them to peanut, you reduce the idea of peanut allergy. And that's because you need allergens to be able to turn off to turn on oral tolerance and to turn off allergy. And so the evidence for peanut allergy prevention by giving peanuts to children has now been adopted by all major allergy societies. The American Academy of Pediatrics have said that in children at low risk of allergy, you can simply introduce peanut into the diet. You don't have to do pre-testing. If they already have eczema or have had some sort of allergic reaction to a food, you probably need to test them first. But generally for the population at risk of allergy, you can give peanut in the diet to prevent peanut allergy. Now, I'm not going to show you the data, but the other food that is now well investigated in this way is egg. A number of studies have shown that you can do the same thing with egg. You can prevent egg allergy by introducing egg between about 4 and 6 months of age to promote oral tolerance to egg. What about pre and probiotics? Well, unfortunately, the evidence around pre and probiotics is still not sufficient for us to give clear recommendation. Despite the fact that this meta-analysis, this review suggested that there was quite a significant benefit of a prebiotic in both reducing allergy and atopic asthma or wheezy infant children, quite significant reduction, I've highlighted them. Despite this, we're still not 100% sure about which prebiotic and the timing of the prebiotic. So the evidence around prebiotic supplementation is still not conclusive. And the same is true for probiotic supplementation. Which probiotic to give to a high-risk family or the child of a high-risk family around prevention of allergy? Studies have shown that some of them work and some of them don't. And I think that's really where the problem lies with probiotics. We don't yet know what probiotic is best, what the timing of the probiotic should be, and how it should be given. And I think when we get the answer to that, probiotics will come into their own. So for the moment, there's no strong recommendation in any of the Allergy Society guidelines around probiotic supplementation in infancy. Remember, I told you in pregnant mothers, there's quite significant work to suggest that they work there. But by the time the infant is born, less clear evidence for what probiotic we should be using. So I think in conclusion, I've hopefully been able to convince you that allergy and the accepted wisdom that if you're born to a family at risk of allergy, you will become allergic, should no longer be what we expect from our patients. I hope I've been able to show you that there are a number of windows that are open during the course of the life of a child to be born or having been born to a high-risk allergy family. And I hope I've been able to show you that there are certain things that we can do to start to close these windows, that we can start to understand that we can do things to be able to help to prevent allergy. I've just given you snapshots of things to be done. I think what I said at the beginning of my lecture is the most important thing. What we really need is a study putting all of those interventions together to see how much allergy we can actually take off the table. Because I have a feeling that if we are strict about allergy prevention through each of those windows of opportunity, we will actually get quite a significant reduction in allergy in our patients. Thank you very much for your attention. Let me thank my friends, my group, for being a part of my life.
Thank you, Doctor, for your presentation. We'll start the question now.
Hi, yes, thank you. That's a great overview of prevention. Thank you very much. I've just got a question regarding partially hydrolyzed.
You're right.
So there's a lot of that here. So I'm from the UK and it's not available, but here there's a lot, and there's a lot of pressure. Now, my understanding, there was a meta-analysis done recently which showed no benefit of extensively hydrolyzed or partially hydrolyzed, looking at many studies. You've highlighted one study there. The worry is, of course, if we start promoting a formula as allergy prevention, that will reduce breastfeeding rates because parents will think there's an alternative, etc. Can we really say it's, I mean, is the jury not still out, or are we really at a point to start recommending it with that risk and knock-on effect on breastfeeding?
So that's an excellent question. So the answer is, of course, breastfeeding should be promoted. Remember that the World Health Organization recommendation of exclusive breastfeeding for 6 months has been slightly modified in the allergy world, where allergy is a risk, to exclusive breastfeeding for 4 months, and then the weaning to allergenic foods. So, but I would completely support the idea of exclusive breastfeeding in high-risk allergy families for at least 4 months. So that is a standard advice that we should be giving. Now, I've spoken to the authors of these guidelines, Andrea, Hania, and what I think is what really is the crux of these meta-analyses is that it seems like the mechanism by which you hydrolyze the protein is important. And an HA formula is not an HA formula across the board. Not all the HA formulae have the modification process works in the same way. And that's probably the answer to why meta-analyses differ in terms of an outcome. So some countries in the world, Germany, Holland, Netherlands, have kept HA formula in their guidelines as an allergy prevention strategy. And as you say, many countries have abandoned it as a prevention strategy. So, but I completely agree with the sentiment that we should promote exclusive breastfeeding as much as we can. And where it can't be done or isn't done, then we should suggest that an HA formula is an option for those children. Why I went to pains to point out that if mothers pick cow's milk-based protein and have a risk of allergy, they actually increase the risk of allergy. Now, that's well shown, and I think that's a real risk that we shouldn't allow.
Thank you, Professor Khan, for this excellent lecture. Just the last point in the summary, you said you introduced weaning from 4 months. My understanding that's only applicable to peanut and egg, but not everything else.
Right, so you're absolutely right. The two foods that have now been extensively studied where there's good evidence are peanut and egg. But there are studies starting to emerge in the realm of other foods, wheat, sesame, and cow's milk, and that evidence will become stronger as time goes on. But for the moment, the strong evidence is to wean to peanut and egg. And probably these others will come on board with good evidence in the near future.
Thank you very much for the very interesting lecture. I need to ask you about the prevention you said can begin in pregnancy. All these facts we pediatricians, we know more or less. But do we communicate this to the obstetricians? Do they have any idea about all this? And how can we make them hear our voice?
Sure.
All over maybe in UK it's better, but what about here? What can we do?
No, you're absolutely right. It's the biggest challenge we face in allergy prevention is getting our obstetric colleagues on board. So in my country, in my hospital, we now have a combined clinic for high-risk allergic moms with our obstetric colleagues, and we introduce this advice. But I understand that the greatest threat to this whole system is the elective cesarean section problem. And in many countries, elective cesarean section rates are now abnormally high. In private practice in South Africa, the elective cesarean section rate is 85%. The world norm is supposed to be 25%. So unless we convince our obstetric colleagues not to do elective cesarean sections, we won't even have a leg to stand on. And the biggest threat to that argument for obstetricians is that an obstetrician believes that the only way that he can guarantee neurological intact babies being delivered is by an elective cesarean section. And that's why they do them. And I understand that there's a move in parts of the world, like the United States, for every baby to be born by an elective cesarean section, 100% elective cesarean section rate, because obstetricians believe that that is the only way to prevent cerebral palsy. Now, the argument to that is that despite the fact that the elective cesarean section rate has gone up in the world, the cerebral palsy rate has remained completely flat. So it hasn't done anything to reduce cerebral palsy. So in fact, they don't have an argument, and we need to convince them of that.
Hi, thanks for the nice presentation. Have we got enough evidence now to say that taking care of the skin in the early newborn period also can prevent the allergies? Because we know the exposure through the skin is one of the risk factors for later development of sensitization.
So
and
you're
allergy.
talking about emollients, skin emollients,
That's
quite
right,
correct.
yeah.
Yeah. So there's some good evidence that to prevent atopic dermatitis specifically, use of skin emollients early in life is a good way of preventing both atopic dermatitis, and then of course remember the problem with atopic dermatitis is once you have open skin, it's a source of exposure to allergens that enter and trigger the immune system. So there's no question that there's a role for that.
If you had a child or with a severe atopic dermatitis and you wanted to start weaning, would you advise to do a skin prick test to peanuts and egg before you start giving them, or would you give
Yes.
it to them and see what happens?
So I would. So that's what the American Academy of Pediatrics recommend, that if you have severe atopic dermatitis, rather do an allergy test before you wean to peanut, and probably now to egg as well, just to be sure. Because the interesting phenomenon in the LEAP study was that they did have a group of patients in whom there was secondary oral tolerance. They were able they had low-grade skin prick test positivity, and they were still able to reduce peanut allergy. So if you had a low-grade skin prick test, you may even continue in that child to wean to peanut. But if you had a very high IgE or skin prick test reaction, I would not expose.
So Dr. Mazen Abu Shaban, head of pediatric department at Emirates Specialty Hospital, will be the moderator for this session. I will give the phone to him to introduce Dr. Hiba.
Assalamu alaikum. It's my pleasure to start the afternoon session of today with very delicious lectures. We'll start with Dr. Hiba. She's going to speak to us about suspected immunodeficiencies in children, how to approach and when to refer. Dr. Hiba is a well-known consultant immunologist in Tuam Hospital. She had finished her qualification and her training in immunology in UK, and she has worked as a consultant immunologist allergy in the Royal Victoria Hospital, Belfast, UK, from April 2013 to 2015, and she is now with us. Welcome, Dr. Hiba.
So when we talk about primary immune deficiencies, they're actually relatively rare diseases, with the first proven case published in 1952 by Dr. Bruton. So in his paper, he reported an 8-year-old boy with recurrent pneumococcal sepsis. And when he was investigating that boy, he did protein electrophoresis, and he found that he missed the gamma chain in protein electrophoresis. So what he did was that he gave him subcutaneous injection of immunoglobulin, and that boy stopped having infections. So the first report of primary immune deficiency was also the first report of the use of immunoglobulin therapy. So what are primary immune deficiencies? They're a heterogeneous group of disorders of both immune function and regulation. They're characterized by increased susceptibility to infection, which we all know. But patients with immune deficiencies are also predisposed to autoimmune disease, lymphoproliferation, granulomas, atopy, and malignancies, really highlighting the role of the immune system not only in fighting infections, but in recognition of self, what we call self-tolerance, and in homeostasis and immune regulation. The most recent report from the International Union of Immunological Societies in 2017, they reported 354 distinct primary immune deficiency disorders. But I'm sure by today they're over 400. They're relatively rare, ranging between 1 in 20,000 and 1 in 50,000. But we know they are higher where there is high level of consanguinity, like in this population. They can range from very mild conditions, like selective IgA deficiency, which people would argue, is it an immune deficiency at all? To severe and fatal primary immune deficiencies, like severe combined immunodeficiency. So looking at the classification of primary immune deficiencies, they were classified in 2015 by the International Union of Immunological Societies. And they're classified as primary antibody deficiencies, which are B-cell defects, or combined immunodeficiencies, which are both T and B-cell defects, but primarily T-cell defects. There are some known syndromes to be associated with immune deficiency. You can have phagocytic defects, either in number or function, or defects of innate immunity, where usually there is specific susceptibility to a group of diseases like tuberculosis or mycobacteria, or specific fungi or herpes simplex, and you can have very specific genetic mutations. There are defects of complement function and numbers, and the diseases of immune dysregulation. And these patients typically present with multiple autoimmune disease. You'll find that they have cytopenias, they have entropathy, they have multiple endocrinopathies. So IPEX, for example, is immune dysregulation, polyendocrinopathy, entropathy, and it's X-linked. And these are quite severe conditions. And the deficiency is in regulatory T cells, so it's in immune regulation. HLH, which we all know about, and autoimmune lymphoproliferative disease, where there's a defect in apoptosis, and that's why we have a lot of T cells that cause benign proliferation initially with hepatosplenomegaly, significant lymphadenopathy, but they can later transform into malignant lymphoproliferation. The autoinflammatory disorders like familial Mediterranean fever, where there is uncontrolled inflammation, are also diseases of the immune system. And the European Society of Immune Deficiencies, when they were looking to register their patients, they did find that they were patients who would fit these groups, but there is no genetic mutation, and they call them as unclassified PIDs. So looking at the International Union of Immunological Societies report in 2017, we can see that there is a gradual increase with times in the 1980s in the number of immune deficiencies with diagnoses. And this really reflects the fact that we're thinking more about immunodeficiencies, as well as we have better diagnostics now. So this is some data from the UK Primary Immunodeficiency Network in 2012, looking at the most common immune deficiencies in both adults and children. And you'll find that antibody deficiency is the most prevalent in both groups together. So when would you think about primary immunodeficiencies? So if you get any child with a serious infection, with an infection that's difficult to clear, it's persistent, an unusual organism, so something like PCP, opportunistic, you shouldn't get it if you're immunocompetent, or if they have recurrent infections. In a child who's failing to thrive, if they have a family history of a known primary immune deficiency, if they have physical characteristics of a known syndrome to be associated with primary immune deficiency, if they have a complication of infection like bronchiectasis, you should look for primary immune deficiency. And as I said, we're increasingly recognizing primary immune deficiencies presenting as lymphoid malignancies, especially if they're EBV-driven. or autoimmune disease, especially if you have autoimmune disease affecting more than one organ, so a cytopenia with an enteropathy, with an endocrinopathy, that may point out to an immune dysregulation. So this is a publication from the Jeffrey Modell Foundation to give us a rough guide about when to think about primary immune deficiencies, and they call them the 10 warning signs of primary immune deficiency. So if someone has 4 or more new ear infections per year, 2 or more serious sinus infections, 2 or more pneumonias, if they have deep-seated abscesses, if the infection doesn't clear with 1 month of antibiotics, if they have persistent oral thrush or fungal infection of the skin, if they don't clear infections unless they get IV antibiotics, or if they're a recurrent deep-seated infection more than once, so septicemia or meningitis more than once, or a family history of primary immune deficiencies. And when we consider immune deficiencies and think about investigations, really we need to try and think which arm of the immune system is affected. So you'll find that bacterial infections are common to nearly all primary immune deficiency groups. Antibody deficiencies typically present with recurrent sinopulmonary infections, or a persistent diarrhea, but they're specifically prone to enteroviruses because of the importance of IgA in the gut. Defects of the early complement proteins again predisposes to bacterial infection, but they also get lupus-like features because these proteins are important in clearance of immune complexes. The late defects of complement predispose to recurrent Neisseria infections. Phagocytic defects, either in number or function, will present with bacterial infections, including abscesses, as well as fungal infections like Candida. Whereas T-cell defects get everything. They get opportunistic infections, they get PCP, they get viruses, bacteria, GVHD. And when we're thinking investigations, it really follows a pattern. So we'd look from the presentation, which arm of the immune system do you think is most likely affected? Can we measure numbers? Are there any subgroups or subclasses we can measure? Can we assess function, either in vitro or in vivo? And is this pattern from the result, does it fit into a specific syndrome? And can we confirm this by molecular analysis? And we always have to think, is this a new disease if it doesn't fit with anything else, because we're still diagnosing immunodeficiencies. So when we're investigating and thinking about the phagocytic defects, always look at the CBC, and I think as pediatricians, we're very good at looking at neutrophils. Is this patient neutropenic? Look back, have they always been neutropenic? Is it a congenital neutropenia? Or do they have a neutrophilia, a very high neutrophil count? Do they have it only now that they have the infection, or is it persistent? Is there a leukocytosis with it? So like leukocyte adhesion deficiencies, they have a persistent leukocytosis and neutrophilia. If they're presenting with recurrent abscesses, fungal infections, lymphadenitis, we can think about chronic granulomatous disease, and we have to test for neutrophil function, what we call the neutrophil burst, by either dihydrorhodamine test or the tetrazolium blue test. If we're thinking about leukocyte adhesion deficiency, we can test for specific receptors via flow cytometry, like CD11, 15, and 18. So if a patient presents, we're thinking about complement deficiency like recurrent Neisseria, we can do CH50, which is a measure of the function of the classical pathway of complement, or AH50, which is a measure of the function of the alternate pathway of complement. And depending on the results, we can look at specific complement proteins. For antibodies, we need to check the total immunoglobulin levels, IgG-AM, and don't forget your IgE. It's very important, because if you have a completely absent IgE, and allergies do a lot of IgE, if you get an IgE of 0, I would recommend check immunoglobulins, because they may be immunoglobulin deficient. You can get low IgEs, but completely undetectable. That might ring a bell that this patient might be having an immune deficiency. And some immunological deficiencies can have very high IgEs, like the Job syndrome or the DOC8s or Omen syndrome. You can test for IgG subclasses. And to look for function, we do vaccine responses, where we look at specific responses to specific vaccines. And we usually choose a polysaccharide vaccine because this assesses pure B cell responses, pure antibody responses. We take a sample, we vaccinate the patient, and we take a sample 4 weeks later to look for what kind of response that patient made. To look at the lymphocytes, again, look at your CBC. As I said, as pediatricians, we're very good at looking at neutrophils, but please look at the lymphocytes, especially in young babies. Are they lymphopenic? Is the lymphopenia persistent? And if it is persistent lymphopenia, that should raise the suspicion of severe combined immunodeficiency. Again, is the lymphocytosis persistent? And does that come with a leukocytosis? Is it a leukocyte adhesion deficiency? Then you do the lymphocyte subset analysis, and we can look at function by looking at lymphocyte proliferation. So when you do a lymphocyte subset analysis, this is what it looks like. You get CD3, you get the numbers and percentage, and this is a pan marker on T cells. It tells you how many T cells you have. CD4 is a marker of T helper cells. CD8 is a marker of cytotoxic T cells, whereas CD19 tells you about the number of B cells you have, and CD1656 is a marker on NK cells. And then you can look for the specific protein. So if you have a clear pattern, you can then think, okay, this is this disease. Can I look for the protein like X-linked A-gamma globulinemia? You can look for the BTK. Or you can progress to genetic testing, either via next-generation sequencing, whole exome, or whole genome sequencing, whatever you have available. So I'll speak in more detail about severe combined immunodeficiency because it's R1 emergency and it's a potentially fatal condition. It's an inherited PID. It's characterized by deficiency of T cell number or function, but most of them will have low T cells. The B cells and NK cells can be present or absent, but even if they're present, especially the B cells, they don't work well because they need T cell help to work normally. The prevalence is about 1 in 50,000. It's a pediatric emergency because it's life-threatening if it's diagnosed late. And it should be suspected in any baby with persistent lymphopenia. It ranges from typical SCID, where patients typically die in the first year of life, to atypical SCID, where they can survive a few years longer, or Omen syndrome that we'll touch on a bit later. So typically, these are babies that can present any time from 3 months of age with persistent respiratory infection. So you'll find their adenovirus just doesn't clear up, or their paraflu, or they can get CMV. They can present acutely with PCP and end up in PICU requiring intubation. They may just have diarrhea and failure to thrive, or severe or invasive fungal infection, or just recurrent oral thrush. And especially in this population where they get BCG at birth, they can present with disseminated BCG. Or they may have a history of a sibling who died early in life, especially if they're consanguineous families. Omen syndrome is a phenotype of SCID where there is a hypomorphic mutation. So there is some protein expression that leads to the production of T cells, and usually high number of T cells. But these T cells do not work well, and they're actually autologous. And as well as the infections, these babies have generalized edema, they have scaly erythematous skin, they're very sick, and they also have hepatosplenomegaly. So when you're suspecting a SCID, look at your CBC. Do they have lymphopenia? But a normal lymphocyte count does not exclude SCID, because if they have normal or high B cells, this will compensate, and you'll have a normal total lymphocyte count. Or if you have some maternal T cell engraftment, again, you can have normal T cells normal lymphocytes on CBC. When you do the immunoglobulins, you'll find that they're very low, but in Omen syndrome, typically IgE is high. On a chest X-ray, you will not be able to see a thymic shadow. And really the key test is lymphocyte subset analysis, where you find severe deficiency of T cells. They will have very, very low T cell numbers, and obviously impaired function. And genetic testing, you don't really need it for diagnosis, but you will need it for genetic counseling. And whenever you think primary, think secondary immune deficiency, so you do need to exclude HIV. So initial treatment, you need to isolate these babies with barrier nursing, strict hand washing. Only CMV negative mothers should breastfeed. Any blood product should be CMV negative and irradiated, that is T-cell depleted, to prevent GVHD. You do not give them any vaccines, especially not live vaccines. You need ID on board as soon as possible to screen and treat infections early. Start them with PCP prophylaxis with cotrimoxazole, antifungal prophylaxis, and if they have previous herpes simplex infection, consider acyclovir, and start them on immunoglobulin replacement therapy, and while preparing them for a bone marrow transplant, because that's the only cure. You need to transplant them as soon as possible. I'll touch on a few of the more common primary immune deficiencies. X-linked agammaglobulinemia, which is the most common, but we do have autosomal recessive forms of agammaglobulinemia. The hyper-IgM syndromes, common variable immune deficiency. Transient hypogammaglobulinemia of infancy is where there is delay in babies from the age of 3 months in producing their own IgG, and they're losing their maternal IgG. So you'll find at time, and it can be up to 4 years, where their IgG starts to get low. Usually IgA and M are normal. Most of these babies are completely asymptomatic, but some can get infections. And in these cases, you will need maybe to give them prophylactic antibiotics or even immunoglobulin replacement until they start making their own immunoglobulins. And we'll touch on some of the PID syndromes. So X-linked agammaglobulinemia or Bruton's agammaglobulinemia that was described earlier, these are boys. It's the most common form of antibody deficiency in children. They typically present in 6 to 8 months of age with sinopulmonary infections, diarrhea, giardiasis. When you examine them, they're failing to thrive. You find that they're coughing, they're having this purulent cough. On examination, you can't see any tonsils or feel any lymph nodes. And you'll find that their immunoglobulins are very, very low or completely absent. And on lymphocyte subset analysis, they do not have B cells. The mainstay of treatment is the immunoglobulin replacement therapy that should be started as soon as possible to prevent complications like bronchiectasis. Really, any patients on immunoglobulins, they do not need any vaccines. And live vaccines specifically should be avoided, especially oral polio, because they are at risk of getting oral polio. And in some, you might need, as well as immunoglobulin replacement, is antimicrobial prophylaxis. So hyper-IgM syndrome, we all know that the first antibody to be produced is IgM, and via a process known as class switching, IgM will then change to IgG, IgA, and IgE. So these patients have a defect in class switching. So they can produce IgM, but due to some molecular defects in these molecules, either CD40 ligand, CD40 or UNG, or NF-kappa B, they cannot class switch. So you'll find that they have a very high IgM, and usually with infections, the IgM increases more, but their IgG and A are very low. Usually they present typically the same presentation as Bruton's or X-linked agammaglobulinemia, but in the CD40 ligand, because it's primarily a T-cell defect, they also get pneumocystis and cryptosporidium. So the CD40 ligand and CD40 defects will need a bone marrow transplant as well. Common variable immune deficiency is the most common immune deficiency in older children and adults after selective IgA deficiency. It's a heterogeneous, really, condition. And initially, there were no genetic mutations found, but now we're finding more and more gene mutations to be associated with CVID. And because the diagnosis is not really very clear, there's a significant delay. And because it's a disease of adults, people seem to think that adults do not get primary immune deficiencies, but they do. And how to diagnose CVID is really by finding a low IgG plus IgA or IgM. And clinically, the patient will at least have recurrent infections or an autoimmune disease or granulomatous disease or lymphoproliferation or a known affected family member. You need to do vaccine responses to see if the immunoglobulins they have are working or not. And you need to exclude secondary causes of antibody deficiency and diagnose it after 4 years of age to exclude transient hypogammaglobulinemia of infancy. And whenever we find low immunoglobulins, we should think about secondary causes because we need to have a diagnosis and we need to treat appropriately. So secondary causes include drugs like anti-epileptics or antirheumatic drugs, lymphoproliferative diseases like lymphomas, leukemias, myelomas, and protein losing states. So if you check an IgG of somebody with nephrotic syndrome, you'll find it very low, as well as protein in losing enteropathy and congenital lymphangiectasias. But typically, patients with secondary antibody deficiency do not have infections. Whatever they have works, and they very rarely need treatment for their low levels. Selective IgA deficiency is, as I said, the most common immune deficiency, but it's asymptomatic in most patients. Most people with IgA deficiency don't even know they have it. There is an argument, is it an immune deficiency at all? There is an association with autoimmune disease like celiac disease. Patients with IgA deficiency have an increased risk of atopic conditions as well as blood transfusion reactions. You can have a deficiency in IgG subclasses, usually IgG2 or IgG4, but again, these are more commonly asymptomatic unless the patient has an associated specific antibody deficiency. And that's where a patient over 2 years of age does not respond well to polysaccharide antigens. And we only diagnose it over 2 years of age because naturally, children under 2 years of age do not respond naturally to polysaccharide antigens, and that's why we always give them protein antigens in their primary vaccination. So the common immune deficiencies we see in the pediatric clinic as part of syndromes, we have the Wiskott-Aldrich, which is your typical boy with severe eczema, with thrombocytopenia and bleeding tendency and recurrent infections. They have a combined T-cell and antibody deficiency. The DiGeorge syndrome, so that's your baby with severe congenital heart disease, hypocalcemia, and low T cells. They can have a complete thymic aplasia where their T cells are very low, and in that case, you need to manage them as a severe combined immune deficiency, or a partial T cell defect where they do have a mild or moderate lymphopenia, and you probably just need to monitor those. Ataxia telangiectasia is your preschool child with progressive ataxia, telangiectasia, and recurrent infections. Harper IgE syndrome, the autosomal dominant form, or Job syndrome, so they might turn in your allergy clinic because they have severe eczema, they have very high IgE, they get recurrent skin abscesses, recurrent pneumonias, typically with staphylococcal, and you'll find on x-ray that they have pneumatoceles. They tend to retain their primary teeth, and they have increased risk of fractures. So you've diagnosed primary immune deficiencies, and as we've seen, it's quite a heterogeneous group, and depending on your diagnosis, then you're going to treat. So diagnosis, if it's a mild immune deficiency, you might only just give them antimicrobial prophylaxis or treat them just as and when they get an infection. If it's an antibody or a combined immune deficiency, you will treat with immunoglobulin replacement. If there's a specific cytokine defect, like for example, interferon gamma or its receptor IL-12, you can give interferon gamma or GCSF in neutropenias. Enzyme replacements like C1 esterase inhibitor in hereditary angioedema, or PEG-ADA in ADA skids until you prepare them for the transplant. Many immune deficiencies, for many immune deficiencies, the treatment of choice is a new marrow. So like the severe combined, the chronic granulomatous disease, they do need a transplant. Thymic transplantation is an option for patients with complete DiGeorge. And gene therapy has moved a long way in the treatment of primary immune deficiencies. And it's now available or becoming available for X-linked ADA SCID and X-linked SCID and CGD and Wiskott-Aldrich syndrome. So just looking at immunoglobulin replacement, and the reason I decided to speak a little bit about it is because we get a lot of overuse and misuse of IVIG here in this country. So these are the FDA-approved indications for immunoglobulins. So primary immune deficiency that we spoke about, or secondary immune deficiencies, but specific ones like CLL, multiple myeloma, post-BMT, and HIV in children to prevent infections. And with replacement therapy, we use a dose a lot lower than we do in immune modulation. So in cases of Kawasaki and ITP, or some neurological disorders in children, the most common one is Guillain-Barré, where you use 4 times the dose, and we don't know exactly how it works, but it does reduce inflammation. So what is immunoglobulin? It's a blood product. It's from donors. It's purified plasma. They try to purify IgG. They're screened very well. It's pasteurized and nanofiltered. And the products available are intravenous and subcutaneous that we're trying to get in this country. It's not widely available, although FDA approved since 2006. And now there's a hyaluronidase facilitated subcutaneous, where they give the hyaluronidase enzyme first under the skin to allow more volume of subcutaneous immunoglobulin. And it allows you to space the subcutaneous immunoglobulin more. So looking at the difference between IV and subcutaneous preparations, IVIG you give every 3 to 4 weeks, whereas subcutaneous you can give weekly or bi-weekly. IVIG, obviously you need a line, whereas subcutaneously it's easily given as home therapy while the child is watching TV, and you get less time off school. You get more systemic reactions with IVIG, especially with the first infusion if they're acutely unwell. Whereas with subcutaneous, you don't get a lot of systemic reaction, but you may have mild localized reactions that tend to improve with time. With IVIG, the trough levels tends to go up and down, whereas subcutaneous, you try to maintain it closer to the normal, and the cost and efficacy is comparable. So does immunoglobulin replacement work? This is a study looking at the number of pneumonias per year and IgG trough levels. And you find that the higher your IgG trough level is, the less pneumonias those patients had. So it does work. So in summary, for primary immune deficiencies, what we can do, please think about them. In anybody coming with a serious, recurrent, persistent infection, if they have multiple autoimmune disease or lymphoproliferation with it, look for lymphopenia and neutropenia every time you're looking at a CBC and see if it's persistent. If the patient's coming with recurrent sinopulmonary infections or chronic diarrhea, measure serum immunoglobulin, especially if they have bronchiectasis. If you're suspecting SCID, check lymphocyte subsets, look at your T cells. And if there is a specific pattern, if you have a patient coming with a specific presentation, do that specific test. Like, for example, if you're expecting CGD, do the neutrophil burst. And we are available for consultation. Thank you very much.
Thank you, Dr. Hiba. This is a marvelous lecture, actually very illustrated, very clear, very helpful to us as clinicians. We will open the session for questions. Only 3 questions will be taken because we are in shortage of timing now. Dr. Abu Hamour is waiting for his lecture as well. So we'll take 3, sorry? I am okay. Okay. 3 questions we'll take. Who will start?
I have one question. Yeah. Hi. Dr. Hiba is actually my professor. I'm her resident, and I'm doing the rotation right now with her. I have one question, Doctora. Usually when we suspect immunodeficiencies, these are patients who are in the PICU currently having severe infections. What is the yield of you doing immunoglobulins and lymphocyte subsets? I mean, screening for primary immunodeficiency in the patient who's currently having the infection.
So Judy's question is, if we have a patient in PICU, acutely ill, can we screen them for SCID, for example? How will the illness affect the results? Okay, so immunoglobulins are not acute phase proteins, so they should not be affected. So immunoglobulins are fine. The problem is with the lymphocyte subsets, because if you have an acute infection, they can go up, they can go down. If they're high, we're happy. No problem from an immune deficiency point of view, unless they're persistently high, as we said. But if they're low, Usually in severe combined immune deficiency, they're very, very low. You'll find a CD3 of 10 or 11 rather than 2,000 or 3,000. So it's actually quite clear. But if we find that they are moderately reduced or mildly reduced, we tend to recheck them again in convalescence.
We'll take it actually in details what you have mentioned and said. It means that most of our patients will be referred for immunological problems, because actually we are getting kids who have, you can say, every 2 weeks one infection, which can be viral, which can be, most of the time it is viral, actually not bacterial, and especially when they enter the nursery or they enter their school in the beginning. So how these kids can be helped, and what is from the immunological point of view, what is your advice actually?
Okay, usually whenever we see a patient in clinic and whenever we're writing our note or a summary, we say, we always say what is our index of suspicion of primary immune deficiency. So if it's a child who's getting recurrent runny nose, he's 3 or 4, he's getting recurrent runny nose every 2 months, no real fever, no real pneumonia, no otitis, just a bit of a viral infection, and he recovers, he's healthy, he's thriving. Really, the index of suspicion is very, very low for a primary immune deficiency. Especially the other thing we encounter is asthmatic children, where they do get a lot of antibiotics as part of their asthma. So they come in, they're wheezing, they give them steroids, inhalers, and antibiotics. And they refer to us, do they have an immune deficiency? And we do, whenever, they come all the way, we do evaluate them, but most of the time we don't find anything. Compared to your child who was admitted with pneumonia, after 4 months later with another pneumonia, they've got true otitis, their ear is, discharging, and then you look at them like, oh, there must be something wrong with you.
I'd like just to ask about what families ask us in the clinic if there's any immune booster or any medication or any special diet that can boost the child immunity and improve his status to fight infections.
Okay, well, if you find one, let me know. I don't think there's any evidence that there's anything that specifically boosts the immune system. Whenever I get asked, I said, just be healthy, have a healthy diet, let him be active, exercise, something like that. But no, there's nothing, no miracles, unfortunately.
Or lyophilized bacterial lysis. I think it works for children who don't have. I'm sorry. Thank you. It works for children who don't have immune deficiency disease, just because they are attending the daycare center or they have frequent upper respiratory tract infections. I think it helps. From my personal experience and the INT experience, it helps. This is, I think, what you are. Yeah. Also, they say zinc supplement. Also, it might help. But again, those are not immune deficient patients. They are prone to respiratory tract infection because of the environmental situation that they attend their care centers. Am I right, Dr. Bassel? Thank you.
In case of no other question, then we have to shift to the other lecture. The second lecture will be updates on community-acquired pneumonia. Dr. Walid Abu Hamour, he's a very well-known infectious disease consultant in Al Jalila Hospital, and he's the head of the infectious diseases in Jalila Hospital. Welcome, Dr. Walid.
I would like to thank Dr. Bassel for inviting me to this annual conference, and thanks for the scientific committee as well as everyone who puts everything together to have the second annual allergy pulmonary conference. Thank you again, Dr. Bassel. And I would like you, it is good that you have papers and pencils, so be prepared to the first question. And if you answer the question correctly, I advise you to leave the classroom. If you have one mistake, then stay. We will start with the first one.
The objectives here, we will talk about community-acquired pneumonia from 3 months and above. So we will not talk about neonatal pneumonia. We will not talk about viral pneumonia. And this will guide you to help you to make differential diagnosis, whether to treat the management plan to treat as outpatient, or you can comfortably admit to inpatient or ICU. Also, we'll talk about the guidelines of treatment and when you have to shift the patients from the floor to the ICU and the guidelines for discharging the patient. And if we have time, we'll talk about complicated pneumonias like empyema, abscess, and necrotizing pneumonia. So it is diarrhea, TB, malaria, and pneumonia. Pick one. Next. Oh. The next, if available, a chest X-ray should be done for children with positive pneumonia or possible pneumonia when a diagnosis is made, when a history of tachypnea is present, when antibiotics are prescribed, or when you consider complications of pneumonia. Choose and move. Okay. A 3-year-old female patient presents to you in the office in November. This is very important as ID. It is very important to know which time of the year you are encountering your patients, because certain time of the year associated with certain infection and certain etiological agents. So this is in November with cough and tachypnea. You hear crackles in the left lower lobe and minimal retractions. She is alert, talkative, good energy, no problem with the PO intake, immunization up to date. You have believed patients may have pneumonia and you would like to treat as an outpatient. So choose what you will do first thing to check. Only one. You will do complete blood count, chest X-ray, pulse oximeter, blood culture, or all of the above. Shall I move? Okay, a school-age child who hospitalized with community-acquired pneumonia can be safely discharged. So you have a patient, school child, school-aged, admitted to the floor. When you will discharge the patient? And this is a frequent question I'm getting every day. When we can discharge the patient? So it's very important to know if you have community-acquired in the floor, when you will discharge the patient. Of course, he will be able to take PO and antibiotics and fluids. This is given. Febrile for over 24 hours. Pulse oximeter measurement more than 90. In room air more than 12 hours. 1 and 2, 1, 2, and 3. Pick and choose. Move in. Okay. Previously healthy 2-year-old diagnosed with pneumonia. Faint crackles in the right lobe. Also in late October, this is important. Respiratory rate is 30 per minute. Temperature is 38.5. She has received all immunizations, and this is very important always to ask about if the child up to date in vaccines or not. Very important to ask if the child attending the daycare center or not. These very important questions always we have to ask. She is interactive and drinking well. Which oral antibiotics you would like to choose? Just read them and pick one. And Dr. Basil, let me when I have to move. You have to answer. Okay. This is Dr. Basil's fault. Move. توكل على الله move. A fully immunized 6-year-old boy is hospitalized for pneumonia. Radiography demonstrates left lower lobe consolidation without an effusion. So just consolidation, no effusion. He has 92% oxygen saturation on 30% FiO2. Some retractions and poor oral fluid intake. A blood culture is obtained. What the first line antibiotic therapy is recommended? Pick and choose. You know, these are very practical cases you encounter daily on your practice, right? Whether in the clinic or you have to admit the patients. Always daily we encounter. So it's good to know. At least, you know, this is give you guidance which one to choose when you have to discharge, when you have to admit. Move. A 5-year-old is admitted with right upper lobe pneumonia. Child is not fully immunized. It's very important here. His blood culture yield Streptococcus pneumoniae. Susceptibility testing on the blood isolate demonstrates a penicillin MIC more than 4 microgram per ml. So what's the appropriate antibiotics you would like to choose for this patient? This is highly resistant penicillin strep pneumo, right? Pick and choose and let me know if I can move. Move. Dr. Basil is not answering, but he's saying move. Okay, I'll move. Okay. So you got it correct? Huh? Hopefully? Okay. So the introduction. In this 30 minutes or 20 minutes left, I'll talk about the revised guidelines of management of community-acquired pneumonia. And the IDSA and Pediatric Infectious Disease Society convened many subspecialists and consultants in infectious disease and reviewed many studies and published papers on community-acquired pneumonia 3 months and above. And they came up with guidelines. These guidelines also endorsed by the American Academy of Pediatrics and other medical societies in the United States. But let me tell you something, and this is important either for this talk or other talks. Guideline is guideline. This will not replace your clinical experience and your own clinical judgment. Because I have seen this many times, they say, this is the guideline. But okay, but the guideline, always the patient does not go by the book. So your clinical input is very important. This will not replace your clinical input, but it gives you roadmap, guidance, how to manage, how to treat. And this is true for every disease, not only for this lecture. And this is, if you would like to refer to the published article about these guidelines, this is in a clinical infectious disease by IDSA. All of you know the classifications, strong recommendation is moderate recommendations or weak recommendations. Okay, we'll talk about the pneumonia, and all of you are familiar. This is lobar pneumonia, this is bronchopneumonia, and this is the normal lung. And look here, the abnormal lung with gray hepatization, which is stage 3 in the pathology, filled with the neutrophils, fibrin, congested vessels. So definitely, if you look under the microscope, this is abnormal lung. The epidemiology. Okay, pneumonia is the single most killer in children worldwide. Who got it right? Who got it right? Raise the hands. How many? 10% maybe? 5%? Okay. I'm so confident that most of you choose diarrhea, right? It is pneumonia. Actually, it is. They estimated more than 2 million children die from pneumonia every year. And in 2007, among 9 million children who died, around 2 million from pneumonia. So pneumonia is very important. And that's why Dr. Basil, he picked this topic for me. Okay. So the epidemiology we know now is pneumonia number 1. Regarding the etiology of pneumonia, across the board, viral infection is the most common etiology for pneumonia. It's around 80 to 85% of all pneumonias are due to viral infections. Around 20% only bacterial infections, but unfortunately, antibiotics prescribed for all cases of pneumonias. I would say maybe 90%, though 85% due to viral infection. 3 months to 5 years, viral pneumonias is the most common, but strep pneumonia also to be considered. 5 years and above, still viral pneumonias are the most common. However, you have to consider atypical when it comes to the age school children and strep pneumonia. Other bacterial infection like Staph aureus, group A strep, TB, fungal, also this is in specific conditions. Fungal infection like histoplasmosis in immune competent child, it resolves spontaneously. So fungal infections in immune competent person does not need a treatment. General clinical features. Most of them, bacterial infection, they look ill. Fever, almost present in 90% of the cases of bacterial pneumonia. And it is important, it can be the only manifestation of pneumonia. It's very important to note this. If you have a child with persistent fever and you can't explain what, it is good to do chest x-ray because it might be pneumonia. So it can present only with fever. Cough, also not in everyone, but usually in the majority, around 70% they have cough, and usually productive in older child. Tachypnea in 2/3 of the patients. Retractions, emesis, abdominal pain in 20%. Recently, we had a patient, he had URI symptoms, thinking this is a viral infection. He was given PO antibiotics by his primary. Still, he had the runny nose, but later on, he had severe abdominal pain. So he was admitted in one of the hospitals for 1 week to rule out surgical cause. And then they did ultrasound and CT abdomen, and parents told this is appendicitis, but when they found the CT, they could see fluids in the lung. So they did chest x-ray, and it was horrible pneumonia with empyema. And the main manifestation was right upper quadrant pain. So be careful, right upper quadrant pain, it could be manifestations of pneumonia, lower lobe pneumonia. Pay attention to this. This is a study, they looked to 254 children. I don't know how they say children, though the upper limit of the age is 26 years. But anyhow, 254 patients with strep pneumo, whether it is from the blood culture or the pleural fluid. And they look at the main common symptoms. And you can see fever in 90%, cough in 70%, and this is important. So 30%, they don't have cough. So you have to put everything together. Tachypnea in 55, decreased air entry in 55, crackles, less, retraction, even lesser, grunting, emesis, and abdominal pain in 20%. So if you look at this, really you could find all the symptoms and signs in one patient. So the high index of suspicion is very important for making the diagnosis of bacterial pneumonia. Outpatient diagnosis. Routinely, chest X-ray, CBC, ESR, C-reactive protein, procalcitonin, which always done for every patient coming to the emergency room with bacterial pneumonia, is not recommended. If you think this patient can go home, either observation because of viral pneumonia or oral antibiotics, don't do any. If you think the patient does not need admission, it's not recommended at all. It is waste of the resources. Pulse oximetry should be done in every patient. So every patient whom you think has pneumonia, it is very simple, non-invasive, and very informative. Check the pulse ox. Who got it right? Again, maybe 5%, which is good. So pulse oximeter, whether you are in the clinic or the emergency room, just ask the nurse, please check the pulse ox. If it is 99, 97, 98, this is very reassuring. If it is less than 90%, then you have to scratch your head. So don't jump on the chest X-ray or blood cultures or whatever, or CBC. It will not be helpful at that point of time. The most important, which is feasible to be done, is pulse oximetry. If available, which is very important, nowadays we have the BioFire in our hospital, and most of the hospital, they have what's called point of care testing. The rapid testing for viruses is very important. It takes around 3 hours with the BioFire, but it tells you this is influenza, para-influenza, meta, RSV. So the family will be reassured, will be comfortable that there is an etiology for it, and also you will be more comfortable to discharge the patient if he doesn't need admission. This is influenza, right away you give him Tamiflu and send home. This is para-influenza, reassurance, and go home. If you think this is complicated pneumonia, this is another story. Inpatient criteria, when you have to admit the patient. Of course, 3 to 6 months, if you think bacterial pneumonia, admit. And this is very important because I have seen kids 3 months, 4 months discharged on PO antibiotics coming back with complicated pneumonia. So it is recommended to admit 3 to 6 months, which means neonatal to 6 months, whom you think this is, you did chest X-ray, consolidation pneumonia, regardless how the patient looks to you, admit the patient. Patients whom you think, and I don't agree totally with this, and most probably you don't agree with this guideline, it is not only MRSA. Staph aureus pneumonia or Staph aureus positive blood culture, I will admit. I will not discharge patients with Staph aureus pneumonia from the chest X-ray. If there is rheumatoceles, a little bit of effusion, and whom you think from the image of the chest X-ray, this is Staph aureus, I will not discharge the patient, whether it is MSSA or MRSA. Do you agree with me? Anyone would discharge anyone with Staph aureus pneumonia? Not to admit? I will not be courageous not to admit. Because Staph pneumonia, it's very bad. And if you don't treat, it will be localized somewhere with septic arthritis or endocarditis or osteomyelitis. And the lung will be horrible also from the Staph aureus. I don't agree that only MRSA. If there is respiratory distress, you have to admit. Concern, also follow up. And that's why, sometimes you will be questioned by the CRM or the social nurse or the insurance, why you admitted this patient. If I have a patient from Ras Al Khaimah coming to me and I think this is bacterial pneumonia, easily can be treated outpatient, but I'm concerned about the follow-up. Follow-up means to see him within 48 or 72 hours, because if there is no improvement, you have to admit the patient. So it is not totally safeguard, given the antibiotics can go home. You have to bring the patient in 48 hours to check if there is improvement or there is no improvement. So again, this is personal call and judgment. Patient medicine is most of the time in the gray zone. It is not white and black. And of course, if the pulse oximetry is less than 90% on room air, admit the patient. Criteria for respiratory distress, all of you are familiar with the criteria and the definition of tachypnea. I will not talk about it. And dyspnea, you are familiar with it. Okay, these are for the medical students, not here, all of you, you know it. Inpatient workup, okay. We decided to admit the patient. What workup we will do? Chest X-ray, 2 views. Sometimes there will be argument with the radiologist, they do 1 view, and if it's abnormal, they'll do 2. Most of the time I argue with them, and I told them, whenever I order myself, khalas, 2 views. It is recommended 2 view because with 1 view, you may miss the infiltrates. And it's good for the hilar lymphadenopathy with the lateral chest X-ray. Dr. Razwana here, right? And Dr. Basil here. Pulmonologist here, Dr. Muhammad. I don't know, maybe they are not here. You agree with me, Dr. Basil? Okay. Definitely we'll do CBC, blood culture, ESR, and chest X-ray. If we can get a sample of sputum, we will send. If the patient intubated and then this is an ICU, we'll take deep tracheal suction. Urine antigen for strep pneumo, don't do it. It is useless. So no more you have to order it, and it is an obsolete test. In patient diagnosis, we talked about it. Would you repeat chest X-ray routinely? Anyone would repeat? No, it is not recommended. As long as the patient is improving, you don't have to repeat. Because I have seen also, this is a practice, common practice, bacterial pneumonia, and 2 days repeat the chest X-ray. It is waste. If he's clinically improving, don't repeat the chest X-ray. If blood culture showing whether MRSA or not MRSA, you have positive blood culture, Staph aureus, I myself would repeat the blood culture. Anyone would not like to repeat blood culture with Staph aureus? All of you will repeat, right? So again, guideline is guideline. You have patients with Staph aureus in the blood, whether MRSA or MSSA, I would repeat the blood culture to make sure it's clearing. You agree with me? Good, at least you agree with me. The others, as long as the patient is improving, I'll give it time. Usually 48, 72 hours. If you repeat it in 24 hours, it will be positive. Staph aureus, it takes time to clear it from the blood, not like other agents. So wait for 48, 72 hours, and then repeat after the appropriate antibiotics. Because what happens, sometimes the patient not on the right antibiotic, they repeat the blood culture is positive, and then they will add another antibiotic. So I have seen, I'm sorry to say this, patients transferred to us on 4 antibiotics, and the patient is not improving. And usually I go back to the first 2 antibiotics that already was given from the previous hospital. So the point here, your patient is not responding, not always because of the failure of the antibiotics. It's not. Because you have to look at the pathology. Maybe because of folliculated empyema, because of necrotic pneumonia. That's why the patient is not responding. Not because of the antibiotics. You have to have other modality of treatment, like surgical intervention. I have seen patients with pneumonia, Dr. Rizwana can share this with me, 4 antibiotics and antifungal. I have seen, wallah, it can happen, everywhere it can happen, not only here, worldwide it can happen. So this is the inpatient diagnosis. Assume it's strep pneumo blood culture, would you repeat? No need. Other than Staph aureus, don't repeat. We are talking about healthy children. Remember, healthy children. We are not talking about Dr. Hippa's patients, immune compromised, okay? Or fungal infection or gram-negatives or whatever. We are not talking about those patients. Those are different story. Here, CBC, if it is less than 15,000, it is reassuring that most probably it is not bacterial infection. Bilateral infiltrates, usually it is not. Most probably is viral infection. However, if you find big consolidation, this is bacterial infection. If you find effusion, most probably it is bacterial infection. Atypical infection, rarely to give you pleural fluid, though it can happen very rarely, but it will be small amount, not really big pleural effusion. So chest X-ray can guide you what etiology, viral, atypical, or bacterial. Criteria to admit to ICU. Okay, you have your patients in the floor or in the emergency room and you decide to admit either floor or the ICU, or in the patient and you decide to admit to the ICU. The criteria, if there is no good response in 72 to 48 hours, which means still the patient's retracting, still requiring oxygen, he might need CPAP or BiPAP or intubation, you have to send him to ICU. If you did X-ray and multi-loculated empyema, send him to the ICU. If it is acute necrotic pneumonia, send him to the ICU. So these are the indications. If the patient's on oxygen and FiO2 less than 92%, providing you are giving him 50% or more, don't keep him in the floor. Send him to the ICU. So clear indications when you have to transfer the patient. Otherwise, it will be deviation from the standard care of treatment for your patient. So you have to be careful about this. If you have immune-compromised patient, comorbidity, sickle cell disease, diabetes, whom you think this is not normal host, it is good to be in step-down or high dependency area or what's called intermediate area. Okay, discharge criteria. I would like you to remember the magic number 12. Okay? Improved clinical status more than 12 hours. Okay. Room air more than 12 hours. Chest tube out more than 12 hours. And he can take, of course, PO intake, able to tolerate. So remember more than 12 hours. So anyone get it right from the questions? If you remember that, afebrile, this is the right, afebrile 24 hours, right? This is wrong. So remember 12 hours. To be honest with you, and practically, we don't follow this. Anyone follows this? Usually we'll say tomorrow, 24 hours afebrile, right? But this is the guideline. So it depends on your case, you have to judge. But the guidelines is more than 12 hours, not 24 hours. Anyone would discharge patient chest tube removed in less than 24 hours to observe? No. So would you discharge? You have a patient with chest tube and chest tube removed in the morning. The parents would like, yeah. So this is the guidelines, and remember, these are experts on the field, and they reviewed tons of papers. So it means, but clinically we, not I would say most of the time, but quite good number of the time, we treat ourselves to be, as patients, as physicians, to be satisfied. No, wait another 24 hours. Am I right or not? 5 minutes? Oh, more than enough. Outpatient treatment of pneumonia. If you think this is community-acquired pneumonia, okay, the patient does not need treatment, so just give him what you would like to give him. This is bacterial pneumonia. Patient does not need admission. Healthy child, fully immunized, can tolerate PO. What's your first choice of antibiotic? Huh? Amoxicillin. What's the dose? Very good, excellent. So the first choice is amoxicillin 90 milligram per kg per day BID. This is providing that in your area there is no high resistant level of strep pneumo. If it is more than 2 and less than 4 and the patient can go home, I'm not talking about the patient himself. I'm talking about in your area and or the hospital, you give high dose 90 milligram, but instead of BID, TID. So it's always too good to know what's the antibiogram in your hospital.
But what's the resistance here in the UAE in general for strep?
It is the high resistance is less than 10%. This is from Latifa Hospital because at Al Jalil still we cannot generate antibiogram. I don't know about Rashid Hospital, but this is my speculation. We don't have high level resistance in our area. We have intermediate, but we don't have the high level. However, we have a patient right now in X hospital. They consulted me with strep pneumomeningitis, MIC more than 4. MIC more than 4. Meningitis. And the patient is not doing well. Okay, very good. So if you admit the patient, and you admit the patients to the floor, fully immunized, no comorbidities, what's the first choice for you? Antibiotics. Usually what you do, Augmentin, because you think this is Staph aureus. Yeah, to be honest with you, it is a tough call. If you have a child who is healthy, he is healthy, fully immunized, the level of resistance it is not high in our area. It is just pneumonia, not complicated pneumonia. I will give ampicillin. Because what's the most likely etiology in this patient? Strep pneumo, right? The same patient, you did chest X-ray and you think, oh, there is pneumococcal. What's your choice now? Huh? Pneumococcal, I would say, yeah, we are dealing with Staph aureus. So I have to cover Staph aureus. At this point in time, now we are talking about most probably complicated pneumonia. Still, you can give ampicillin plus anti-Staph aureus coverage. They say if you have really complicated pneumonia, like empyema, loculated empyema, necrotizing pneumonitis, you may go to the third generation cephalosporin, ceftriaxone or cefotaxime, and you cover for staph. So the usual regimen with complicated, again, don't misunderstand me, with complicated pneumonia, usually the third generation cephalosporin plus anti-staph coverage. I generally, or not generally, all the time, though the guidelines say vancomycin, my advice to you, don't use it. I will go with, really, if clindamycin is a choice, if not terribly sick. However, Staph aureus resistant to clindamycin from the antibiogram Latifa Hospital to clindamycin is it's 16%. So the recommendation in general, if the level of resistance to Staph aureus for clindamycin more than 10%, and you are encountering severe infection with Staph aureus, the recommendation not to use clindamycin. So the option here, vancomycin or other antibiotics. I don't use vancomycin, and I have patient transfers from other hospitals that failed, vancomycin failed, okay? Simply because the penetration to the lung is not that the best. Comparing, for example, I'm not saying commercial statements, comparing to linezolid or teicoplanin. The lung penetration is way much better than vancomycin. 2, you don't have to do levels. We have problems with the level of the vancomycin. I have kids whom I have to raise to 100 milligram per kg, and the level is still suboptimal. We have problem with the vancomycin, but particularly in the lung, the penetration is not really great. 5 minutes gone? I will answer the questions best. Okay. We talked about this. Just one word about empyema. You have pneumonia and empyema. I would recommend ultrasound. Ultrasound is superior to the CT scan. People, they jump to the CT scan thinking that CT scan is more informative than ultrasound. This is not true. Ultrasound is superior to the CT scan. It gives you the fluid, consistency of the fluid, the size, loculation. It's very good. If you think of necrotizing, ultrasound also it can give you, but the CT scan also would be helpful. In general, the management of complicated pneumonia with empyema and effusion, you have to consider 3 things. And then you have to consult the surgeon. You look at the size of the pleural effusion. It is a small size, and the definition less than 10 millimeter of the opacity of the lung, or less than, or 1/4, less than 1/2, or more than 1/2. So you look at the size of the effusion, plus you look at the clinical picture of your patient. There is respiratory distress, yes or no, and then you will look at the complications. You are dealing with large empyema, loculated. The patient is really not doing well. So the small you will leave alone. The moderate, if there no respiratory distress, you have 2 options: either chest tube or leave him alone. If he develops complications, you have to do chest tube with fibrinolytic agents or without fibrinolytic agents. The large lobulated empyema, you do first choice, chest tube with fibrinolytic agent. You wait and see if there is no improvement, you do VAT, or certain people, they go to VAT right away. So these are the general guidelines for the empyema. Again, this is a frequent questions. For how long we have to treat? And this is always they ask me, for how long we have to keep the patients? Generally 2 to 4 weeks, but not all of them IV. And they say 10 days after the fever. 10 days after the last fever, then you can discharge patient to complete 2 or 4 weeks. It depends on the situation. If you have necrotizing pneumonitis, I will go with 4 weeks. If it is simple empyema and that's done and everything is fine, total 2 weeks will be great. 1 week IV, 1 week oral antibiotics. So this is the general, but it is variable from one patient to another.
Thank you, Dr. Abu Hammour.
I think I answered all the questions, right?
Yeah.
Yeah.
All of them. Okay, thank you so much.
Do we have time for questions?
No time for questions?
2 questions. Yeah.
2 questions. Dr. Basil, don't ask me, huh? By the way, I am his uncle. He's my uncle.
I'm proud to have you as my uncle, Professor Abu Hammour. I will share with you a very interesting case regarding complicated pneumonia. I have a patient admitted, referred from another hospital for complicated pneumonia. On the X-ray looks like nematocele with necrotizing pneumonia on the CT scan. We decided to start the child on Rocephin, and instead of vancomycin, we went for linezolid. We were happy with that choice. Let me tell you what happened later. The child, she was 12 years old, improved quickly. Her fever disappeared. Oxygen was weaned. She was on 10 liters, and she was discharged home after 48 hours of this treatment. And we decided to send her home on linezolid orally. We were able to find it here in UAE. I mean, yes, in the American hospital, we gave her, and she's improved, went home. I've seen her after 3 days, as per recommendation. On day 3, fever started to come back again. We repeated the CT scan to see if there's any accumulation of fluid in Paima pus, and the CT started to show worsening. So we were puzzled, really. How did she improve? And suddenly she's getting worse and worse. 72 hours discharged, yeah. Yeah. The issue here, so we thought we reviewed our diagnosis again, because at the end we took her to bronchoscopy, and we were surprised the culture to come back TB, tuberculosis. The message I'm trying to tell here, linezolid has anti-TB effect. So if it treats TB, but it doesn't treat TB in the best way. So the child improved in linezolid not because of the staff, improved because linezolid has some anti-TB effect, but because not the optimal treatment of TB started to get worse later. And then we have to stop all these antibiotics and start her on 3 anti-TB medication. So if you want to use linezolid, my advice, make sure it's not a TB.
Thank you so much for sharing this very interesting case with us. Again, I'll go back to the basic rules in medicine. Nothing will replace good history and generation. If we just go one step extra and ask always any contact with people, etc., we might find another. There any
the main 4 years ago, the main was that.
You see, the family, because we didn't ask them. Usually we don't ask, this is pneumonia. The other message from Dr. Bassel's case, which is very important, I don't have time to, TB can mimic anything in the world. So always, in the back of your mind, tuberculosis. Particularly, in endemic areas. In endemic areas, always we have to ask about contact with TB or anyone has been treated for TB.
Last question, please.
I have an argument and have a comment. So, Dr. Walid, I have to argue with you. So for chest X-rays for kids with pneumonia, frontal view can be enough and has very good sensitivity of 97% on some of those studies. If you compare only frontal or frontal and lateral views. So most of the time you will get lots of good results with only frontal. I mean, because most of the pediatricians, they do excellent history and physical examination. If they use their hands on physical examination, they will get it right. So if they percuss, I think they will know before the X-rays. And sometimes I've seen it that some of the pediatricians said, no, it's worse now more than the X-ray, and they repeat X-ray in a day, and it's really worse. So frontal view alone can give you a really good thing. The other thing is about TB. Although we're not labeled as TB endemic areas, but because we have lots of people coming from outside, Department of Health, they did an auditing over 1 year, and they found they catch more than 1,000 patients with active TB. So this was through the visa screening. And you will imagine those who has TB, they are the majority, or a big chunk of them are those who are domestic workers. They work in the beauty salons, they work in the daycare, they work at our homes, they're drivers. So you need to be really vigilant about this, about TB. Doesn't cross our mind, we don't see it that much, but it is there. And my colleague who see lots of TB patients in his clinic, like every now and then he'll tell me about this family who had a maid. The maid has an open active TB, and now they have to screen the whole family. So we need to keep it in our mind.
Thank you, Dr. Muhammad, for your argument. Well taken. And Dr. Muhammad is an expert in pulmonary field, pulmonologist at Tawam Hospital. This is an argument, I said the argument me and the radiologist. With TB, Dr. Muhammad, you will be satisfied only when with one view? If you think this is TB, you order just one view?
So one view will show you, with the view you would like to know if there is any pulmonary TB, and you can see if there is any paratracheal lymph nodes. So paratracheal lymph nodes, especially we're talking about the right paratracheal stripe. If it is really enlarged, you will see it very well. You know that there is enlarged lymph nodes. And then if you're going to start a treatment, doesn't matter. I don't think you need to do a CT. You start the treatment and see, how is the progress.
Again, the infectious disease people, they have different views. When it comes to TB, strongly recommended 2 views because you might overlook the hilar or perihilar lymph nodes. But again, this is medicine, Guideline. At the end of the day, it's your judgment. Thank you so much, Dr.
For us, the pediatrician, we always choose 2 views, actually, to be honest, and we order 2 views to be on the safe side and to be sure of it. Thank you very much, Dr. Hamour. We appreciate it. Thank you.
We would like to welcome now Dr. Rizwana, who was so patient with us. She's the consultant pulmonologist at Jalila Hospital, and she trained for pediatrics and pulmonology in the U.S., New York, and Boston Children's Hospital, Harvard University. She will talk to us about aspiration pneumonia. So welcome, Dr. Rizwana.
Hi. So I'll try to, I'm cognizant of the fact that we are running short on time, so I'll try to condense it as much as I can. And if I'm going too fast, feel free to stop me. But let's see. By the way, I'm Rizwana Papati. I'm one of the pediatric pulmonologists at Jalila Children's Hospital. And the topic I'm supposed to present today is aspiration lung disease, evaluation and management. So the outline of this talk is we are looking at various types of aspiration. So first is a foreign body aspiration. Then we will do aspiration pneumonias, aspiration of liquid and food. Now this can be a large volume aspiration or recurrent small volume aspirations. And then we have aspiration of hydrocarbons. I think for the time limitation, we can skip the hydrocarbon aspiration for today. Let's look at the foreign body aspiration and some of the interesting things which we can remember. Epidemiology-wise, so majority of these patients are under 3 years of age. So usually your toddler age group. 90% of them are less than 3 years, and 80% of them are between 18 months to 3 years. 2/3 are boys. And usually these are your toddlers because they lack discretion, they have this oral exploration phase, they lack molars to chew the food properly, and they tend to play while eating. 90% are food and toys. And latex balloons are the leading cause of choking-related death. So in your clinics, if you are fond of giving those latex gloves to parents to make balloons out of them, please be careful about that. Hot dogs are the most fatal food. And the high-risk characteristic of food which are prone for aspiration, they are cylindrical, airway-sized, and compressible. So your grapes, your hot dogs, these are the most common foods which can cause foreign body aspiration. 80% of symptomatic foreign body aspiration are the result of peanuts. So most common is peanuts. There was a paper which was published in 2003 in Pediatrics which looked into fruit gel snacks being the new peanut causing aspiration. Hot dog is common for upper airway and esophagus foreign body. Many causes of aspiration are not observed, resulting in delayed diagnosis because we are not following these kids everywhere. Recognize retained foreign body as an etiology for recurrent pneumonia. So again, a very important thing to look for in kids who presents to you with recurrent pneumonia and who kind of fits into the age group. Coming to the pathophysiology of foreign body aspiration, a laryngeal impaction like hot dogs or balloons, they're kind of stuck at your larynx and they can cause immediate respiratory arrest and they are responsible for highest mortality rate. Whereas majority of the foreign bodies like peanuts and fruit gel snacks and all these vegetables and all these things can enter your tracheobronchial tree. Right mainstem is more common because it is shorter and broader and it's easily accessible. So what happens to the distal lung, either the distal lung could be overinflated because of the ball valve mechanism. So if the foreign body is partially obstructing the airways, so air is going in, but it's not coming out. So with every breath, you're taking the air and you get inflammation of the distal lung, or there is an resorption at atelectasis and you get underinflation of the distal lung segment. Hemoptysis may occur because of vascular hypertrophy and erosion due to chronic inflammation, specifically for veggies, and it can also, the foreign body can directly injure the bronchial mucosa. So this is, you can see here, different types of x-rays for foreign body inhalation. You can see hyperinflation of one side of the lung. Again, the pathophysiology includes acute paroxysmal coughing, and there is a lag period because the sensory receptors undergo adaptation and they're present with complication of aspiration. It may lead to focal bronchiectasis through airway obstruction and post-obstructive foreign body inflammation. Esophageal foreign bodies may produce airway obstruction by transmitted pressure through the posterior tracheal wall. And at-risk population are your infants. Post-esophageal surgery patients are at risk. So if you have a tracheoesophageal fistula patient who has been operated, that patient is at risk. If you have an esophageal atresia patient who has been operated, that patient is at risk. And kids with eosinophilic esophagitis can also present with foreign body-like symptoms. History, to be careful whether it was witnessed or unwitnessed. Cough. So foreign body can present with anything, like, cough, stridor, wheezing, hoarseness, fever, and dyspnea, depending on the location of the foreign body. Absence of symptoms does not rule out a foreign body. Only 2/3 of patients seek treatment within 1 week of the event, as per the recent papers. Frequently misdiagnosed as croup, viral URI, recurrent wheezing can be misdiagnosed as asthma. Physical exam can be normal. You can see variable degree of respiratory distress, again, based on where the foreign body is situated. And lower airway, classically, you see focal diminished breath sounds with inspiratory rhonchi. Upper airway, you see hoarseness or stridor or aphonia, and rapid changes may occur due to changing position. Now, coming to the imaging, so you tend to do neck and chest radiographs for kids you are suspecting foreign body aspiration. Only 10% of foreign bodies are radiopaque. So look for partially obliterated air column, or you can look for secondary signs, which could be pneumonia, atelectasis, compensatory emphysema. And inspiratory and expiratory views tends to give you unilateral hyperlucency on the expiratory film or possible mediastinal shift. So normally when you do an inspiratory film, it should be more black because of more air. An expiratory film should be less black because of, it should be grayish because of you're expiring the air out. But if there is a foreign body in one of your airways and distal lung segment is overinflated due to ball valve mechanism, you can see hyperlucency on expiratory films. Decubitus films or fluoroscopy can also show unilateral air trapping 25 to 50% of the time. So 1 out of 4 or 1 out of 2 times, those x-rays are normal. This is again a lateral decubitus view where the dependent part shows hyperinflation. Complications of foreign body aspiration can present with recurrent or persistent pneumonias. They can present with bronchitis, bronchiectasis. And what happens after removal of foreign body? You can have pneumothorax, pneumomediastinum, or post-obstructive pulmonary edema. And this is very important to know why you should look for post-obstructive pulmonary edema, why it is essential to observe the kid in a HDU or even in the wards after removal of foreign bodies. And this is because when there is a sudden increase in negative intrathoracic pressure, as the patient is breathing against an obstructed airways. So your airways are obstructed, now the kid is breathing against that obstructed airway, it leads to an increase in venous return and decrease in cardiac output. And the fluid transudates into the alveolar space and it causes pulmonary edema. So very important to observe for post-obstructive pulmonary edema. Coming to the therapeutic approach, very, very important, no chest PT, no bronchodilators, because it poses the patient at risk of foreign body migration. If you give chest physiotherapy, either you push it down or you push it at the junction of the airways or carina, and that could be fatal. And if you do bronchodilators and chest PT, it can also cause vagal-induced arrhythmias. To the operating room after getting emptying if possible, general anesthesia, no positive pressure ventilation. Again, you'll push the foreign body down. Spontaneous breathing, rigid bronchoscopy, and you get a lot of cool tools available these days. There is little role for flexible bronchoscopy for foreign body removal. Studies have shown that bronchoscopy is effective in greater than 95% of the patients with a complication rate of less than 1%. And here you can see this pieces of peanuts from the bronchus. After removal, you suction past the level of obstruction. You leave granulation tissue alone. It resorbs by itself. You don't need to fiddle with the granulation tissue. Indications of thoracotomy are rare if it is a major impaction or there are severe chronic inflammatory changes and there is a risk of bleeding. So if there is hemoptysis, then you need to do thoracotomy. Consider steroids, consider antibiotics, and chest PT post-procedure management to avoid or treat pneumonias. Rescope if symptoms persist for more than few days. And this was in Pediatric Review in 2000, which is almost 20 years old now, but it still holds true. As long as children have mouths and their world contain objects that fit into those mouths, foreign body aspiration will occur. The only way to reduce the number of associated deaths is through public education and legislation. So the number of this foreign body aspiration is not going to decrease unless we have widespread education about it. Now coming to the second types of aspiration, which is aspiration of liquids and food. This does not happen normally. It happens in predisposing disease states. Like you don't, neurologically normal individual would not aspirate liquids and foods on a regular basis. So it's either you have some predisposing conditions such as prematurity where there is coordination issues, you're sick for whatever reason, you have RSV bronchiolitis, for example, and you have tachypnea, respiratory distress, and then the kid can have coordination issues and swallowing fatigue. And studies have shown association of aspiration risk with RSV bronchiolitis. Bottle propping, if the bottle is propped in a vertical position, that can also lead to aspiration. Anatomic abnormalities, such as choanal atresia and stenosis, tracheoesophageal fistula, laryngeal cleft, all this can prone the patient for aspiration of liquids and food. Aspiration is the primary cause of lung injury with tracheoesophageal fistula, to be kept in mind. Kids with syndromic issues such as Down syndrome or trisomy 18, macroglossia, micrognathia, all can prone the kids for aspiration. Palatal remodeling secondary to prolonged intubation, very, very important to keep an eye. If the patient has a history of being ventilated and intubated for a month, very high risk for aspiration because of palatal remodeling. Again, neurological abnormalities such as perinatal hypoxemia, congenital hydrocephalus, or interventricular hemorrhage, recurrent laryngeal nerve injury due to some sort of surgery, brainstem abnormalities, and neuromuscular disorders such as spinomuscular atrophy, Cornelia de Lange syndrome, or myotonic dystrophy. All these neuromuscular issues, prematurity, anatomical defects, and primary or secondary swallowing disorders can make the patient prone for aspiration of liquid and food. Now, I'm not going to go into details of this, of distinct phases of swallowing, but on the top you can see the diagram of the mouth and pharynx of the adult, and on the bottom you can see that of the kid. There is, I don't know how to point out. So here you can see there is a laryngeal descent. So larynx is lower in adults compared to the child, and here you can see the soft palate and epiglottis are touching each other in an infant or a child. The soft palate and the epiglottis are touching each other, whereas in adults, you can see the soft palate is here, and then your epiglottis is here. So as you become mature, your swallowing becomes mature, and there is laryngeal descent, which makes us less prone for aspiration compared to the kids. So as I said, there are normal protective mechanisms. Because of lack of time, I don't think we need to go into details into this, but interesting thing is, like, viral infection can cause the adult pattern. What happens in adult, if you choke on something, say it goes into the wrong route, like you're drinking water, you cough and then you swallow. So that is an adult pattern. You revert to the immature pattern. So in infants, what happens, they become apneic. So you stop breathing because of chemoreceptor and vagus nerve and all those sensitizations. So when they have viral infection, even a 3-year-old, a 4-year-old, a 5-year-old can go from the adult pattern to the immature pattern. And instead of exhibiting cough and swallowing, they revert to apnea. And as I mentioned, in infants, you have a position of epiglottis and soft palate, which puts you at more risk for respiration. Again, I'm not going to go into details about this. Let's talk about inspiration-induced lung injury. So it can be a complication of general anesthesia. In 1 out of 2 to 3,000 general anesthesia, you can get aspiration-induced lung injury. Trauma and ICU patients with altered mental status at very high risk of aspiration. Secretions, blood, bacteria, liquids, food particles, anything could be aspirated. And then what happens when you have aspiration-related lung injury, you have mild subclinical pneumonitis, which can progress very rapidly to acute lung injury or acute respiratory distress syndrome. And then the kid can have progressive respiratory failure. And the kid can be revived out of all these complications, but they are left with the fibroproliferative chronic lung injury. They are left with fibrosis because of aspiration-related lung injury. So it needs to be very careful in ICU in post-anesthetic patients too. Now coming to the third types of aspiration. So we looked at foreign body aspiration. We looked at aspiration of large volume of liquids and solids as can happen in neurological impaired patients post-anesthetic. Now we are going to look for aspiration of liquid and food, large volume aspiration pathophysiology. So severity of lung injury is determined by the pH and volume of aspirate. So large volume is 1 ml per kg. In dogs, 2 ml per kg can cause death. pH closer to 1.5 results in greatest injury. Large particles can cause acute airway obstruction and then hypoventilation, right? And CO2 retention. Now, smaller particle or liquid can cause hypoxemia. So you have reflex airway closure, you have pneumonitis, destruction or dilution of the surfactant can lead to atelectasis, and post-obstructive pulmonary edema, as I explained earlier. So this is the pathophysiology of large volume aspiration. So it depends on the pH of the aspirate and the volume of the aspirate. Acid aspiration can cause more rapid changes. You can get atelectasis within few minutes because the acid destroys the surfactant in your lungs, and that can lead to resorption atelectasis. We will not go into the histological findings, but they usually damages your type 1 and type 2 alveolar cells. And as I said, like, in animal models in 2 to 3 weeks, when you have large volume aspiration, even though the aspiration causing agent is removed, you treated the pneumonitis with good antibiotics, you give good ventilatory support to the patient, you can still end up with parenchymal scarring and bronchiolitis obliterans. And I've seen few patients post-ARDS having BO or fibrosis of the lung. And that is aspiration-related injury. We will not go into the physiological changes, but you can see this is acute inflammatory exudate. You can see here all this is acute inflammatory exudate in the bronchiole and surrounding alveoli, and you can see the fragment of aspirated vegetable material in the lumen of the bronchi. This is airway-centered fibrosis. Fibrosis around the bronchioles is a typical manifestation of aspiration injury to the lungs. Coming to the complications of large volume aspiration, as we all can anticipate, you can get secondary bacterial pneumonia, right? Because there is foreign body in your airway. Risk factors are gum and dental disease, tube feeds, because if the tube is dislodged, instead of going into the esophagus, it can go into your airway, intubation and tracheostomies. Patient presence with witnessed inhalation of liquid or vomiting, symptoms of gurgling, cough, and wheezing. And it can also occur without coughing or choking if you don't have a strong gag reflex. Examination is again variable, like you can hear rales or wheezing. Chest X-ray, again non-specific. You can see focal consolidation, you can see interstitial infiltrates, and usually the findings are more on the dependent lobes when you are suspecting some sort of food or large volume aspiration. Treatment, again antibiotics with risk factors or clinical suspicion of superinfection. And for aspiration of gastric contents, chest physiotherapy remains the mainstay of the therapy in such patients. Outcomes are usually good. Mortality is 5%, which is not like less. And no death if less than 3 lobes are affected. If more than 3 lobes of lungs are affected, then there is a high risk of mortality. Again, antibiotic choice, most aspiration pneumonias are thought to be mixed organisms, so you have to cover for aerobic and anaerobic bacteria. Clindamycin, timentim is superior to using ceftriaxone alone. Now, this is the third type of aspiration. So we looked at foreign body, we looked at large volume aspiration. Now, these are the patients we encounter mostly in our clinic, which is recurrent small volume aspiration. And the outcome likely depends on the host and the frequency. So again, these kids are likely to have some sort of predisposing conditions. Most of this low volume, or small volume aspiration is associated with reflux. Gastroesophageal reflux plays an important role in these kids. History, it could be silent. You can have history of coughing, gagging, wheezing, or gurgling sounds, but usually it was my pulmonary board question that if a 3-year-old or a 15-month-old is having recurrent noisy breathing or wet-sounding cough, the most common differential diagnosis included is aspiration. Examination, you observe the feeding. You feed the kid in your clinic, and you can see if the kid cough with, drinking liquids. Handling of secretions, palate, tongue, and oropharynx for any abnormalities over there. You need to check the gag reflex, whether it is weak or not. And if you have transient wheezing or crackling after feeding, again, it points to some sort of aspiration. Chest X-ray, again, non-specific, from finding localized infiltrates to diffuse infiltrates, to peribronchial coughing, hyperinflation, or normal. It could range from normal to the worst X-ray. Barium swallow is best for detecting large anatomic problems, esophageal motility, but it is insensitive for aspiration. So barium swallow and upper GI, this is what I explain to the patients. I do modified barium swallow in all the patients I suspect aspiration, but I tell them it is specific, it is not sensitive. So if you have an abnormal modified barium swallow, that means that stems the diagnosis of aspiration. But a negative modified barium swallow doesn't mean anything. It just tells you that you're not aspirating at that particular time. If you repeat the MBS 5 minutes later, it could be abnormal. So you need to explain that to the parents very clearly. That's good enough. So MBS, or modified barium swallow, is standard for evaluating swallowing mechanism. It's relatively sensitive. It's not very sensitive. It's specific, though. Again, salivogram is the same thing. It's a radioactive material, infused swallowing things or barium. You give it to the patient to swallow, and you track the saliva. And again, it is very specific. If the saliva is going into the wrong direction into your airways, or it's pulling up into your laryngeal area, it stems the diagnosis of aspiration. But if it is negative, it again doesn't mean anything. Bronchoscopy, it's not sensitive for aspiration. Sometimes you can find food fibers or lipid-laden macrophages that could be suggestive of aspiration, but it's not definitive for aspiration. GERD, gastroesophageal reflux disease, all children with aspiration from above should have a thorough GERD evaluation. And this was a study in 2012. And here you can see they evaluated kids who had GERD-like symptoms, and they did the feeding screen. Out of that, 28, passed the feeding evaluation, and 39 kids failed the feeding evaluation. And when they did modified barium swallow in kids who failed the feeding evaluation, they found 16 out of 17 had abnormal modified barium swallow. So even a feeding evaluation by a trained speech and swallow pathologist can lead to the diagnosis of aspiration. And this is the lateral view. I have kind of compared it to the diagram here, and here you can see in the arrows. So this is the lateral view of neck in a young child showing the anatomical landmarks, and the hatched area represents airfield structures. And you can see the lateral view of the neck. There is an abnormal filling of the vallecula, which is the short arrow. So this is the vallecula, and this is the short arrow, which shows the barium is going into the vallecula. And this shows the barium is going into the laryngeal area. So this is the laryngeal penetration of the barium, and it is obviously abnormal. Again, the treatment for recurrent small volume aspiration, it should be directed at the underlying problem. If the kid has GERD, you need to treat the GERD. Mild swallowing dysfunction, you can alter the feeding techniques like positioning of the bottle, using slow nipples, thickening of the feeds, and be aware of necrotizing enterocolitis from some thickeners like Simply Thick. So here also you get variety of thickeners, but be careful about the probability of neck. Maintain good oral hygiene, treatment of reflux, early use of antibiotics when you suspect an aspiration pneumonitis, and G-tube and Nissen fundoplication. High risk of pneumonia occurrence in severely neurologically devastated children. So they have as high as 40% risk of having recurrent pneumonias due to aspiration. And the only therapy to, only way to prevent their GERD is using a G-tube and plus minus Nissen fundoplication. Now, tracheostomy can worsen your aspiration because the secretions, it's an open invitation to the outside environment. There are laryngeal diversion surgeries which can help sometimes. What happens if it is a lipid aspiration or lipid pneumonia? Do you think we have time or we can stop here? It's not very common, hydrocarbon and lipid aspiration. Then we can give justice to other people who are waiting for presenting too.
I don't know, it's up to the audience, but I think it's important.
It is important? You want me to
5
go
more
through?
minutes maybe, and then questions?
Okay. So let's do lipid aspiration or lipoid pneumonia. Again, if it is endogenous, you can get chronic bronchial obstruction. This is very simple. You can imagine if there is lipid balls in your airways, it can cause bronchial obstruction, and it happens secondary to storage diseases. Exogenous, you can aspirate the mineral oil, aromatic oils, polyethylene glycol, and all those things. It provokes a particularly severe obstructive and inflammatory syndrome. Lipoid aspiration or lipid aspiration is much more severe compared to your food and liquids. So it provokes a significant inflammatory syndrome. Once in the alveoli, it causes chronic alveolar and interstitial inflammation. The other food and liquid aspiration can cause parenchymal inflammation. Here it causes both alveolar and interstitial inflammation. And the presentation may be variable. This could be asymptomatic. Kid can present with pneumonia. Kid can present with interstitial fibrosis. And to an extreme, it can also lead to cor pulmonale. Chest X-ray shows non-specific findings again. CT scan shows parenchymal lesions between 150 and 30, which indicates fat. That's the size of the fat globules. BAL, bronchoalveolar lavage, can show fat globules on the surface. And treatment is again supportive. BAL, you can do bronchoalveolar lavage and long-term steroids if there is interstitial fibrosis. You do not treat this lipid aspiration or lipoid aspiration with antibiotics. And complications includes repeated infections and aspergillus infection, particularly with cavitation. You get non-tuberculous mycobacterial infection because lipids enhance the growth of this organism and impede phagocytosis by the host macrophage. Very important, if there is a high risk factor for a kid, say, having a storage disease or history of aspirating mineral oil, you need to be aware of secondary infections with aspergillus and non-tuberculous mycobacterial infection. Again, it can very well cause pulmonary fibrosis. All the aspiration can cause pulmonary fibrosis as a complication. And sometimes when the parents are not very keen to put a G-tube or fundoplication, and this is very essential to explain to them what could be the short-term and long-term complication of recurrent aspiration. Oil red staining of bronchoalveolar fluid shows lipid-laden macrophages over here, the blue color, and this is the macroscopic appearance of a exogenous lipoid pneumonia, and you see microvesicles and vacuoles. Hydrocarbon aspiration, want to continue still?
I think we should stop here just to leave some time for questions.
Yes, so let's put some time for questions. We can do it in a better way next year.
Thank you so much, Dr. Rizwana.
Thank you.
I just have a comment that I saw a lipid aspiration with a child, baby aspirated on vitamin D.
Right.
Oil-based vitamin D, and it wasn't clear in the history, and he presented with respiratory symptoms, and basically after we investigated, and so I think just for the audience to be careful with these over-the-counter products that are oil-based. Any questions?
Yes, thank you, doctor, for that presentation. Following an episode of a choking episode with liquids, say, for example, or solids, the parents bring the child to us for immediate evaluation. We may not find anything at that point in time. How much time should we keep the child under observation or before something, give the time for something to happen?
Right. So it depends on the age of the child. Like, if somebody comes with a 3-year-old toddler and say that he had a choking episode while he was eating peanuts or any sort of cookies or something, where you expect there is a foreign body aspiration, even though the physical exam could be normal, chest X-ray at that point of time could be normal because it takes time for the obstruction and hyperinflation to happen. You need to observe the kid. If you find the kid is completely asymptomatic, they still, not for foreign body aspiration, but for, say, hydrocarbon aspiration, they at least recommend observing the patient for 4 hours in the emergency room, even if the patient is completely asymptomatic. Decubitus X-rays are very helpful in this case. And that has always worked for me. Like, your PA view, your lateral views may be normal, but if there is small obstruction, like, decubitus view can identify. And the other thing I've observed here is like patients, mothers, like, history needs to be paid attention to. So there was a mother who went to 2 different hospitals before ending up to our emergency room, where she told the doctor, I think my kid could have aspirated. I don't know, I haven't observed it. He could have aspirated, he had pneumonia, he had respiratory distress, he had some crackling sound at that time, was treated with antibiotics for 2 weeks, 2 different antibiotics. And then the kid ended up, like, so high index of suspicion. So if there is a history, if the patient comes, I would keep a high index of suspicion. And if it is like, a foreign body like peanut or something, and the age of the child falls under like, between 18 months to 3 years or 4 years of age, I would want an ENT to come and evaluate and possibly like, you don't have to take him to the OR right away, but it's better to, because that kid would present 2 weeks later with complicated pneumonia.
Thank you very much, Rizwana. I will share with you another interesting case from clinical experience. Right. 4-year-old child who's been diagnosed to have asthma, and she was on steroid inhalers, and she was on the highest dose of steroid inhalers. Right. This child, every 1 to 2 weeks, keep coming to ER with acute asthma attack, status asthmaticus, and ending up with IV hydrocortisons, IV salbutamol, even sometimes thiophlin. Response, goes home. A few weeks later, same scenario, keep happening. We were questioning if the mother is giving the medication. We went through all possibilities. Even we involved social services to go and look at this family to see what's going on, why this child keeps having these attacks of asthma. At the end, after thorough histories, investigations, doing a lot of things, this child was diagnosed to have silent aspiration syndrome. This child aspirates on food from time to time, and she presents with acute, sudden, wheezy, obstructive airway attack resembling asthma. This child does not have asthma. So, at the end of we did a lot of tests, and we confirmed the diagnosis of recurrent aspiration syndrome. And this child, at the end, needed gastrostomy to stop these attacks. So stopping the child from eating and putting in gastrostomy solved the whole issue, and this child stopped coming to ER complaining of these recurrent attacks. The message I'm trying to say, this is a severe case, it's not a common case, but aspiration sometimes can happen silently, and it needs a high index of suspicion. And the most difficult thing I find is doing the right test, video fluoroscopy, swallowing video fluoroscopy, where in the UAE, up to now, I cannot find, I don't know in the Al Jalil if they have it, a very skilled technician who I can depend to tell me yes or no, this child does not have aspiration syndrome.
But again, it is not sensitive, so that's the drawback of video fluoroscopy too. And then I explained to the parents, especially for neurologically abnormal kid, they can aspirate from above and below. So you can have a gastroesophageal reflux when you are lying down. That reflux content can come up, and you can aspirate that in your airways. And when you have excessive oral secretions because of autonomic dysfunction, if you're a cerebral palsy kid, for example, or if you have a viral infection, you have naturally increased upper airway secretions. Those secretions, if your swallowing is not safe, can go into your airways and you can present in a similar fashion. Yeah.
Yes, I mean, gastrostomy you can keep and challenge this child with food every few months and see does she aspirate or not. At some stage, neurologically, she will mature, she will correct this problem. So the only way to know is by retesting with this video fluoroscopy, although it's not very sensitive, but to give her a trial of food every now and then and see does this food causing aspiration or not. And because it took 3 years for this gastrostomy to be closed.
Similar case, 6-year-old, difficult to control asthma at Boston Children's. And this was like, kid was treated with everything, like, reflux treatment, and you cocktails as usual you receive, severe persistent asthma or poorly controlled asthma, and then aerodigestive evaluation was done, and the kid had a laryngeal cleft, 6-year-old. A small laryngeal cleft that you can aspirate, you can present with poorly controlled asthma. So it's kind of, the index of suspicion needs to be higher in such kids.
We have one more question.
Oh, sorry, okay.
No? Oh, I thought you...
No one? Was I too good or?
Well, I have a question. Is there a role for Survanta for post-large amount aspiration requiring
So post-ARDS, studies have been done to give an exogenous surfactant, but none has shown statistically significant clinical benefit. Steroids have been used to a varying degree, long and short-term steroids, but other than that, nothing works, and you end up with pulmonary fibrosis.
Okay. So if no questions, we will thank Dr.
Thank you so
Rizwana.
much. Thank you.
And we'll have a coffee break.
We have a coffee break, huh?
Yes. No, we don't? I was hoping for.
That was the wrong time to give me a talk before the coffee break.
Now we can start the session. The moderators will be Dr. Rizwana and Dr. Fadl. I will give the stage to introduce the speaker for them.
Dr. Vishwanath is going to present the next topic. He's a consultant and head of pediatric pulmonology at NMC Royal Hospital, Khalifa City in Abu Dhabi. He has been trained in pulmonology from UK and Canada, fellowship from University of British Columbia in Vancouver, Canada. He also completed his accredited sleep technology education program from American Academy of Sleep Medicine. He has over 19 years of work experience with some of the best hospitals in India, Canada, and United Kingdom. And he worked, prior to moving to UAE, he worked in UK as a consultant pediatric pulmonologist. He has a great passion for teaching and training, as we can see, and he has co-authored a book. Now I feel really bad. Your resume is pretty strong.
Thank you.
He's going to present today on is all cough and wheeze is asthma, different phenotypes, different management. I think it's a need of the time we have a discussion on this topic, and thank you so much for presenting it to us.
Thank you very much, Rizwan, for the nice introduction. And I would like to thank Dr. Basil for inviting me to be with you all today. We had a nice, interesting talk. So I actually wanted to make this as a more of a interactive session. So I have picked up a couple of cases from my practice, which I am going to present, and let's discuss on to see these cases, whether they are asthma or not asthma. So today's objective will be to see the common respiratory conditions and then the clinical approach and management of them. And in the end, let's go through the asthma phenotypes and the evaluation of the asthma phenotypes so far. So as a pediatric pulmonologist, I usually get the cases to be reviewed for either persistent cough or a wheeze not controlled, or having a persistent chest symptoms, and are the unusual chest X-ray shadows from the patients or the general pediatricians who looked after these patients. So to start with, I have I was asked to see a 12-year-old boy with a cough since 8 months. The cough was on and off continuously, not associated with any breathing difficulty. he had a dry hacking cough once or twice it was coming in bouts. For having a upper respiratory infection and the cough related with it or the fever, he never had any the fever. So this was the cough. Sorry, I don't think it is playing. Let me play this in here. Can you hear?
Is allergic also like this?
Allergic, he had once in a while sneezing, that's it.
Otherwise not?
Otherwise no.
So now in the morning when you took breakfast, you are fine?
I didn't know.
In the morning not taken? Why? Why not taken?
I only ate cereal.
Cereals. So in the morning you took? Okay. So while going school in the bus, you are fine?
I was fine till I reached school. It started.
Okay. In the yesterday night also you slept well? No coughing in the night also?
Only a little.
Sometime. When yesterday you was playing? Okay. Take it. Bye-bye.
So what do you think, does this child have asthma? Upper respiratory noise, okay. So he's been treated with all the medications with the asthma. So can I confirmatively tell mom, does this child have asthma or not? No, because the pressure is so much tension in the family and he's been treated with so many medications which we use for asthma. So what could be the differential diagnosis? Habit cough? It's mainly when he is awake in the morning. That is the typical history. And sorry, the video was not very clear. When he was talking, he was fine. So when you stop asking him anything, then he will start coughing. And he could get the cough on request. Psychological, habit, okay. And what do you think I should be doing? The parents are there with me. Now there is enough stress in the family, so I can't just tell this is psychological, go home. So they're not going to buy this story. So of these three, chest X-ray, is there any role? No, because they also already had a couple of chest X-rays, which was normal. Lung functions, okay. So blood test, allergy screen, probably we don't get the answer. Yes, it could be thought about, but I don't get any answer immediately. So I need to just, I'm in a situation where the parental anxiety has been suffering for the last 8 months or so. So I need to give some answers. So the easy one in our hand is the lung function test. So this was the lung function test. For people who are not very familiar, this is the inspiratory phase and the expiratory phase. This is pretty much normal lung function. And if you look at the FEV1, we expect at least 12% change to say it is a bronchodilator response to call it as asthma. So when the lung function is normal, can I clearly say this child doesn't have asthma? Sorry? Yes? So in a well-controlled child with asthma, you can have a normal lung function. So it is very difficult to say right off that the child is not asthmatic even with one normal lung function. So because they always put into so many terminologies into the parents' mind about the allergy, here it's more common. They come with allergy, either is it allergy or is it asthma. So it is very difficult. Yes, they had a normal lung function. So in the history, what are the 3 or 4 important things? What can make you to help or make a helpful diagnosis? Wheezing. So from the history, mom said he never was wheezy when I reproduced. Usually we get a practice of doing the noises ourselves, like was he getting this noise? No, he never got this noise. It's always the cough. Sorry? Immunization, he was vaccinated, completely immunized child. From the cough point of, timing of the cough. Yeah, there was no cough in the night. So yes, a couple of you suggested the habit cough or psychological cough. So the typical diagnostic clue for me in this one is the dry honking cough which he had and which was always dry. except for when I was having an upper respiratory infection, it was a wet cough. Otherwise, it's dry throughout. And he was the cough was reproducible on request. When I asked him to cough, he would cough with a bout of cough, and it used to completely disappear in the night, or whenever he was doing his favorite work, like watching video or playing. He never used to cough. So this helps us to make a diagnosis of a habitual cough. Yes, it is probably easy to diagnose, but it's very difficult to manage these cases. So how do you want to manage this child? So he's in front of me. What should I be telling the parents? Sorry? Stop the treatment. Psychotherapy. Okay. Anything else? So main thing is, yes, psychotherapy is the treatment. From the initial phase, when I usually see at least 8 to 10 of these patients every month. So what I have made is now, I have collected the parents, counseled them. I have each ethnic group, 1 or 2 moms who are very happy to talk to the parents about this type of cough. So whenever they come, depending on the ethnic, say if it is an Indian, where the Malayali speaking or Hindi speaking, I pick up the phone to that mother, ask for their help. I ask them to share their experience, and once we say this is the habitual cough, then I give the phone to them. So that part of psychotherapy, yes, we can ask for a psychologist, but we may not have access to the psychologist all the time. So it's more of a reassuring the parents is very essential, given from the history why I say it is a habitual cough. But before saying habitual cough, there are a number of comorbid conditions which are truly can affect or mimic like that. The asthma, rhinitis, GERD, and then this literature was showing about the anxiety and depression. Anything which is precipitating factors can also give rise to this type of cough. So we need to first evaluate and answer or identify these ones to treat, and then say it's a habitual or not habitual. So the management-wise, it is more of a tick phenomena, the habitual cough. There was a Cochrane review published in September 13, looking at almost 18 uncontrolled or the studies collaborated together, looking at almost 250 patients. Of that, most of the patients did not have any cough in the night. So that is the most common feature to say habitual cough. And they never had, the quality of cough was always dry or honking or a barking type of cough. And most of the treatment is the hypnosis or the cough resolving with just a suggestion therapy, or giving more of a confidence to the parents and ask them to try and counsel the parents and the child to look after their cough. So what is the easy way which you can teach them? This typically happens in the adolescent or around the adolescent age. So what could you give a solution to that child or the mom? From the clinic, yes, you have stopped all the medicines. You clearly tell there is no need for the asthma medication. Probably I would say use the Ventolin if we really have wheeze. I don't want to cause problems. If there is a wheeze, yes, at that time they can use. So what else? The counseling part is very essential. I usually, first we have to accept this child is having a really problem. If we say you are playing or putting it on, then we lost the plot. So we have to accept, yes, you are really suffering from the cough, but how to manage this cough? I usually ask them a question, who is strong? Is the cough or you? So they always don't like to defend, so they say, I'm strong enough than cough. Okay, that's good. So I tell parents that I would give you a magic medicine, but I have nothing else, just a warm glass of water. So that I have given your mom a magic medicine, she will put in the warm glass of water. You carry that glass with you all the time, the bottle. So whenever you feel like coughing, take a sip. It should sort out your cough in 3 to 4 days. We have to give you some timeline. And as a pretending, this was all taught from my professors in Canada. We had a good results with this technique. And then later, is just a back of threatening kind. I know it is not good to threaten children, but I always tell if it is still, I want to see them after a week or two. If the cough is still persisting, then we may need to look down, either the scope or a bit of operation to see what's actually happening with your cough. Believe me, 98% they won't have cough after 3 days. So it is very easy to diagnose, but counseling becomes a very difficult in these cases. So treatment is identify and then treat the underlying causes, and then because the physiology we have to understand, the coughing can irritate the airway, that can lead to the more coughing, and then we have to important to break the cycle. And we have to positive reinforcement by accepting, yes, you are having a problem, and this is how you can manage this by yourself. And identifying which situations which bring on this type of cough. And a referral to the child psychologist, of course, is the very important thing if we cannot manage that and if they come back again with the similar issues. Moving on to the next scenario, I was asked to see a 13-year-old girl who is having breathing difficulties on and off since for last 8 to 10 months. Before that, she was absolutely fine. Child is having difficulty in breathing, and she used to feel like that her throat is closing and she was not able to breathe properly, and there was no problem in breathing out. She was okay. These symptoms usually used to happen whenever she was running around or playing, or whenever she was very stressed or excited. And she used to, when I asked her what she was doing, she used to take a little bit of a rest and she used to feel a bit better. So she used to continue with her work or the play. So she never sought for any medical help for her symptoms so far, but because it's happening all the time, then parents were more worried. So she has been tried with many medications which we use for asthma, like the inhaled steroids or the nebulized ones, and they were not helping her. So otherwise she was fit and healthy. There was no other issues. So does this child have asthma? What makes you to think she hasn't got asthma? Okay. Yeah. Exactly. Next, what could be the differential diagnosis in this case? Sorry? Vocal cord dysfunction. Okay. Anything else? Anxiety. Okay. Panic attack. And what is the investigation we need to be thinking of? Okay. Let's from the history, there are a couple of things which go against asthma, as there was no wheeze, and they used to get better on their own without any medical help, and even the inhalers have not helped her. The differential diagnosis, as a couple of you suggested, maybe vocal cord dysfunction, anxiety-related breathing issues or panic attack type, and then the exercise-induced asthma is another group which we should not forget. So investigation-wise, how many of you think the lung function is good enough? Which one is the first choice of these three? Lung function. So it is the lung function now, or it is the exercise test? Exercise test? Okay. So our symptoms is pretty much related to exercise. So it is much wise to do an exercise test. So what do we do with the exercise test is you bring the child, do a lung function first, and then you make them run on the treadmill. We have protocols to follow, and then do the lung function again to look at the pre and post changes in the FEV1, at least 10% decline. So when we did the lung function test, there was no bronchodilator response for the first PFT, then the exercise test, which was completely normal. So does this child have asthma now? No. Probably the diagnosis is the vocal cord dysfunction. The main diagnostic clues we got are from the just going back to the history. That is very essential because she is giving a history of throat is closing. So there is more of upper respiratory issues than the lower airway issues. So then not able to fill the lungs, but she was breathing out easily. So history is very important, and there was no problem in breathing out, and the lung function was normal or exercise test. So what we do now? Sorry? Okay. So refer to ENT. What would the ENT do? Okay, they do the bronchoscope, and then it may be normal. So then what is we are come back to the same situation. Now we are the management wise. What do you want to do? Physiotherapy? Sorry? Calcium. Sorry, calcium for what? Okay. So calcium, but probably it is more to do with the laryngomalacia, which we used to use, but even now there is no evidence of using calcium for laryngomalacia as well. But yes, it can help with the maturation of the cartilage. You can try, but more in those cases. So physiotherapy, coming to physiotherapy, probably it is the speech and language or vocal therapy is more essential. So let's look at what was, this is the center where I did my fellowship from. We looked at the 52 retrospective study of like 52 children who presented in the 1 year with the possible exercise-induced symptoms. When we looked at them, only 1/4 of them did have a criteria to feel that probably exercise-induced asthma with positive test. And almost 1/4 of them did have a vocal cord dysfunction, and couple of the children did have the bronchoscopy while they are running on the treadmill, just to see what is the movement of the vocal cords, what they are doing. So it's instead of abduction, they adduct when they are breathing in. That brings on this all symptoms. And as rightly said, when the vocal cords are closing, they cannot breathe in. That puts them into the triggering of the panic attack situation. That increases the vagal nerve stimulation and all. Then again, all the adrenergic response and the cholinergic response that causes the more complexity of the pharyngeal spasm that causes all the symptoms. And the complaint was almost a habitual cough was also there. And then sometimes they never had any respiratory problems. They used to get these symptoms on and off. So why it happens? It's mainly looking at the laryngeal structure. It is highly innervated organ which does multiple function at the time. So it's like airway protection, swallowing, and phonation, which all happens at the same time. Especially children, when they are running around, they are shouting, running, or calling for help. And in that way, even the breeze can cause the stimulation of these nerves, and that can cause the dysfunction of the larynx, leading to these refractory symptoms with inappropriate laryngeal closure, leading to all these symptoms. So it is mainly because of the precipitating factors. Again, we need to look into, is there any aspiration or any aggravating comorbidity in these children to treat before we discard them as a vocal cord dysfunction. These comorbid or precipitating factors cause laryngeal sensitization, and whenever there is a trigger, they do get exaggerated response of laryngeal hyperresponsiveness, leading to these symptoms. So it's all go back in trying to identify the morbidity, comorbid condition, try to treat them, and educate the parents on how to manage these conditions. So treatment-wise, again, yes, positive reinforcement, accepting, yes, these symptoms do happen, and it is known that she is not putting it on. So it is mainly, we had to try and educate the patient to see. It typically happens in the adolescent age group, especially the girls, more common we see VCD because of the possible anxious nature. And when you go back and ask the parents, how is the child, how she copes with the stress? So most of almost more than 90% of the time, we get an answer which she is very anxious child. So that triggers of the symptoms. So we had to counsel her against the calming down, and then yes, you can ask the ENT people to look at. Sometimes we don't want to miss any vocal cord nodules, which causes or trigger this type of symptoms. Yes, we had to try and evaluate that and referral to the child psychologist.
Exercise-induced asthma. You call it exercise-induced bronchospasm.
Yeah.
Because these are not asthma actually. I may run and I get myself a severe bronchospasm. I'm not asthmatic. So they suggested don't use the term asthma. Use bronchospasm. And your article is also showing that your article was 2005. This is very recent.
No, these are two different, I think you are getting confused. The bronchospasm exercise-induced symptoms it's a different entity, and the vocal cord dysfunction is a different entity. Here, there is no bronchospasm at all. Yeah. No laryngomalacia. No, it's not laryngomalacia. These are the different things what we can try and think about. But if you go back to the history is more important. Why I always suggest taking the detailed history is very important, because it's a more of inspiratory phase issue rather than the expiratory. So exercise-induced asthma symptoms or bronchospasm, yes, it is a definite phenotype, which I will talk later. They do have symptoms of wheeziness, and they won't get better without the Ventolin. So any symptoms, yes, the medication is helping. So that goes in a different, it's a lower airway issues. There is an entity phenotype who definitely presents with bronchospasm, but this one is more of an upper respiratory issue. So these two scenarios makes us to think is that all wheeze or all the cough is asthma? So definitely not. So we need to think about, is there any other different phenotypes in the asthma, and is it really we need to treat everyone as a, unfortunately I'm sorry to say here I've seen in last 2 years the inhaled steroids or the nebulized steroids and the single air montelukast being used like chocolates. I'm sorry to say that, but it is true. It's been given for almost every child. In a school, there will be like 80% of the children are on this medication for either upper respiratory infection or it's mainly, I feel, is probably lack of time to educate or understand ourselves to differentiate this child really has a problem or not. And the most other part is that is from the clinician's side. From the parental side, it's mainly the drawback of doctor shopping. They never come back to the same doctor again. They just go to the next doctor. So they continue to this process. So we have to put that into a bit of phase to try and stop what is we need to treat. So coming back to the different phenotypes, yes, there is initial, the phenotypes were thought about, is it early onset asthma or an late onset, the symptom related history, exacerbation, and then the lung function when we started doing. So there are a number of parameters were used to arrive at to an TH2 inflammation or non-TH inflammation to even the genetic level. So this was the initial broad classifications to look at the phenotypes. And the initial phenotypes were categorized into relation to their characteristics, so and how they behave. So the early onset of allergic wheezers or the late eosinophilic wheezers. See here the exercise-induced symptoms. They do usually come with cysteine leukotriene. So when you use the cysteine leukotriene inhibitors, they do respond well. So they do have only exercise symptoms. The rest of the time they don't have any bronchoconstriction. Then the neutrophilic ones, which usually will have a possibility of what we say as a protracted bacterial bronchitis or cystic fibrosis group who has not been treated appropriately, they need antibiotics. So we need to look into the different phenotypes or the characters to look into. And the other one which is in the rise is the obesity related. It is more to do with the lung mechanics, and it is very important for us to advise about the weight loss, and they are the obese patients are the more fit patients for the sleep study to see whether they need the CPAP or the BiPAP for overnight support. So the different task forces aggregated together to create or put the asthma phenotypes into 9 phenotypes into 3 general category. The first category is the trigger-induced asthma. So there is a trigger for this asthma initiation that can be allergic, non-allergic patients, or the infection. This is what we most commonly see in the preschool wheeze. whenever there is viral infection, they do have a highly sensitized airways. They cause bronchospasm, leading to wheeze and exercise-induced symptoms, which later happens, which is a typical phenotype of exercise-induced asthma. And the clinical presentation, how they present in the which age group, the preschool asthma or the infant, is it episodic or is there a trigger with the wheezing with the multiple factors? These are the group who will definitely need the ICS, and even the GINA guideline, the 2018 recommendation is to start the early ICS low doses to manage these cases. And the third category is the inflammatory markers of asthma, which we usually do in a difficult to control asthma, BAL, to look at what is the eosinophils or neutrophilic count and treat them appropriately. So again, there is a number of the literature to look at the different categories of the phenotypes. So those are the main three categories, phenotypes which we use. And again, that brings us back to the basics of the wheeze or the cough can be due to many, many causes. So history is very, very essential for us as a clinicians in the clinic, and then that depending from the allergies to vocal cord dysfunction. So depending on what the history we get, we can evaluate the child accordingly. So I conclude by saying the asthma is a chronic condition. However, we need to identify comorbid conditions, and we need to have an awareness about the different phenotype of the asthma, and we need to ask for some help if we are struggling. Thank you.
Thank you so much. It was really wonderful, very helpful. Does anybody in the audience have questions? I have two comments.
Okay.
So one is on habitual cough, and that is, initially it was called psychogenic cough. Now they don't use the terminology, they use habitual cough, and it is a diagnosis of exclusion.
Yeah.
So even if we are pretty sure, like, I tend to, if it is a first-time patient, I would do a chest X-ray on a patient along with PFTs to rule out any anatomical malformations or pneumonia or pneumothorax or anything. And second thing is for vocal cord dysfunction, I think PFTs are helpful because blunting of inspiratory loop can point towards the diagnosis of vocal cord dysfunction or inspiratory issues.
Yeah. So that I don't know whether we have time for the workshop. If you are all interested, I can just run through that slide. Sophia, is it okay, 5 minutes? Then it's all yours. Sure? Just I'll show that one slide.
Yeah. There's a workshop. There's supposed to be a workshop. So I don't know if you are into it. Dr. Vishwant is ready to do it, or if you want, he can just talk to in 5 to 10 minutes about the clinical or the practical aspect of asthma and consider that as a workshop. Is that okay? You can do that, Dr.
Okay, just 5 minutes, Sophia. Thank you. No, it's to continue mainly the spirometry. Sorry, I'll come to that slide. So it's mainly the setting up the spirometry. The lab is very important for us to know about what it goes into. So we need to have a test initiation with the calibration every day to be done with the latitude and then the certain temperature. And the test duration we need to look into, and the end of test criteria. There is a definite ATS criteria which we look into when we are doing the lung function. As we discussed, this is the inspiratory phase and the inspiratory loop and the flow volume loop, this one, with the inspiratory and the expiratory. So we are mainly looking for the FEV1 changes from the pre-test to the post with the bronchodilator response. The main thing, ratio and the FEV1 is the one we look into. So this is the one, mainly these are the different flow volume loops which can help you in making the certain diagnosis. So this is the normal one. And see the early small airway obstruction, it's mainly, this is a typical asthmatic where there is a scoop in the expiratory phase. And it's a chronic patient who has, like mainly we see in some of the cystic fibrosis or any other bronchiolitis obliterans patients with previous infection. There will be a severe scoop in the, they will never get better even with the post bronchodilator response. They do respond to an only small amount. And if it is a fixed large airway obstruction, this is the inspiratory phase will be a scoop. And if it is a variable extrathoracic large airway obstruction, there is a scoop in the inspiratory phase. So that tells us there is an upper respiratory issue we are dealing with, and then it needs an upper airway evaluation with the ENT team. And then restrictive conditions, they both have a scoop in the whole FVC, the flow volume loop will be curved. Anything you want to add on, Rizwan?
I think that's good enough, yeah. Like, the other thing I would say is every hospital should invest in a good pediatric clinical psychologist, to be honest. I'm lucky to have one in my team for sleep disordered issues, for behavioral issues, habitual cough. It makes a lot of difference. Thank you.
So next, one more point I wanted to talk in the workshop is about the inhalers and nebulizers. So just a quick question. There is always a scenario we think about, is it a true or false when a child, say 2 children, a 3-year-old child who is sitting quietly on the parent's lap with the face mask and the aero chamber with the inhaler. The other child who is crying away, screaming, not settled on mom's lap with the nebulizer. So which one do you think is getting the medication into the lungs? Not for you, Sophia, you can't answer.
Inhalers.
Sorry, which one? Crying? Okay, so is the crying baby gets more medicine? No. Good. So that's it. I don't want to talk anything more. That's a very important point. If I say some, even yesterday I was in a DOH workshop, I was talking about this. Almost 30% were saying the crying baby is the one who gets the medication. So I just choose a couple of them and ask them to mimic crying. So crying is a expiratory, so you cannot get, yes, they get a gasp. That's the only time you can get the medicine into. And if you look at the typical pattern, the nebulizer is here. It is actually giving the medication to the environment or to the parents rather than the child. So it always needs to be with the face mask. So if you look at the main deposition, the child who is not crying, there is a lung deposition of the medication and a minimal oropharyngeal deposition. And if the child is crying, absolutely there is no lungs, you cannot see. It's a oropharynx or into the stomach. So you are getting more systemic effect and more Ventolin, more crying, more tachycardia. So the parents get panic, doctors get panic, then I don't know what to do. So that will be the situation. So looking at the best method is the inhaler with the face mask, or depending on the age, the mouthpiece. This is even the DOH guideline, and most of the guidelines, even DOH last year we concluded the guideline, we talked about the inhalers, and we do recommend the inhaler use even in the acute exacerbation phases with the face mask and the aero chamber. And here again it talks about the drug deposition. Even if you use with these instruments in an appropriate way, even with the MDA and spacer, the drug deposition is only around 60 to 70%. So it is very essential, whichever the device you are choosing, we have to train the parents on how to look after the device, plus how to give the medication. And if the child is old enough, I usually start talking to the child once they are like 7, 8 year old. I will straightly start asking them to show me in the clinic how they are using the medications or the device and how do they take the medicines. This is to show the relevant drug delivery, even with the nebulizer, if you think it is appropriately, only 23 to 26% they still can have an error in using the medications, even if you think the nebulizers is best, but still the MDI has pretty much the same relevant errors. So it is very essential, whichever the device, we have to train the parents. And the drug deposition, again, MDI and spacer has a high drug deposition and can be used even in the acute exacerbation of asthma. So whichever the device is one part, the second part is it is very essential for us to educate the parents about each medications what they are using. So sometimes I have seen they continue to use only the Ventolin, they stop the steroid inhalers or the nebulization. So it is very essential for us to make them understand which is the preventive medication and how long, what we need to do, and which one is to be continuously used and which one is a relieving medications. Thank you.
Hello. Now we come to the last talk of the day and of the conference. I would like to welcome Dr. Sofia. Okay, good. Sofia Konstantopoulos. I hope I pronounced the name correctly. She is currently a pediatric consultant pulmonologist at the Sheikh Khalifa Medical City in Abu Dhabi. She completed her primary medical training at the University of Athens. After that, she moved to USA. She did 3 years residency program in general pediatrics in New Jersey. Then she moved to the Philadelphia Children's Hospital to complete a fellowship in pediatric pulmonology. And then after that, she did 1 year fellowship in pediatric and adult sleep medicine. And before she came to UAE, she was working as a consultant pediatric pulmonologist at the Children's Hospital of Philadelphia, where she completed her fellowship program. Welcome, Dr. Sofia.
So just quickly through the objectives, I'd like to describe the current evidence in the use of biological-based therapies for the treatment of severe asthma, differentiate the biological therapies for severe asthma based on patients and treatment-related factors, and then apply updated guidance to optimally utilize biological-based therapy in patients with severe asthma. So we all know that asthma is a highly prevalent disease. It actually affects 1 in 10 adults in the US, and it affects 3.3 million children. And we know that 50% of all healthcare costs that go into asthma are going to be spent on those patients that are suboptimally controlled. So it's a highly prevalent disease with a high burden on the individuals and the society. I'm not going to dwell a lot on the pathophysiology of asthma, but as my colleague Dr. Vishnu covered beautifully the different phenotypes, but just to keep in mind that there's 2 types, like type 2 of inflammation and non-type 2 of inflammation. And it's important to differentiate the 2, as this is severe asthma, so a spectrum of disease with different phenotypes. And this helps us sort of pick our biomarkers as well as the biological and other therapies we use to treat severe asthma. So in the type 2 inflammation, just remember what you already know, which is the Th2, CD4 subtype cells, the eosinophils, atopy, allergy. And then in a non-type 2 inflammation, just remember that the center is the epithelial cell and how it responds to obnoxious stimuli and signals such as viruses, environmental triggers, toxins, bacterial and viral infections, and so forth. Just to make things even more interesting, there is a crosstalk between these pathways through the innate lymphoid cells. So what we call severe asthma, because it's really important to differentiate the uncontrolled asthma, that means the patients with poor control of their symptoms who have frequent exacerbations and require systemic corticosteroids, going to the emergency department, versus the people who truly have severe asthma. So ERS and ATS put in together a task force and then defined severe asthma as the asthma that requires high dose of inhaled corticosteroids plus a second controller and or systemic corticosteroids in order to control the symptoms, or patients who still have symptoms despite these therapies. In Gina's definition, it would be your patients in step 4 and step 5. So high dose of inhaled corticosteroids, long-acting beta agonists, add on a anticholinergic agent, or low doses of systemic corticosteroids who require these therapies to stay controlled, or who even need more because they have persistent symptoms. How would you tell the difference in your clinic and then know to refer these patients, the GINA 4 and 5, to pulmonary? Well, Dr. Vishnu has given also a great example of this. You would have to go back to the history of the patient, ask about adherence, technique, environmental exposures, and then treat other comorbidities that may be contributing to your patient's poorly controlled asthma. So if you have rhinosinusitis, very important in pediatrics, postnasal drip contributing to symptoms, gastroesophageal reflux disease is also a major comorbidity. Obstructive sleep apnea, like we've seen before, plays a role, and of course obesity, which is increasing. Smoking, buhur, exposure to obnoxious sort of odors, and pollution, environmental pollution, all contribute to poorly controlled symptoms. These patients do not necessarily qualify for severe asthma. Severe asthmatics are a different category. Severe asthma clinical features would be frequent and persistent asthma symptoms, frequent exacerbations, decrease in the lung function, which leads to chronic airway remodeling and substantial impairment in the quality of life, as well as emerging comorbidities, especially in older individuals, such as anxiety and depression. And this can be a two-way street with regards to the symptoms of asthma. Factors: genetic makeup, phenotypes of the patient, airway remodeling, if you start early and you have sort of fixed lower airway obstruction rather than reversible, the environment, of course, that you live in, and sort of all the factors depending on the patient, such as their comorbidities, quality of life, all play a role. What is the goal for treating severe asthmatics? Well, we, first of all, would like to reduce the exacerbations, the ED visits, all the morbidity and mortality related to severe asthma. And of course, we are interested in controlling their symptoms, in managing their comorbidities, in improving their lung function and preserving it, as well as improving their functional status and quality of life. There are still 3,000 adults in the US who die of severe asthma, so this would be something to consider and address, since it's a disease that in a way can be preventable. The pillars of the treatment for severe asthma would be, number one, make sure that the patient is on an optimal dose of an inhaled corticosteroid and a long-acting beta agonist. This is important. Make sure, as I said before, check the technique, check if they're really compliant to the medication, treat the other comorbidities, and you should be doing this in every single visit. The second one has to do with the oral corticosteroids. The take-home message here is, if you need the medication, you have to give it, but then make sure that you give the least amount possible and for the least duration of time in order to control the patient's symptoms. And make sure if you leave them on long-term systemic steroids that you monitor for the side effects, such as blood pressure, glucose, bone density, as well as eye complications like cataracts. Now, you could also have add-on therapies without phenotyping, so without telling which sort of phenotype of severe asthma the patient has. And these add-on therapies are like your tiotropium, for instance, your anticholinergic agents that you could add, in addition to other things such as, for instance, azithromycin. This has shown that it does decrease, when started early, the severity of an asthma exacerbation, and also it decreases the burden, as per recent studies, of the influenza in asthmatic patients, so that could be helpful. Other non-pharmacologic, down on the bottom, therapies would be the bronchial thermoplasty for adult patients primarily. And sure, we could do sputum-guided treatment in an ideal world. If you have an adult and they can expectorate, you can collect their sputum and see what they're made of, if it's neutrophils versus more eosinophils, and there's a good correlation between the sputum and the blood eosinophils. However, this is not always possible in clinic, and obviously you need a special center, plus it's not possible for younger kids. So then you're left with your add-on phenotyping for these specific patients, and by this we mean the new biologics. Okay. Just before I delve into the biologics, I'd just like to point the different biomarkers that we could use, and you could even order in clinic. So we have some of them you could order in clinic, I guess. IgE levels, IgE-specific levels. You could actually also use the CBC for the peripheral eosinophilia. And the last one, which is really important, would be your FeNO, your exhaled nitric oxide, which could be done in your pediatric pulmonary practice. The IgE level is important in picking up your patient who has this allergic phenotype. It does not tell you whether the patient will respond to the anti-GE therapy, but it does tell you who has allergic asthma, and it also helps you guide the dosage of the medication. The other important thing for the exhaled nitric oxide is that it's actually very useful, because we know that patients with higher FeNO numbers are going to be the ones who have more exacerbations frequently. And this is also another biomarker that we could use to see whether there's response to therapy. And this one responds to therapies that target the IL-13 as well as the IgE, but not the IL-5. Just keep this in mind. Okay, so for the novel therapeutic targets for severe asthma, I have here the Th2 cell in the center and its communication with the eosinophil. The eosinophil loves IL-5. Now we have the IL-13 for and also IL-4. So try and remember all these, because recently approved dupilumab is a target for IL-4 and IL-13, while the IL-5 is targeted with biologics such as mepolizumab, rislizumab, benralizumab, and we're going to talk about them specifically. Just as a group of altogether, the omalizumab, we know it's a monoclonal antibody, anti-IgE. We use it in children older than 6 years of age with moderate to severe persistent asthma who have a positive skin test or in vitro reactivity to perennial allergen, and their symptoms are inadequately controlled with the other therapies, the high dose of inhaled corticosteroids, LABA, and so forth. So the GINA 5. Then we have mepolizumab and rislizumab. These are also monoclonal antibodies which bind the IL-5, which is soluble in the serum. IL-5 is the happy place for the eosinophils. Older than 12 years of age, sub-Q, mepolizumab. Older than 19 years of age, IV for rislizumab, and this is based on the BMI of the patient. Benralizumab is different than the other two, even though it targets the IL-5. The way it does it is it binds into a specific receptor, and then I'm going to show you later in a cartoon how it works exactly. But just remember, IL-5 in the serum, the first two, and this one on the receptor. Okay, so how does anti-IgE work? We know that IgE in the blood is bound to the Fc's epsilon receptor, and this activates the mast cells, which then release their contents. So omalizumab used now for more than 15 years, and this is one of the first studies done in the US. And so you have here on the left-hand side, you see that there is the protocol-defined asthma exacerbation rate over 48 weeks. So the patients who received the medication versus placebo have a 25% reduced risk for an exacerbation. That was on top of their standard therapy, inhaled corticosteroid and long-acting beta agonist. And then on the right-hand side, you do see that these patients' mean asthma symptom score actually improved. The higher your score, the worse is your asthma control. So we'd like that to be decreased. Since then, there have been many studies in cohorts of patients across the world, and so in real time, we know that omalizumab helps when it's as an add-on treatment in the right specific patient population with improvement in the lung function, as there is increases in the pure FEV 1% predicted. As you could see on the left-hand side, from baseline after 16 weeks of treatment, FEV1 changed from more than 14% predicted. And then on the right-hand side, you do see a change in the asthma symptoms of patients before starting the medication, improving in 16 weeks and sustained within 6 months of therapy. And in the middle, you can see that there's also a reduction in the number of days that there is actual absence from school and work, so that's also very significant. So in summary, omalizumab improves quality of life for patients, improves asthma symptom control, improves lung function, reduces exacerbations, ED visits, need for systemic and inhaled corticosteroids, and remains safe for adults and children, overall well tolerated. Now, with regards to the two types of asthmas we talked about it, the eosinophilic asthma affects 40 to 60% of cases versus the non-eosinophilic. So the symptom severity is increased in this patient of eosinophilic asthma. And IL-5 is the one that regulates the proliferation, maturation, and migration and functions of the eosinophils. So the targets, IL-5 or the eosinophil IL-5 receptor. So we see that on one hand, we have the eosinophil, and the levels are raised in 40 to 60% of patients with allergic asthma. They release toxins that promote inflammation, and on the other side, we do see that IL-5 is the principal regulatory cytokine for the eosinophils. It's involved in the maturation, differentiation, survival, and activation of eosinophils. So mepolizumab and rosalizumab target IL-5, and without IL-5, there's no eosinophils, while benralizumab binds to the receptor, rather, IL-5RA. So what do we know about mepolizumab? Technically, this is the first study done with the monoclonal antibody in humans back in 2000. They gave mepolizumab, and then in two different doses, as you could see in purple, and then in the light blue in the bottom. And they compared this to placebo, which is the orange on the top. The patient's blood eosinophil count is on the left-hand side, so you measure the levels initially, and then you do allergen challenges. As expected in the placebo group, with any patient, you give them an allergen, they're going to have a peak in their eosinophilic count. But the patients who received the two different doses of mepolizumab, as you could see, there's a decline in their numbers, and there's also that these peaks are lost as you are on the medication. So you lose your delayed phase in asthma response, which controls their symptoms better. However, this was a negative study with regards to their primary outcomes, which was a number of exacerbations. And this was due to the fact that they took all comers. They did not only include the severe asthmatics. So they were, in a way, not targeting absolutely the right number population of patients. Now, this one, for mepolizumab, another study that showed that technically familiar with the Kaplan-Meier analysis, you want to show the proportion of patients without an asthma exacerbation during the study. As you can see, the patients without an exacerbation remain higher with mepolizumab versus the patients who were randomized to receive placebo. There was a sustained benefit for 8 weeks, and there were no serious adverse events. So mepolizumab, severely controlled asthmatics, significant reduction in exacerbations if they were in the allergic phenotype. Now, how this one is the DREAM study. It shows again the same thing, that mepolizumab reached helped patients sort of have less clinically significant asthma exacerbations from the start of the treatment till the end of the study versus placebo. And you could see that there was actually no difference between the 3 different doses that were tried. This is the last one study that shows basically, again, that the cumulative number of exacerbations when using placebo was higher versus when using mepolizumab either as IV or sub-Q, and these two did not differ between the two modes of delivery, IV versus sub-Q, and that there was also a greater reduction in the median dose of systemic steroids used from the start to the end of the study. So the glucocorticoid steroid dose decreased by nearly 50% when they remained on the medication. And there was an improvement in the lung function of the patient seen on the bottom left compared to placebo. So we could use it sub-Q. It's on a monthly basis. And it doesn't have to be given IV because there's the same clinical efficacy between the two modes, IV and sub-Q, as seen on the upper top slide. Graph. Okay, now reslizumab. So in this case, we had 106 patients who were randomized to receive this at 0, 4, 8, and 12 weeks versus placebo. And again, you do see a reduction in the sputum eosinophil count compared to placebo. There was a reduction in the number of exacerbations. There was an improvement in the lung function, and the benefit of this was more in patients who were known to have nasal polyps. So for patients with nasal polyps, reslizumab greater than 18 years of age, allergic asthma, you may want to try this medication on top of the other treatments, inhaled corticosteroid, long-acting beta agonist, and other controllers. Which patients benefit more? They actually did this study, and it did show that you can measure the absolute eosinophil count, and the patients who benefited more in terms of change in their FEV1 from baseline, as well as their asthma scores, so better control of the symptoms, were the patients who had a eosinophil count of greater than 400. So below 300, you're sort of not sure if it's going to help them or not, but if you have 400 or greater and the patient fits the rest of the criteria, this medication should help. Finally, this is another study showing again the same thing, that there's improvement in the lung function, which you see on the right-hand side. The placebo is the orange, and then you see the medication with the red line, as well as in the Kaplan-Meier again with a increased number of patients having exacerbations in the orange versus the red, which is the patients who had received the medication. Okay, so now how does benralizumab work? So it binds with this receptor, and then this changes the long chain of the immunoglobulin. And so that brings in the natural killer cells, which then through perforins and granzymes and to the implosion of the eosinophils. So it's an antibody-directed, cell-mediated cytotoxicity. And the eosinophil with this medication sort of undergoes the programmed cell death. It dies out. So what did the study show from benralizumab? So if it was administered 30 milligrams every 4 weeks or every 8 weeks compared to placebo, so this would be the purple line placebo, and the treatment arms are in orange and in light blue in the bottom, you did see an improvement in the sense that there was a longer time to first exacerbation. And so in this study, they actually did the following. They took the patients with severe asthma who were poorly controlled. They had a long run-in period. They gave them systemic steroids at baseline, and then they tapered them down. So you see they go from 0, and they drop down where it says the median change from baseline. That's dose of corticosteroids from baseline. They reduced it by 50%. And then they randomized the patients to either placebo in the purple line up top, or benralizumab 30 milligrams every 4 weeks or every 8 weeks in the bottom. So as you could see, the patients who are on the treatment had a 75% reduction in the median dose of steroids compared to the one before starting the therapy, while the patients who were on placebo eventually had some increase, and their reduction from baseline was only 25%. So the take-home message is once the medication was started, the patients were able to decrease their glucocorticosteroids dose more versus placebo, and that's a good thing. Moving along to the last of the biologics I'd like to discuss, which was recently approved for patients older than 12 years of age, is dupilumab, and this one is actually a monoclonal antibody which targets IL-4 receptor of the IL-4 and IL-13 receptors. So it helps with regards to decreasing IgE production, Th2 differentiation and survival, airway inflammation, airway remodeling, as well as mucus production. So the study on the graph on the right-hand side, you could see that in 1,900 patients older than 12 years of age with uncontrolled moderate to severe asthma, they gave 2 separate doses of dupilumab, either 200 milligrams every 2 weeks or 300 milligrams every 2 weeks, and they had 2 actual placebos because there were 2 doses of the medication. So in comparison, you could see that the patients who received the medication had a within 2-week increase in their lung function. You can see it up top on the orange and then also the light blue compared to placebo. And this effect was sustained throughout the 12 months of the study. So dupilumab sub-Q, 300 milligrams every 2 weeks in steroid-dependent, moderate, severe, uncontrolled asthma. You could see that it led to a decrease in steroid use as a percentage of 70%, which was statistically significant versus 41% in orange on the first graph on the left. And also, this meant that there was a steroid reduction as a percent of subjects on the right graph. So 80% of the patients were able to have their dose reduced by 50% or greater when they were on dupilumab versus placebo. 70% of patients actually were able to drop their steroid dose to less than 5 milligrams per day. And actually, there were 48% of patients, so nearly 50% of patients who came completely off of systemic steroids when they started on this medication. There are, however, certain limitations on the major trials for these biologics, even though they're very helpful for the right patients. There are small sample sizes for a lot of studies, so we need additional studies with larger group of patients to confirm the findings. There's limited data on the durability of the response. We have to determine more effective biomarkers in order to be able to effectively select the patients who are going to benefit from these biologics. And also there's somewhat limited data with regards to which biologic to use first, as well as what would happen if we were to combine 2 biologics together. Last one, I wanted to just show this one, which comes from the CHESS Foundation, which is a CME-supported activity from the Annenberg Center of Education that I used to adapt for this talk. And with the Allergy and Asthma Network and other entities, they have been giving this to the patients. I'm not sure if you could see it clearly, but it's more of a questionnaire with regards to asking the patients about their symptoms and sort of pulling them through and making the right decision by informing them on the benefits and risks of the treatments and asking them their preference. So thank you so much. Any questions?
Thank you very much.
Okay, I hope this was not too long.
For this elegant, very clear and easy follow presentation. Any question? Yeah.
Yeah, please.
Thank you for your presentation.
Thank you.
I think the key message to get across is what's severe, and in fact, I think the definition about this step 4, step 5, because I mean, we did a study in the UK looking at people that died from asthma, and over half of them, by that definition, had moderate asthma. But the asthma killed them. So we can't say they've got moderate asthma. In fact, I think what's more important with the is an exacerbate how often they're having attacks, how often they're handling. You know, there's so much really
Yes.
involved in asthma. It's our duty as a doctor who see asthma
Yeah.
to actually be conscious of the fact that somebody in the risk of dying, and we need to take it seriously, and we need to be checking their technique, checking their compliance, all those things which I think we're not doing.
Yeah, thank you so much for this. You're actually bringing up an excellent point, the fact that severe asthma really affects a smaller portion of patients versus what would be the uncontrolled asthma. So making that distinction is very important. So thank you.
There was actually audit in north of UK, and they found that the cases of death actually more involved children with mild asthma, but they, for some reason, they had a severe acute attack asthma, and then, because they were not prepared that this is severe asthma.
So it doesn't mean because you have severe asthma you're going to die, but obviously it means also that any patient with a mild asthma attack can eventually die. But this was not the purpose of the talk. It was more to focus on what biologic therapies, other things you could give. It was not to answer the question about the asthma exacerbations, how to manage them and who's at risk, but more to talk about who qualifies for this severe persistent, and can we phenotype them, can we put them on biologics, can we spare them from steroids systemically, rather than how you sort of avoid the exacerbations in the patients who are uncontrolled.
Dr.
Yes,
Basil?
I'd like to thank you first for traveling from Abu Dhabi just to give this talk and go back. That's a lot of devotion. Thank you. It's a very nice scientific talk. If we come to practical points here, other than Xolair, in your practice in Abu Dhabi, have you used any of these biological medications?
No, because I think the short version of this is that I didn't have patients who specifically qualified for anything else, but I think the more perhaps we get patients referred to us and the more we learn about this and understand the different phenotypes, the biomarkers, the more we understand how these medications work, the more likely we're going to be to use them. Because I think our allergy colleagues, they do use them a lot in adults particularly.
Xolair, do you have a lot of patients on Xolair?
Yeah, we have a handful.
Thank you.
I don't know if anyone else has other experience in the audience using biologics more, would like to share, comment?
I've never used them other than Xolair, really, because I think they are new medications and they are used in very severe cases of asthma. They are very expensive. We don't have much of experience on how to use them yet, but I'm sure they are coming at some stage to be used.
Great. Thank you. Thank you so much.
Any other question? Thank you very much.
Okay, thank you. Thank you so much. Thank you. Thank you.
Just to say that the fact so many of you are still here by the stage, it's a testimony for the quality of the speaker, quality of the talks we had. And that we'd like to thank Dr. Basil for this excellent, and congratulate him and his team for this excellent.
Thank you, Dr. Fadel. First, I'd like to thank all of you who stayed till the last minute. This needs a lot of devotion, and that means you are really loving to learn because all of us are tired. So thank you for staying. I hope this conference was interesting enough to you. It has a lot of topics, a lot of scientific material. Some of the lectures were basic, some of the lectures were more deep and advanced. So we tried to cover as much topics as we can and try to talk to different peoples at different levels. So hopefully next year we will continue to do this conference, and hopefully next year we'll expand more, get more speakers and get more audience to attend. The aim is to increase awareness of allergy, bring to you the latest updates, evidence-based management of allergies and asthma and eczema. So I hope you enjoy it, and thank you for staying. Thank you very much.